Pradeepa? Huh? Eric? மத்தியம் டாக் இல்லைன்னு நினைக்கிறேன் எனக்கு அதுக்கு நான் பார்த்துறேன் இப்போ இது முடிச்சிடறேன் ஃபர்ஸ்ட் அதாவது உன்னிகிருஷ்ணன் ஆஃப்டர் ப்ரோக்ராம்
Sir, can you listen to us?
Yes. Pradeepa, you're there.
Appadru sir. Yes, sir. Pradeepa.
Yeah.
Illa, she's coming.
Okay. Slides அவங்க தான் இன்னைக்கு பிரசன்ட்.
Okay, sir.
எந்த ராதாதும் சேர்த்து கேட்கறதுக்கு.
Okay, sir.
We have your slides, sir.
Okay. So mine and Radha's together.
Yes, sir, we will present.
Yeah.
5:30 5:30.
ஒரு தடவை வேணா அது போட்டு பார்த்துடலாம்.
Okay, sir. Now we will try, sir.
Just now, yeah.
Okay.
8:30, 7:80. Wait up.
Perfect.
Thank you.
Sir, Dr. A.G. Unikrishnan is joined.
Oh, yeah. Hello, Uni.
Hello, sir.
There
Thank you.
There you are. Hi.
Thank you, sir, for the.
I like your glasses, like Harry Potter's glass.
Thank you, sir.
Very nice. All set. You have downloaded your slides, and so that's okay.
Yes, sir. I've sent my slides, but I've also, I have my slides here. Should I just share it and show?
You just share it and see, and then you can switch it off.
Hello, Dr. Anjana.
Welcome, sir. Welcome, sir.
Slides are visible, no?
It's coming. It's coming. Perfect.
Yeah.
Minimize it and keep it here.
Yeah.
You're right. He does look like Harry Potter, doesn't he?
Yeah. It's still the glasses, no?
It's the glasses, yeah.
And the webcam.
Sir, you just need one thing, sir, that Z mark. That's all.
Oh, I hope I don't have it. That's what Voldemort has given, no?
No, we'll not get to sit here. Suddenly you'll do like that and boom, we'll all go.
Sir, do you want to see the slide, sir?
He just now saw.
Oh, you're mine.
Oh, yes, sir.
Can you quickly go through it?
All the best and congrats.
Thank you.
Just go through it. Yeah. Keep going. Yeah. Okay. Okay. And then I'll stop there, and then Radha will take over. Okay.
Here, sir.
I'll stop there, and then Radha will take over from there. Okay.
Okay, sir.
Go through it. Radha's slides. Let me see. She's got about 15 slides or something. We've got some exciting new data to present, Oni. Precision diabetes going to the next level. This very new data, unpublished. Good. Okay. Wonderful. So you have to present, Pradeepa. Okay.
Yes, sir.
You have to show. Okay.
Yes, sir.
We have 11 minutes more still.
Oh, good.
Welcome, Dr. Unikrishnan.
I can finish my tea by that time.
Please do, please do. Mine is at 4 o'clock, no?
Yeah, 4.
Yes, sir. Yes,
Start
sir.
sharp.
Sharp 4, sir.
Keep it off.
I'm here only.
Yeah,
I may stay
Okay.
yeah, sure.
muted, but I'm here only.
Thank you. Ready, Pradeepa?
Yes, sir. 1 minute to go.
Yes. Exactly at 4.
Hello, Dr. Ranjit.
Congratulations, Suni. Ranjit will
Thank
be
you, sir.
reading
Thank you.
Ranjit will be reading your citation. So
Thank you, sir.
the two Unnikrishnans.
Yes, yes.
Confused. People get confused between them.
Often get mistaken for each other. Messages meant for him go to me. We go to him.
And vice versa.
Good evening and welcome you all to the evening session of the second day of the 8th Dr. Mohan's International Diabetes Update. We have planned a wonderful and exciting sessions for you this evening. To begin with, we will now go to the Dr. Mohan's International Diabetes Update Gold Medal Oration Award to be conferred on Dr. A.G. Unnikrishnan, who will be speaking about involving patients and communities in diabetes care, insights from real world. Before we invite the orator, I request Dr. Ranjit Unnikrishnan, Vice Chairman, Dr. Mohan's Group of Institutions, to kindly read a citation and introduce the recipient of this award. Over to you, Dr. Ranjit Unnikrishnan.
Thank you, Pradeepa. It gives me great pleasure to read the citation of my good friend and colleague, Dr. A.G. Unnikrishnan. The Scientific Council of Dr. Mohan's Diabetes Education Academy, the education wing of Dr. Mohan's Diabetes Specialty Center, Chennai, has great pleasure in conferring the 6th Dr. Mohan's International Diabetes Update DMIDU Gold Medal Oration Award on Dr. A.G. Unnikrishnan, CEO and endocrinologist and Head of Patient Care Research and Education, Chellaram Diabetes Institute, Pune. The earlier recipients of this award were Dr. Srikumaran Nair, Professor, Department of Medicine, Endocrine Research Unit, Mayo Clinic and Foundation, Rochester, Minnesota. Dr. Nikhil Tandon, Professor and Head, Department of Endocrinology and Metabolism, All India Institute of Medical Sciences, and Head, Capacity Building, Center for Chronic Disease Control, New Delhi. Dr. Sundar Mudaliar, Clinical Professor, Department of Medicine, University of California, San Diego. Dr. Michael Pratt, Professor, Department of Family Medicine and Public Health, University of California, San Diego, USA. And Dr. Alka Kanaya, Professor, Department of Medicine, Epidemiology and Biostatistics, University of California, San Francisco, USA. Dr. A.G. Unnikrishnan completed his MBBS in 1994 from the Calicut Medical College, MD in Internal Medicine in 1998 from Christian Medical College, Vellore, DM in Endocrinology from Institute of Medical Sciences, Banaras Hindu University, and DNB in Endocrinology from the National Board, New Delhi, both in the year 2003. He has over 18 years of teaching experience for undergraduate, postgraduate, DNB, and DM courses. He has served as lecturer in Department of Endocrinology, Christian Medical College, Vellore, and Professor of Endocrinology at the Amrita Institute of Medical Sciences, Kochi. Dr. Unnikrishnan's research interests include diabetes management, gestational diabetes management, diabetes in children, and goiter treatment. His research has led to over 190 publications. In addition to these publications, he has co-authored the largest multi-center study of subjects with pancreatitis and pancreatic diabetes worldwide. He has also served as the editor-in-chief of the Journal of Thyroid Research and Practice and executive editor of the Indian Journal of Endocrinology and Metabolism. Dr. Unnikrishnan serves as principal investigator for several national and international clinical research studies. He has been conferred with several awards and honors, including the Jacob Memorial Prize by the Christian Medical College, Vellore, the Subhash Mukherjee Oration Award by the Endocrine Society of India, Srivastava Award by the RSSDI, Dr. Sam G.P. Moses Oration Award by the Diabetes Association of India, the Diabetes Excellence Award at the Digital Diabetes Summit, the C. Munichudappa Oration Award by the RSSDI Karnataka chapter, and the Madhu Kumbh Oration at the Annual Diabetes Association meeting at Nashik. Dr. Unnikrishnan also oversees a philanthropic rural diabetes care program at his institute, which has so far given care to over 1 lakh people. The scientific committee of the Dr. Mohan's Diabetes Education Academy, Chennai, India, has great pleasure in conferring the 6th DMIDU Gold Medal Oration Award on Dr. A.G. Unnikrishnan for his remarkable contributions in the field of endocrinology. May I now request the award to be presented to Dr. A.G. Unnikrishnan.
Congratulations, sir.
Well
Thank you.
deserved. It's an honor to have you with us. The floor is all yours now.
Thank you. I hope I'm audible and my slides are visible.
Yes.
Yes, yes.
So first of all, let me thank Dr. Mohan himself, and of course, Dr. Anjana and Dr. Ranjit Unnikrishnan, Dr. Guha. It's an honor to receive this award because it's an honor to receive it from Dr. Mohan. We've all, for years and decades, admired Dr. Mohan. In fact, I remember during my MD once when I listened to Dr. Mohan, I was amazed at the wonderful work he was doing and was then proud to have been associated with him over several years. And finally, to receive an oration, a gold medal oration at Dr. Mohan's International Diabetes Update, also after all this very distinguished people who've received it before, is truly an honor. It's touching and I'm moved. And I thank you all from the bottom of my heart for this opportunity bestowed on me. So let me begin by actually thanking Dr. Mohan for the award, because he's a living legend in the field of diabetology. And it's indeed, words cannot describe my feeling right now. Let me also start by saying that this is my short agenda for today. Diabetes management in India, there are challenges. Our experience in the community, particularly in involving the community and patients in their own care, and how we try to design a new way forward. A lot of this work is done in the pre-pandemic era, and after the pandemic, of course, our thoughts have changed, and the direction we've given to the outreach program has made a definite change. But a lot of work has been done in the pre-pandemic era. And this is a slide to show regional disparities in the prevalence of diabetes in urban India. And you will see that the disparities are there wherever, whichever part of India you look at. But largely, the prevalence of diabetes is very high. If you look at the status of diabetes care in India, this is a paper first authored by Dr. V. Mohan sir himself. And it shows that the diabetes, the HbA1c is 8.9%, suggesting that we can do more. And this paper also suggested that about 40% from patients have neuropathy, 6% nephropathy, 20% retinopathy, and 7% cardiovascular disease. So this is how we decided to work on our outreach program. And the rural part of India is remote and people cannot reach there easily. Health systems are not available. People have to go long distances if they would like to actually get medicines or they'd like to get treated. For example, this is a picture of this gentleman from our rural diabetes care program, and I'd like you to see his feet. So he has actually, when he came first to the clinic, he has bound his feet in a plastic cover and tied it with a rope, which looks like something like a lace. And the other leg is also at risk. You can see a bandage at the other leg, and you can see that toes are destroyed and have almost been amputated, auto-amputated or amputated surgically. So this is the status. And we say that offloading of the toes is very important in diabetic foot. But here is a gentleman who actually needs to, at this age, probably earn his daily bread, and he cannot offload his feet because there are other considerations in his mind, and therefore diabetes management is complex. This is inside our mobile diabetes clinic, which I will show later. This is Dr. Prasanna Dhore. He is a manager at our administration and heading our outreach program. And this is the outreach clinic. And what we do in very simple manner, we have a biothiometer, we have a Doppler, handheld Doppler, we have a retinal camera. And what we do is that we station this mobile clinic in the main village. And in the morning, people go to the small village and come back to the main village. And the next day also, they do that. And when one hub and all the spokes are over, then the whole unit migrates to the next hub. So this is the hub and spoke model, which we thought was very useful in treating diabetes, because around 50% of rural diabetes is actually undiagnosed. So we had a challenge. Instead of going to the entire population and screening them for diabetes, why not look at the entire population, but pre-select people at high risk of diabetes and then call them to the mobile clinic. So there are several questionnaires, and in some of our projects, we've used a simple questionnaire which looks at, symptoms of the eye, excess thirst, excess urination, etc. And in some of the projects, in the newer projects, we've used the Dr. V. Mohan's diabetes risk score, which also we found to be very useful. So when you are screening the population, what you can do, instead of screening everybody, it's because not every finances are always a problem, and the logistics of screening huge population is always a problem. So instead of screening the whole population, we thought we would send field workers house to every house, call the people who are at high risk, and then bring them to the mobile diabetes clinic for screening. Of course, that by itself is a logistical exercise, as I will show you. But even then, if you do that, at least you are able to pick up more cases of diabetes and reduce the screen failure rate. I want to speak a little bit about the diabetes risk in women. As you know, during puberty, women, female, adolescents and children, during puberty, they are at risk of polycystic ovarian disease because they have insulin resistance. And during adulthood, because they have estrogen, they are relatively protected from cardiovascular disease, but they do get gestational diabetes. They are at risk of postpartum weight gain. And of course, they are at risk of preeclampsia and hypertension. The third time when they are susceptible is menopause, when they do not have estrogen and their cardiovascular risk goes up again, equivalent to that of men. And of course, by menopause, the diabetes duration has been significant and they put themselves at risk again. And of course, by old age, again, there are the problems of old age like osteoporosis. So we did this study published it recently about obesity and its link to undiagnosed diabetes and hypertension in rural parts of Western India. We found that 30% of women and of course 35% of men had a high waist circumference. These are some glimpses of our outreach program. And we have what we do is that we have a small TV screen with educational programs for diabetes for people to watch. We list out the symptoms of diabetes on the screen, on the wall of the mobile clinic. We have a medical officer, a driver, a couple of nurses who rent out an apartment and stay in the vicinity of the remote village. And I have immensely enjoyed going to the village because it's a completely different feel from urban Pune. And the food, the air, the beauty, the natural beauty of the place all make it really a wonderful experience. But I just want to show a little bit how we men always seem to have, always seem to take advantage of a situation. You'll see in this queue, all the men are standing and all the women are just waiting. So this is also a problem, and it's not just in rural areas, even in urban areas, and all of us as well are to some extent, there are studies which show that women do not get guideline directed therapy as much as men. Women, when they have a cardiovascular event, they do not get the time they take to reach hospital and the treatment they receive. Often they do not get the therapy that they really receive. So this is something which we also saw in the rural area, and we decided to address it with women. We decided to address it with ASHA workers or accredited social health activists who are actually women who empower people in the community and show us that we can actually do better. This is another case, a little girl from our rural diabetes program. So what she told us is that, she is in a remote place, so does not have access to insulin. Not every day she gets insulin. Her father has to really work hard to make enough money to get the insulin. And while the days she's waiting for insulin, she feels tired, she feels weak, she feels weight loss, and she even gets abdominal pain. And on the day her father comes and gives her insulin, it's like a present or something you get on your birthday or something like that. It's a gift, because once she takes that insulin, she feels so much better. And we are on 100 years of insulin, and we have parts of the country where people really do not have access to insulin. And this is one of our doctors, Dr. Vedavati Purandare, who's our senior consultant diabetologist, and she took care of this little girl. And I don't even want to imagine that during the days when she did not get insulin and she was having abdominal pain, was it that she was having some sort of a subclinical ketoacidosis causing pain? It's possible. And her needles, the needles that she used were also so old, and she would use the needles virtually for a month or so. So these are all opportunities. And many times when I go to the rural outreach program and people start praising us or start, blessing us, and they start giving us, mementos in the outreach program, the sarpanchas and the village heads, what I tell them is, we are not doing anybody a favor by helping people in the village. We are doing it because this is what we should be doing. We as doctors, diabetologists, endocrinologists, this is not something which we are doing as a help to somebody else. This is our duty, because this is why we became doctors, and this is why we took on this profession. This is why we treat people with diabetes, so that we can help. So it's not that we are helping anybody out. It is our duty to go ahead and take care of not just people in the cities, also people in the urban places without access to healthcare. And that was the thinking of our chairman, Mr. Lal Chalaram, and that is how we decided to embark on this program. So this is a brief about diabetes management in India. I showed you the larger picture of obesity, diabetes. Now I also showed you the individual cases which show you that there is a felt need. Let me now talk briefly about our experience in the community. So again, what we decided is that given the disparities in regional health and given the gender disparities, we thought that we must empower the female health worker, the accredited social health worker called ASHA worker. And we decided to recruit the ASHA worker in the village to go to all the houses. So this is the spoke where one ASHA worker covers a village or a couple of villages. This is, you can see the spoke here, and inside is the ASHA worker. And this is a hub, the large village where our mobile diabetes clinic is stationed. And what you will see is that on the day the mobile diabetes clinic visits the spoke, that day the ASHA worker will bring the patient to the mobile clinic for screening. The next day the hub will, from the hub, the mobile clinic will go to another spoke, so on. And therefore, the mobile clinic using a hub and spoke model is able to cater to a wide variety of places rather than stationing at one place. At one place, there may be a sub-center or a PHC, but not everywhere it will be there. Another thing what we thought about is that we will not work outside the government model. We will work with the government, strengthening the rural health system. And therefore, once we strengthen them with training, those wheels will start rotating by itself and take care of itself. So we believe that we should work with the government when we take care of health. So what we did find is that of a huge population we screened, we found that we called about 17,000 people at that time, and that we are talking about in 2016. And we found that out of the 17,000 we brought after a high-risk screening program, 3,490 had diabetes, which means that the pickup rate for diabetes was about 20%, which means it is better to actually call high-risk people for screening. This is a picture, of course, the mobile clinic. You can see the registration room, the examination room, the investigation room. And this is the model which we've shared with many people about our model. There's a small refrigerator to keep equipment. There's an examination bed where we do the ankle brachial Doppler and also the handheld Doppler and the biotissue meter. We have a small lab where they do the glucometer. We do also the ECGs. We have a small place for patients to sit inside. We have a fundus camera here and the medical officer who does both the fundus assessment as well as gives a final prescription. And this is a registration room. So this is how it looks like. This is a registration. This is the examination, blood collection. This is the blood test being done. This is the fundus camera. This is a prescription. And there's a small mirror which uses the Snellen's chart to do it. So this is a compact, small area, very small clinic. We actually at the, just before the pandemic started, we had 3 such mobile diabetes clinics operating. And this is a white paper from the ICMR, national white paper they brought on the management and care of diabetes in India. And they actually mentioned us and our outreach program in starting these mobile clinics. So the other problem is rural obesity, which is another problem. And we found that about 20%, 26% is the prevalence of obesity in rural India. This is a study of a large number of subjects, as you can see. So 26% the prevalence of diabetes in rural area, and you can see it is whether you look at BMI or waist circumference, it is high. In fact, if you look at the waist circumference, it's about 32%. So we also looked at newly diagnosed hypertension and newly diagnosed diabetes and the total. What we found is that the distribution, you can see that this is BMI below 18, 18 to 22.9, 23 to 25, more than 25. We found that there was a steady increase in the prevalence of new onset or newly diagnosed hypertension with BMI, and of course, newly diagnosed diabetes with BMI, excluding the people with known diabetes. We found that it was 11% was the prevalence of newly diagnosed diabetes and 20% the prevalence of newly diagnosed hypertension. And if you club the two, the numbers were significant. It's just to highlight that this obesity in rural India portends an increase in hypertension and also in diabetes, new onset diabetes and hypertension. So we've looked at the diabetes management in India. There are challenges. I talked about our experience in the community. Now let me talk about how we tried to design a new way forward. So this is a study which I did many years back when I was in Cochin, and many people don't know that I have done this randomized controlled trial of yoga and peer support on glycemic outcomes in women with type 2 diabetes. This was an NIH grant by which Professor Ashwati Sridevi received, and I was her guide for this project. And at that time, what we did is that as part of the Ascent program, this grant, we decided to divide 3 groups. So we took around 124 people and divided them into 3 groups, randomized. One group we gave was control. One group we gave was yoga, as much as twice a week, thrice a week. And the third group we gave was something unusual. We called it peer support. So that's where I found that number 1, women, and number 2, peers who have diabetes are wonderful educators. You don't need doctors or diabetes educators or nutritionists to reach out. So we did the study and we decided to compare these 3 outcomes. And of course, we published the glycemic outcomes, which was more or less similar. We published the hypertension outcome, which showed some marginal benefit in the yoga and the peer support group. But then we looked at the quality of life, and that's very important. Quality of life. And that we found some very interesting results in peer support. So what is peer support? Peer support is defined as a support from an individual with an experiential knowledge based on a sharing of similar life experiences or prevention plans in daily life. So using, or rather employing people with diabetes, especially women with diabetes, to go at least once or twice a week and a phone call to other women with diabetes and empowering them. So we talked about ASHA workers, we talked about yoga teachers, but we are looking at people with diabetes who are going out into the community and helping other people with diabetes. So this is a study which really inspired me. I did it in Kerala and during the days I was in Cochin. And what we found is very interesting. We found that, well, the control group, there was not that much difference. They were very exciting little findings of a significant p-value in the quality of life in both the yoga group and the peer support group, particularly the peer support group, because actually when you do research, you mustn't expect anything. But really, I wasn't expecting that. I thought yoga would be better than peer support. But here we showed that yoga and peer support were better than controls. And that was very fascinating. And that showed that diabetes is the more empowering that you can do to patients and communities, we can actually help the patients better. And this is a paper which was published, and Dr. V. Mohan sir was also part of this paper. This is a CAR study, which again, I was an investigator, and even after that, I continued to be a glucose control, looking after the glucose control, etc. for the study. And this was published in the Annals of Internal Medicine in 2016, again, which showed that this is urban India care coordinator driven, guideline directed therapy. This showed that actually HbA1c, lipid profile, and blood pressure, all three, just a care coordinator to give a little nudge to the patient and the doctor to bring it together, could increase guideline directed therapy to people. So I really hoped that a rural project would also show a similar result, but it was time to do actually an intervention to see what happens. So that's when we decided to do this project called Diabetes with Dignity. Of course, we got the help of Sanofi, but importantly, we got the help of the Ministry of Health and Family Welfare. We also got the help from the Jilla Parishad, the health authorities in Pune district, and also we got the help of the Arogya Bhavan, which was the health authority office in Mumbai of the entire Maharashtra state. So all these people came together, and we decided that we also did not want to, we wanted our results to be evaluated independently, not by us, somebody else. We could design, we could conduct it, we can implement it flawlessly because we have already built the capacity to do that. We have good relations, not just with the patients out there, but with the doctors in the rural areas, with the government medical officers, with the health authorities. So we are able to, we have their trust because they know that we are genuine, but still we wanted our results to be evaluated by another partner. And that's where we got the Public Health Foundation of India to be an evaluation partner to this project. So this is the mobile diabetes clinic. We called it Project Diabetes with Dignity. And again, our administration manager, Dr. Dhore, and Dr. Anjali Bhatt, who's of course no longer working with us now, but she, during her period, she helped us drive this project. And here is both Dr. Dhore and Dr. Anjali in the villages talking to ASHA accredited social health workers, empowering them and giving them education. And we designed a curriculum on different aspects of diabetes, like diagnosis of diabetes, diet, exercise, testing, blood pressure, need to visit a doctor. And as I said, we didn't stop there. We also reached out to the village health and sanitation committees and the local leaders and did a diabetes education class for all the people in that district. So when they got involved, or the local leader got involved, they also helped us to make sure that all the people come for the project. We also, in addition, we trained all the doctors in that area, because no point in just bringing the patient to the clinic, or seeing the patient just going to the mobile clinic and seeing the patient after 6 months. No, to close the loop, we also trained all the doctors in that area in diabetes, including government and private and everybody else, so that the whole system could work. So this was designed to see if ASHAs could impact, whether ASHAs could get the patients to go to their doctors and make an outcome. It was not to design whether a mobile clinic works. That was not the question we asked. We wanted to see if the ASHA worker empowerment would work. So briefly, this was a project. We studied 5,000 adults in each group, the intervention arm and the control arm. And these were selected, of course, randomly. And we took 300 people with diabetes in each group. Initially, of course, we assumed a lot of dropout. In one group, the people would be seen in the beginning and at 6 months. And in the other group, this people would be seen in the beginning and at 6 months. But in between, the ASHA worker would make sure that there is a visit and that they would also be community education activities, and they would also be urged to go to their doctor, preferably government doctor, and see how things work. So these results we presented at the IDF meeting sometime back at the IDF Western Pacific region in Kuala Lumpur. We found that the HbA1c, the green color is the intervention group. We found that the HbA1c came down in the intervention group. And the HbA1c, of course, went up in the control group, which was expected because you're just leaving them alone after initial diagnosis and just telling them and seeing them after 6 months. So we did find that, but this was a proof of concept that, yes, training the ASHA worker would help. And we decided, and we continue to advise the government that in addition to all the diseases which the diabetes, which the ASHA workers manage, like vaccination and TB. We wanted diabetes to be part of it. And we are lucky that we've been able to influence the policy in Maharashtra to some extent, where now you're seeing ASHA workers, sub-center workers. I forgot to mention that we also trained all the non-doctors as well as the non-doctor paramedical staff in every PHC and sub-center in that district, in the 2 areas which we studied. So we studied that and we found that the HbA1c came down. We also found that the LDL improved. So we found that the project Diabetes with Dignity interventions were effective in reducing HbA1c among subjects with diabetes in the intervention group compared to the control group, and that the capacity building of community health workers is recommended. But this does not fully describe what all happened. One thing that we found happened is that when we went to the government, once we trained these government doctors, we visited the PHCs and the sub-center. We found that at the primary health center and at the sub-center, they had become so aware of diabetes that they maintained a separate book for diabetes. They kept 1 day of the week exclusively as a diabetes clinic. Where when we went initially in the PHC, what medicines were there? We found more medicines out there in the PHC. And also we found that the government reached out to us, and many of our staff participated in local village, district and panchayat meetings as diabetes advisors. And we found some of our staff were also on the panels and committees to actually implement it. And we know that today Maharashtra has a very excellent rural diabetes care project as part of the government service. So we've been able to help the government. And we also have designed lots of education materials on gestational diabetes, foot management, and we've shared it with the government. And indeed, the government has also used it extensively for education. I'd like to thank Dr. Nikhil Tandon, Dr. Srinath Reddy, Dr. Monica Arora, Dr. Sadhana, who headed the health services of Maharashtra at that time, Dr. Damodar Bachchani, of course, and the district health officer and civil surgeons team, and our own project Diabetes with Dignity team. We also did something interesting to prevent childhood obesity. We designed a module some time back to see whether childhood obesity in urban India can be prevented by a simple module of education with voting pads where children can decide to choose the foods, the right foods, and we give them a training and then see if their decision has changed. We were able to help them choose the right kind of foods, the healthy foods, not the junk foods. And we also tested this, and we found that when we looked at the pre-test and post-test, we found that there was a significant improvement in proportion, and we piloted it in several schools in Pune as part of the Chalaram Foundation. So I think childhood obesity prevention is a very important aspect. And this was also highlighted in the IDF's publication. As you know, we continue to believe that patient education and empowerment is important. And we've our magazine Diabetes Health in its 10th year now, and this is of course a recent cover story on how to eat an Indian Mediterranean diet, which we covered. And of course we've covered the pandemic, we've covered fasting and feasting and almost all topics, and people like Dr. V. Mohan, Dr. Anjana have all contributed to this magazine. So before I end, I want to just conclude by saying that there are lots of challenges in India in the management of diabetes, particularly in the prevalence of diabetes, in the care of diabetes, in how women with diabetes are treated, are given diabetes treatments, the affordability, the accessibility, even insulin as I've shown. But I think that all of us can, it's not that we can't do anything about it. We can all do. At the very least, we can share the right information, like all of us share on social media and public about the importance of diet, exercise monitoring, medications, and insulin. I also described our experience in the community, where I talked about how our hub and spoke model was planned and how it was executed, and how we looked at the India Diabetes Score and other risk scores to bring people, and how we found that high-risk screening was effective. We also looked at the thoughts behind designing a new way forward after the yoga study which we did, and the peer support study we did, and of course the CAR study. All this helped us to design the new way, which is the Diabetes with Dignity study, in which we compared an intervention population versus a control population showed that simply educating the ASHA health workers would help in making diabetes care better, and also in helping the government and working with the government to help diabetes care would make sure those government wheels are activated and people get better. We've shared all our information all the time. I'd like to thank Mr. Lal L. Chalaram for his fantastic vision. And this is, of course, me sitting next to him and part of our entire team. Dr. Dhore, who looks after the outreach program, Dr. Purandare, who looks after our clinical care, and my own family out there who supported me for all my activities. In fact, my little son is also sitting there, and my travels during the pre-pandemic period for putting up with that. My colleague, Dr. Brigadier Anil Pandit, Mr. Shankar, so many people have made us what we are, and this oration is a chance that we can actually remember them. Of course, thanks to Dr. V. Mohan, living legend in the field of diabetology, one of the reasons why we stay inspired all the time. And of course, the various institutions I've studied, the Calicut Medical College, the Banaras Hindu University. This is a huge library of Banaras Hindu University, the Amrita Institute of Medical Sciences, where I worked, the Christian Medical College, Vellore, where I studied, the Chalaram Diabetes Institute and all our staff. And of course, so I've lived in many parts of India, so you can say that I'm really pan-Indian. I've lived in the north, the west, the south, and some of my gurus whom I'm indebted to, Mata Amritanandamayi, and of course, Bhagwan Swami Sri Sathya Sai Baba, who Dr. Mohan is also a devotee of. And I am because of the days I spent with Bal Vikas and Pre-Sevadal and the many activities. In fact, one of the reasons I may have become a doctor could have been because of I used to be an assistant in medical camps during my school days. So I used to be at the registration desk sometimes. I used to be at the helping out with medicines, with cataract camps. So that's very similar to the mobile diabetes clinic work, which I did here at the Chalaram Diabetes Institute in Pune. So I'm really indebted to Swami, and my humble pranams at the lotus feet of Swami. And all my collaborators, the government health authorities, the Chalaram Diabetes Institute, the NCL CSIR, the PHFI, and all our collaborators, my colleagues. Once more, thanks to Dr. V. Mohan, Dr. Anjana, Dr. Ranjit Unnikrishnan for giving me this podium to speak, and for the oration. I'm humbled, I'm touched, and it's an honor being here. Thank you, and thank you.
Thank you so much, Uni. I think you have, every time I hear something new you have done, I've listened to you 3 or 4 years ago when you spoke about your rural work, but it's obvious that you're continuously innovating and learning from your experiences and putting it, as you say, it's all our combined experiential learning, as we call it, that one thing leads to the other. And the real passion and the motivation comes from that spiritual touch, that we have to change the lives of people. And I think I wish you continued success. I know that your institute also follows that philosophy, and your founder, Mr. Chalaram, is also a large-hearted man. And so I'm sure you have just scratched the tip of the iceberg, and you've got a long way to go. And in that part of India, I think you're doing something really unique, and as a model, and working with the government is something which is we find quite challenging, but you have done that also very successfully. So I think these are models which can definitely be emulated to take the care to rural India, because we know that 75% of the doctors practice in urban India, while 75% of the population lives in rural India. And this mismatch can only be solved by things like this. We cannot just tell our doctors, go to a village and stay there. Nobody's going to do that. Right from the British times, we've been trying and really not worked. But then today with technology, perhaps COVID has taught us that we can use other platforms like this. Like today, you're sitting there and we're sitting here. And Dr. Mata Prof was just joined, will be giving the next oration, is in London or Portugal maybe. And from there, we are all connected, and it looks like one small world in one screen. We are all there. If prior to COVID, I don't think we would have even attempted this. If you had a meeting, I would have come to Pune, and if you were giving the oration, you would have come to Chennai. Of course, that has its own charm. I'm not denying that. But then, the world has become so much smaller today and so much connected. We had people from Australia giving orations today and from US and from everywhere. So keep up the great work. Very proud of what you're doing. You truly, truly deserve this. For a couple of years, I've been telling our scientific committee that there's some extraordinary work going on, and this was the opportunity for us to honor you. So thank you.
Thank you, sir.
Ranjit, Anju, any final comments?
No, it's quite stunning the amount of work that you have done, sir. It takes a very large heart to do what you're doing. And we wish you all the best. Very, very happy to be associated with you and wish you all the best for even better work in the future.
Thank you.
Thank you. Thank you, Dr. Anjana. Thank you.
Thank you, sir.
Will we move on to the next oration?
So we now move on to the Professor M. Vishwanathan Gold Medal oration, and to be conferred on Dr. Martha Koch, who will be speaking on writing and publication in diabetes behind the scenes. We have with us Dr. Martha Koch with us, and I request Dr. R.M. Anjana, Managing Director, Dr. Mohan's Group of Institutions, to read a citation and introduce the recipient of Professor M. Vishwanathan Gold Medal Oration Award. Over to you, Dr. Anjana.
Thank you, Pradeepa. Welcome, Dr. Koch. It's an absolute pleasure to have you with us today. And it's my kind duty to now read your citation. So the 6th Professor M. Vishwanathan Gold Medal Oration Award conferred on Dr. Martha Koch, Editor-in-Chief, The Lancet Diabetes and Endocrinology, London, UK, on Saturday, the 31st of July, 2021. The Professor M. Vishwanathan Gold Medal Oration Award was instituted with the main objective of honoring scientists and clinicians who have contributed significantly to the advancement of medicine in general and diabetes in particular. This prestigious Gold Medal Award was named after a clinician, teacher, and internationally recognized leading research scientist in diabetes, Professor M. Vishwanathan, who is also regarded as the father of diabetology in India. The earlier recipients of this award were Dr. Samuel Degago-Jack, Professor of Medicine and Chief, Division of Endocrinology, Diabetes and Metabolism, A.C. Mullins Endowed Professor in Translational Research at the University of Tennessee Health Science Center, Memphis. Dr. Tobin Hansen, Professor, Department of Genetics of Human Metabolism, the Novo Nordisk Foundation for Basic Metabolic Research, University of Copenhagen, Denmark. Professor Kamlesh Kunti, Professor, Primary Care Division and Vascular Medicine, University of Leicester, UK. Dr. Ian Bloomer, Director, Charles H. Best Diabetes Center and Lecturer, University of Toronto, Canada. And Dr. Paresh Dandona, Chief of Endocrinology, Department of Medicine, University of Buffalo, New York, USA. The Scientific Council of the Dr. Mohan's Diabetes Specialty Center has great pleasure in conferring the 6th Professor M. Vishwanathan Gold Medal Award on Dr. Martha Koch this year. Dr. Koch completed BSc in Biology from the University of Minho, Portugal in the year 2000, and her PhD in Biomedical Sciences from the University of Leuven, Belgium in 2007. She began her research career in the Porto Oncology Institute, Portugal in 2000. After being awarded her PhD in Biological Sciences, she pursued her postdoctoral studies at the University of Leuven, Belgium, till 2014, and at the Scripps Research Institute, Florida, USA, till 2015. Dr. Koch has been a professional editor since joining the journal Cell in 2015. Her editorial experience extends through basic science, translational, and clinical research topics. Later, she joined the Lancet Group in 2018 as the inaugural editor-in-chief of eClinical Medicine. She's been serving the diabetes and endocrinology communities as editor-in-chief of Lancet Diabetes and Endocrinology since 2019. Dr. Koch's research has led to several publications in peer-reviewed journals. She has also delivered lectures in various scientific forums. She's been mainly involved in providing training to research personnel on how to prepare, submit, and publish a clinical study from the point of view of a professional editor. And I think that's precisely what she's going to do today as well. We're really looking forward to that lecture. The scientific committee of the Dr. Mohan's Diabetes Specialty Center has great pleasure in conferring this award on you. May I now request the award to be presented virtually. Congratulations, Dr. Koch.
Well deserved.
Thank you. Hi. I'm in London. I happen to be in London, not in Portugal. I wish I was there with you, physically
Yes.
with you. My heart is with you. I am so honored and so deeply humbled to receive this award.
Thank you.
I should say leading a journal is not a one person's effort. It's really a team, and I'm very, very thankful to our team at The Lancet Diabetes and Endocrinology, Dr. David Holmes, Dr. Susan Rahimi, who are fantastic editors and excellent colleagues. And I'm very inspired every day by my colleagues at The Lancet, Dr. Richard Horton, and so many, and it's a great inspiration and a great privilege to work there. And thank you again so much for this recognition.
You can now proceed with your talk.
It's a great pleasure to speak today. Thank you so much for this honor. So I'll tell you a bit what we've been up to at the Lancet Diabetes and Endocrinology, and about some of our priorities and recent contributions to the field of diabetes. And then I will give you a little peek behind the scenes about publishing and offer some tips for writing and submitting a clinical paper, which I hope will be helpful for some of you. But before, I would like to tell you just a bit more about myself and about my background. So I'm originally from Porto, which is a beautiful city in the north of Portugal. After I finished university in Portugal, I moved to Belgium to do a PhD in biomedical sciences at University of Leuven, which is one of the oldest in Europe, from 1425, and I stayed longer for a postdoc in genetics. After that, I crossed the Atlantic to do a second postdoc at the Scripps Institute in Florida. Although I enjoyed research very much, my overall curiosity for science, which more often than not transcended my own projects, triggered my interest in editorial work. So I left sunny and warm Florida, and in early 2015, I joined the editorial team at Cell. So I moved to cold and snowy Cambridge in Massachusetts in the middle of one of the worst winters in recent history. Joining Cell and reading and handling research on so many different topics really amplified my science curiosity. And it helped me see the big picture and how different fields and topics were connected. During my time at Cell, I became more and more interested in translational science and in clinical medicine. And so, in 2018, I moved back to Europe to join the Lancet Group in London. There, I launched a new open access journal, eClinical Medicine, and the year after that, I joined the Lancet Diabetes and Endocrinology as the editor-in-chief. This journey has also taken me to public health research, and I'm currently pursuing a degree in public health at the London School of Hygiene and Tropical Medicine, which I'm enjoying very, very much. So, although sometimes I miss academia, I find the job of an editor incredibly stimulating, and I've never regretted the decision to become one. One of the reasons is because I think I'm a generalist more than I am a specialist, so I enjoy knowing about many different subjects. Being a generalist and not specializing in a research field makes it more difficult to contribute to the content of a paper, of course. But we editors contribute very much to the delivery and the safe communication of the findings, which are key aspects of science too. Scientific journals are platforms for sharing and debating peer-reviewed research at the global scale, and editors help communicate information in ways that can maximize the potential for clinical practice change and for informing health policies in times of uncertainty, such as this pandemic. I chose the Lancet Group for this endeavor for many reasons. As I mentioned, when I was at Cell, I was handling a variety of science topics. I become more and more interested in clinical medicine and public health, and the Lancet is a renowned clinical journal and with very strong interest in public health, of course. But the Lancet is much more than a journal. It's an institution that was born at a time of social change. It was founded in 1823 by Thomas Wackley, an English surgeon. His interests went far beyond medicine, and he campaigned against incompetence, privilege, and nepotism. He saw the Lancet as an arched window to let in bright light, but also as a knife to cut out the rubbish. He wanted his journal to illuminate the murkier aspects of medicine, letting in light and getting rid of dross. Over the past 21 years, the Lancet Group has launched many specialty journals, and our journal, the Lancet Diabetes and Endocrinology, was launched in 2013. So, following this brief introduction, I've now split this talk into two parts. In the first part, I'll talk about publishing during COVID times and give you an overview of recent papers we helped published. And also, I'll tell you a little bit about some of the journal's priorities beyond COVID. Then I will talk about several important points to consider when writing and submitting a clinical paper, and a summary of what happens after submission from peer review to publication. Okay, so let's go. One of our jobs, as I mentioned, is to help publish important clinical and public health studies in ways that maximize the impact of the findings. So, of course, we love to see how our content is highlighted in the media. And although we cannot always control what the media says and how they hype the findings, and they often do that, we can minimize that risk by ensuring that the papers we publish are reported in a transparent, balanced, and accurate way. It goes without saying that last year has been a very unusual year in terms of publishing. Since the start of the COVID-19 pandemic, research has accelerated dramatically. This, of course, has led to many editorial challenges, such as trying to balance speed and volume, and prompting discussion about how potentially certain elements of peer review can be accelerated without impacting quality. Nature published an interesting analysis piece on this topic at the end of last year. And this chart illustrates the substantial increase in COVID-19 publications last year. It's also interesting to see the unprecedented rate of preprint submissions. Preprints such as bioRxiv, medRxiv, and our own Lancet preprint server are publishing hundreds of papers every month. Although preprints can be very helpful to communicate information quickly, it's important to note that some of them may lack the scientific rigor of peer-reviewed papers, and many of these preprints can be speculative and may even contain flawed evidence, which will sadly contribute to public mistrust in science. So this is something, of course, to bear in mind when reading preprints. At the Lancet Group, so this includes all Lancet journals, we have seen an average increase of 140% in submissions last year in comparison to 2019. So here on the right side, you can see the peak of submissions to the main Lancet journal in early April last year in red, and how it compares to the rate of submission in 2019 in blue. In some Lancet journals, the growth was even more than 300%, but luckily we didn't have such high increases at the Lancet Diabetes. So it's clear that the pandemic has changed many aspects of our society. Whether scientific publishing will be the same after COVID-19 will be very interesting to see. All COVID papers that we and all other Lancet journals published are placed on our COVID Resource Center, and they are made freely available so that everyone can read them. I will now highlight a few COVID-related papers that we published and which have made strong contributions to the field. One important thing though, we are proud to help publish the most important work on COVID in the fields of diabetes and endocrinology during these very uncertain times. But we must not forget other fields and priorities. So later I will also talk about non-COVID content. So one of the first papers we published on COVID was a short report from France, suggesting that people living with obesity were at higher risk of developing severe COVID disease. In the meantime, these findings have been validated in other cohorts and settings. And on this topic, we published recently an article showing that actually the risk of severe COVID started to increase at much lower BMIs than anticipated, especially in people younger than 14 and of Black ethnicity. Equally important is to give the voice to patients during this pandemic. So altogether, these findings and discussions help identify individuals who are at higher risk of developing COVID and could require hospitalization. Last summer, we also published one of the very first studies quantifying the absolute and relative risks of severe COVID for people with type 1 and type 2 diabetes, and showing that both types of diabetes were independently associated with a significant increased risk of COVID-19 mortality, as you can see in this chart. And in the same issue, and from the same group of authors, we published a population-based cohort study of people with diabetes who were registered with general practice in England to better understand the associations between risk factors and COVID-19 mortality. So this paper showed that dying from COVID-19 was associated not only with cardiovascular and renal complications of diabetes, but also glycemic control and BMI. Again, these findings help identify individuals who are at high risk of disease and provide actionable points that can help minimize that risk. They also inform policies, for instance, in terms of vaccine prioritization. Indeed, both types of diabetes have been included in the list of morbidities of those who are clinically vulnerable in many countries, so these groups can have priority access to the vaccine. Early on in the pandemic, when little information was available on how to manage patients with COVID and with diabetes, we published practical recommendations for the management of these patients. And just 2 weeks ago, although not a recommendations article, we published the DARE-19 trial, reporting that treatment with dapagliflozin did not result in a statistically significant risk reduction in organ dysfunction or death, or improvement in clinical recovery, but was well tolerated. Beyond research, reviews, and comments we publish, we write monthly editorials on controversial and timely topics, such as the issue of vaccine priority lists for COVID, the links between COVID and diabetes, and the need to prioritize metabolic health in a post-pandemic world, among others. As I mentioned, publishing COVID content has been one of our top priorities since early last year. But this does not mean we should forget about other important topics. Quite the contrary, given that the world is so focused on COVID, and rightly so, but it takes a little more effort to draw people's attention to other important issues. So, beyond COVID, I wanted to highlight some of our other efforts in striving for diversity and equity. So in this month's cover, our artist, Daniel Garcia, illustrates the issue of health disparities. Unfortunately, minority ethnic groups still lack the type of access to health care in diabetes that white populations take for granted. Our editorial this month focuses exactly on this problem. We draw attention to the high burden of diabetes and complications in minority ethnic groups and low-income populations. The Black Lives Matter protests last year following the death of George Floyd placed racism at the top of the agenda for change. It is time to capitalize on this momentum to drive change at individual, organizational, and policy levels. Equity in diabetes can be achieved for Black and minority ethnic groups, but not without first recognizing and counteracting the role of racism, both current and historic, in creating and perpetuating diabetes inequalities. Signs of change are already evident, but much, much more needs to be done. In this comment, also published in the current issue, Sharita Golden at Johns Hopkins explains how for a very long time diabetes and its complications were underappreciated in Black people and minority ethnic groups such as Native Americans, and how this has resulted in health disparities. She also discusses how structural racism has led to current diabetes inequities, and she suggested that healthcare providers should receive mandatory unconscious bias and anti-racism training. And in fact, her institution is already conducting workshops on these issues, and so is the Lancet Group. Another important issue is how virtual healthcare, which has had a clear boost during the pandemic, is also inequitable, because populations with health disparities are the same as those that are having difficulty assessing virtual healthcare. So achieving virtual health equity for people with diabetes will require a number of specific considerations. Another of our priorities is to help increase representation of women and minority ethnic groups in diabetes research and publishing. Just last month, there was an excellent piece of work published in Diabetes Care and in Diabetes, reporting on the current gender gaps in leadership in the diabetes field. Among other data, the authors report that although almost half of the attendees of the annual American Diabetes Association conference are women, only 5 of 81 ADA presidents of medicine and science have been women. But also, women receive significantly less major achievement awards given by the ADA, GDRF, and ESD. But the authors go beyond just reporting this persistent leadership gap and provide recommendations and potential solutions to diversify the field of diabetes research. So definitely worth a read, this piece. Important to mention as well that the ADA is invested in addressing this problem and taking actionable steps to understand conscious and unconscious bias and help build equal opportunities for all. And we can continue to discuss all these persistent gaps, and it's important we do so, but action is key. Just a few days ago, we published a short paper investigating female participation at the annual National Conference of the UK Society for Endocrinology. What the authors did was to quantitatively and qualitatively analyze questions and comments from the 2017 meeting and comparing it to those with from 2018 when the intervention took place. So this was an intervention aimed to improve female participation inclusion by requesting that more women are invited to chair sessions and reminding chairs to offer the opening question to a female audience member if there was the option to do so. And indeed, the authors saw an increase in female participation in 2018 compared to that of the year before. In our journal, we have a gender-balanced international advisory board, and we are proud of this statistic, but our efforts are by no means completed. We also aim to achieve a better geographical balance in both our content and in our international advisory board. And I should say at this stage that we don't see men and women as competing populations, and we don't want to reinforce gender as binary, so measures are also being considered to avoid these issues. We're also very keen to increase the visibility of women researchers and ethnic minority groups in the fields of diabetes and endocrinology via our profile pieces. And although we haven't profiled any researcher in India recently, we are very keen to do so, so feel free to send me your nominations. Moving on, the insulin centenary, of course. One could argue that there is no appropriate date to observe the centenary of the discovery of insulin, since there are several important milestones. But 2021 was chosen as the year for this celebration. Although insulin has changed the lives of countless people with diabetes, it is still inaccessible to millions. So this year is not only a time for celebration, it should also be an opportunity to reflect on the shocking lack of insulin access for so many people and call for action on this issue. Banting, here on our cover, reportedly said, "Insulin belongs to the world, not to me." We published and will continue to publish on this important topic. So let's celebrate, but let's not forget the millions of people with diabetes worldwide who still struggle to access affordable and quality healthcare. For more on our initiative to mark 100 years of insulin, we have created a webpage, so do check it out if you're interested. And in the second part of this lecture, I will talk about some important points that you might want to consider when writing and submitting a clinical paper, and I will tell a bit about what happens after submission. So the first tip I would like to share is do check which reporting guidelines are appropriate for your clinical study. And there are many, and I'm only mentioning a few here, such as CONCERT for randomized trials, STROBE for observational studies, or PRISMA for systematic reviews. But there are many, many more, some of which are quite specific. If you're not sure which reporting guidelines apply to your study, do check the Equator Network website, which provides great guidance on this matter and gives you extremely useful information, including practical help and resources to support you in the writing of your research. The CONCERT guidelines for reporting trials include a 25-item checklist on the various sections of the manuscript. I'm only showing here the first 11, and I won't read them. I just wanted to give you a sense, if you don't know yet, about how comprehensive they are. So this list is for the most common design, which is randomized two-group parallel trial Other trial designs, such as cluster randomized trials or non-inferiority trials, require slightly different reporting, which is also available in the network website as concert extensions. Also, many trials had to be modified in response to COVID-19, and the recently published CONSERV statement offers guidance to help improve the reporting of trials in extenuating circumstances. So take a look if you think you are in that situation. Finally, please do not forget to include the trial protocol with your submission. A protocol describes the aims, interventions, outcomes, statistical procedures, ethical considerations, and so on. And it's important that these elements are available for readers, editors, and peer reviewers, because they are a key quality control. A protocol also safeguards against unethical changes in the methods and in the reporting of the trial. So Lancet journals require that protocols are submitted with trial manuscripts. And I haven't mentioned this yet, but of course your trial should also have been prospectively registered in a public database before recruitment of the first subject. Second piece of advice, present your paper as a logical story. You don't want your readers to be confused and miss the significance of the findings. A properly drafted paper includes a well-referenced introduction that explains the background literature and identifies the aim of the study, and an insightful discussion that contextualizes the findings and highlights both strengths and limitations of the work. Next, spend time to think of a title and an abstract. Actually, guidelines might make this decision much easier for you. For instance, there are specific recommendations for titles and abstracts in the concert guidelines. These are important guidelines to follow because they help ensure that a study is appropriately indexed and easily identified. For instance, by using the word randomized in the title and specifying what phase the trial is. And I'm just giving you an example here on one such title. If your paper is not a trial, just bear in mind that generally short and clear titles are preferable. It is important to note that some health professionals might not have access to the full articles, so well-structured and detailed abstracts will help these individuals and everyone else to assess quickly the relevance of the findings. The next tip I would like to share is to get feedback prior to submission. Ask colleagues outside of your field of research for an honest appraisal. For instance, whether they think the flow of logic is clear and if the claims are backed up by the data. If necessary, do not hesitate to seek language assistance. Check the information for authors of the journal you're planning to submit your paper to, and read it carefully, as these documents contain important information about the formats, length restrictions, and additional required elements for submissions. And you have a cover letter, and is it a compelling one? Cover letters offer a great opportunity to explain to the editor the significance of the work in a more informal way and why you think the paper should be published in their journal. A very good cover letter briefly summarizes what's been done before and how your work advances the field, is honest and precise, and doesn't repeat the abstract. So this last section of my talk discusses briefly what happens after your paper is submitted, and starting, of course, with what do reviewers look for in a paper. So the reviewers, which will include one statistician and at least 3 clinical reviewers at the Lancet, will check, as far as possible, from the submitted material, of course, that the research reported has been carried out well and that there are no flaws in the design or the methodology. So the reviewers help ensure the work is reported correctly, complies with reporting guidelines, and acknowledges prior relevant work, and they will assess whether the conclusions are valid and are well backed up by the data. However, it is important to say that being labeled as peer-reviewed doesn't mean that the work reported can be considered the absolute truth and free of all errors. It just means that the report has been looked at and it was critically assessed by appropriate experts. So if we invite a revision, it's always more productive to respond to each comment clearly and fully, rather than rebutting the reviewer's concerns. You might not agree with the reviewer's point, but in that case, state your case in objective terms. We may send the manuscript for re-review and will certainly do so if there were initial statistical concerns. And editors also might make additional points. These may be formatting or style points, or might be more substantial, but it's very important to address these as well. If your revision is successful and your paper is accepted, congratulations! Your paper will be assigned to an editorial assistant that will copy-edit it thoroughly. That goes well beyond improving grammar and readability. It will help ensure that the paper is reported in a transparent way and improve clarity. We will also commission a comment from an independent expert who can help contextualize the findings for a broad audience and maximize the visibility of the conclusions and the findings. And to help disseminate your work, we might also set up an internal press release for papers of interest to a wider audience, and will certainly promote the paper via several social media platforms. And with this, I will end here. Thank you so much again for this great honor. I'm always happy to receive any questions via email. Thank you for your attention.
Thank you, Dr. Koch. That was a very nice balance of both what you have done over the last 1 year or more, and right from the history, of course, of the Lancet, and then the second half specifically giving help from what happens after we submit the paper. I particularly like the cover letter part of it, which you told us when we met last, something which we don't give too much importance. So do it on the last day. Okay, now what do we write? And so we scribble something and then write. So it's a lot of valuable tips in there. It's really, really useful. And I think a lot of people could be having good work, and following the rules of the game is very important. And therefore, your points are very valid and well taken. Thank you very much. Very, very useful. We will, of course, this being a clinicians meeting, it's more clinical work, but it's still very useful with a lot of clinicians, like the person who delivered the oration before you, Dr. Unikrishnan. There are a lot of people from India who also publish a lot, and so it's useful to all of them. But we might have in the future research workshops designed more for the research community, and there we would definitely like to have you speak on this or on other aspects of research methodology and so on. So thank you very much. Being an oration, normally we don't take up any questions. So once again, it's my pleasure to thank you, Anju.
I would just like to add my thanks to that really refreshing break from a lot of clinical stuff and insulin and OHA. So that was really useful. There are a lot of PhD students tuned in today. We have a large research network as well. So I was actually laughing when you were talking about the cover letter and the abstract, because we spend the days and months agonizing over the results, and we've written the discussion, and finally we're like, it's done. And then we're like, okay, oh no, now there's an abstract, just cut paste something. Oh, there's a cover letter, just whatever, get it done. And we realize that is the most important thing when you are seeing it, and it's been really useful. Thank you for sending out the guidelines and stuff. And if we'll take a look, if you have any other links or anything that we can share with students, that also may be of use. So thank you very much.
Thank you. Just a quick note on actually the abstracts. I think it's important to remember that the abstract is actually the element that goes to the reviewers in the invitation letter. So reviewers decide on whether they want to peer review your paper. And of course, we all know they are very busy. So based on that abstract. So it's really worthwhile to, put quite some time into it. And I'm available for any questions via email. And I'll be happy to give other talks on this topic in the future. And thank you again.
That's very
Thank you.
kind.
And the other point about the abstracts is that apart from this is, of course, a very valid point that the reviewer may only see that to decide whether to go ahead or not. But apart from that, quite often, the number of journals and the number of articles that we have to read every week, very often we don't go beyond the abstract unless it's a topic very close to our heart on something which we are working on. Then we immediately want the full text and then we go into it. Otherwise, the abstract is all that is read. And in PubMed, only abstract comes anyway. And many people don't go beyond PubMed. So if that is not written properly, if the message is not conveyed properly, then the whole paper actually is a waste, even if it gets published. So. Yeah.
Absolutely, that is absolutely correct. And that's why we editors and our editorial assistants actually spend a lot of time in improving abstracts so that they are really reported in a transparent way. And we know that a lot of people indeed, as you say, only read the abstracts. A lot of people don't have access to the full paper and may even make clinical decisions based on the abstract. So yes, it's very important. This element is, in very good shape, very clear and transparent. Thank you.
Thank you.
Thank you very much. We'll be in touch. You're muted.
Ranjani, you're muted.
Sorry. So after the back-to-back orations, we're now moving on to the symposium on precision diabetes.
I just wanted to check of all the speakers for the, I can see Professor Nolan there, I can see Professor Rich there. Has Dr. Mary France come? Or?
She hasn't yet come in, she'll be there, sir, in some time.
Because we are about 8 minutes ahead of schedule.
She just joined in, sir. She just joined.
Oh, she's just joined. Perfect, perfect.
Okay.
Then we have. Anyway, she is the second speaker.
Second speaker, sir. That's what. So.
Good evening, Dr. Rich. Nice to see you.
Good evening. How are you?
Thank you.
So,
Nolan, how are you? Thank you.
Shall we start, sir?
Oh, there's Mary France. Hi.
Yeah.
I think we can start now. Yeah.
So the symposium is on precision medicine and diabetes. Where are we today? And the chairpersons for the session are Dr. Mohan and Dr. Radha Venkatesan. Dr. Mohan has been introduced time and again over the 2 days, and he's the chairman of Dr. Mohan's Diabetes Specialty Center and a recipient of several awards. And before sir tells me to stop, I will just go ahead and introduce Dr. Radha. Dr. Radha Venkatesan is an executive scientific officer and head department of molecular genetics, Madras Diabetes Research Foundation. She has more than 20 years of experience in teaching and guiding PhD students and in diabetes research. Her field of interest is molecular genetics. She underwent training at John Radcliffe Hospital, Oxford, England, and Steno Diabetes Center, Copenhagen, Denmark. Dr. Radha is the PI and co-PI for several research projects in the field of molecular and functional genomics of diabetes, supported by various funding agencies, including the NIHR, ICMR, DPT, and DST. As mentioned before, she's a recognized guide and has guided more than 15 students for a PhD degree. And she has over 112 publications on genetics of diabetes in national and international journals, and also book chapters. We welcome our speakers, Dr. Stephen Rich, Dr. Mary France Hayward, and Dr. John Nolan. So, I hand over this dais to
Anthony, what is that? Those two bands are coming there. Is that? It's gone now.
It's gone, sir?
The two bands there. Yeah. Now I think it seems to have gone. Yeah. Great.
Okay.
Thank you.
That's over to you, sir. You can introduce the speaker. Yeah.
So, ladies and gentlemen, it's a great privilege for me to chair this session with Dr. Radha Venkatesan. This is one of the highlights of this conference, a 3-day conference, Precision Medicine and Diabetes. We have not really had a full session on precision medicine and diabetes in any diabetes meeting in India that I know of for several years. At best, we might have had a small talk or something somewhere, but there's a full symposium, almost 2 hours devoted to this. And we are very lucky that the world leaders in precision medicine in diabetes are here. And we have 3 excellent speakers who are considered among the world's best in their respective fields. And it's my pleasure now to introduce the 3 speakers, and then we will get on with the symposium. And after those, the 3 speakers have given their talks, Dr. Radha and I will make a combined presentation. I'll present half of the talk, and then Dr. Radha will take over the other half of our talk. So can we introduce Dr. Rich, Stephen Rich, please? Can we have his slide? Okay. So let's start with the first speaker, Dr. Stephen S. Rich, MD, PhD, who is a Harrison Professor of Public Health Sciences, Director of Center for Public Health Genomics of the University of Virginia School of Medicine, Virginia. His areas of interest include genetic basis of the type 1 diabetes and its complications, as well as cardiometabolic phenotypes. He serves as principal investigator for several grants funded by NIH, Wellcome Trust, and MRC. He serves as chair of the American Diabetes Association Research Policy Committee and associate editor of Diabetes Care, and member of the NHGRI National Advisory Council. He has published over 600 articles in peer-reviewed journals, and he's a recipient of the Juvenile Diabetes Research Foundation David Rumbaugh Award and fellow of the American Heart Association and Research Award, University of Virginia. I'll probably introduce the other speakers after Dr. Rich's talk, and Professor Rich will be talking on precision medicine and type 1 diabetes. So we have 3 talks, one on type 1 diabetes, then one on gestational diabetes, and then another one on the precision medicine and diabetes complications. And then the 4th talk will be on precision diabetes in India, where are we today? So over to Professor Rich. Let's first hear about precision medicine and type 1 diabetes. We have in type 2 diabetes, we have heard of clusters and we've heard of a lot of things, but in type 1 diabetes, often we get the feeling, oh, it's just insulin deficiency and everybody needs insulin. So what is a precision diabetes? But you'll be in for a surprise. And so over to Professor Rich to tell us about that.
Thank you so much, Dr. Mohan. I wanted to start by expressing my appreciation for the invitation to speak at this meeting. It's one of the historically important meetings in precision medicine in the world. And this is great to be able to present today. So what I thought I'd do is to give you some background first on type 1 diabetes, and then also on some of the aspects of precision medicine that we talked about as part of our precision medicine diabetes research, or precision medicine diabetes initiative that's sponsored by the American Diabetes Association as well as the ESD. And so one of the things I'd like to start with is just a little bit of background. Type 1 diabetes from a Western society anyway, is thought to be autoimmune, where you have complete destruction of the insulin-producing beta cells in the pancreas. It occurs in all ethnic groups, racial groups, ancestry groups, very high prevalence in Finland. And but as we've thought in the past, as a pediatric disease, it actually occurs in all ages. The mean age, and it really has two sort of areas of ages of high incidence. Typically in pediatrics around 10 to 12 years of age, but in adults also around 25 years of age. Many studies have shown that genetics accounts for around 50% of the overall risk of type 1 diabetes, at least in the European ancestry populations. Interestingly, studies in Denmark shown initially that the risk for type 1 diabetes of a sibling of someone with type 1 diabetes is about 8%, which is also what it is estimated in offspring of someone with type 1 diabetes. However, a conundrum is that studies out of the Joslin Diabetes Center have shown that if you have a father with type 1 diabetes, the risk to a child is much higher than if you have a mother with type 1 diabetes. And that's not exactly clear why that happens. Anything from immune system to microbiome to various other ideas have emerged, but nothing is resolved. In the genetics of type 1 diabetes, the HLA region genes account for about 50% of the genetic risk. That was shown in, as early in the 1970s. And the HLA region genes are followed by insulin as the most important loci, with odds ratios in the HLA region around 7 and insulin around 4. And then you go from odds ratios of around 2, 2.5 for PTBN22 down to 1.05 as we've seen as larger sample sizes available. Again, much of this has been performed in European ancestry populations. However, recently we've published some information on the genetic risk where there is quite a bit of overlap between the sites and even the single nucleotide polymorphisms or SNPs that are associated with type 1 diabetes in multiple ancestry groups, but there's some very ancestry specific loci as well as SNPs associated with genetic risk. The autoimmune process in type 1 diabetes is thought to be the primary driver. And again, it's an autoreactive T cell process that seems to consider the main effectors of beta cell destruction. And it's important to note that in the pancreas, we have, hundreds of thousands of islets of Langerhans. And although this cartoon suggests that beta cells are the majority, actually they're the minority of cells. And how the autoimmune process targets this is not really clear. We often think of staging in type 1 diabetes, that there's underlying genetic risk in individuals followed by insulitis and beta cell injury as seen by development of classical islet autoantibodies. And then a process where you have prediabetes, where you have loss of first phase insulin response followed by the overt clinical diagnosis. However, there are certainly cases where you do not see the autoantibodies appearing in a consistent manner or even at all. It's also a problem in terms of tracking and understanding the natural history, because unlike type 2 diabetes, where you have the majority of individuals with type 2 diabetes having a family history, only about 5% of those individuals with type 1 diabetes have a positive family history, that is a first or second degree relative affected by the disease. So it's often really misdiagnosed until the individual goes into diabetic ketoacidosis and then is subjected to significant amount of time in the hospital as well as increased healthcare costs. So going back to precision medicine in type 1 diabetes, our paper that was published in Diabetes Care and Diabetologia recently really talked about the 5 pillars of precision medicine: and precision diagnostics, therapeutics, prevention, prognosis, and monitoring. And I'll touch on some of these with respect to type 1 diabetes. As noted by this paper in Diabetologia and Diabetes Care, precision diagnostics really talks about refining the characterization to optimize those downstream effects in terms of therapies, prognostics, prevention of complications. How does one do optimal treatment? And so it's really trying to use all available information to really determine what is the best path forward for the person with type 1 diabetes. One of the things that we've talked about in terms of autoantibodies is that the classical evaluation of progression is based upon autoantibodies, and these can be insulin autoantibodies, ICA, GAD, and zinc transporter. And so one of the things that was shown early in some of the DPT-1, as well as studies in Finland, studies in Germany, more recently studies out of the University of Colorado, the DAISY study, and also the Environmental Determinants of Diabetes, the Young or TEDdy studies, have shown that the number of islet autoantibodies is really correlated with the proportion of individuals without type 1, with or without type 1 diabetes. And this chart shows the proportion of individuals without type 1 diabetes. And if there are no autoantibodies, and this is out of Germany, there's really no evidence of progression. And if you have one autoantibody, it's a higher rate, two autoantibodies, and the highest rate were 3. This was based upon the insulin ICA 512 and GAD autoantibodies. In TEDdy, which was a study that started with individuals at, right after birth at relatively high HLA risk, the 5-year risk of developing multiple islet autoantibodies was 4.3% at 7.5 months and 1.1% at 6.5 years. So it also shows that having a relatively high genetic risk also tends to push the diagnosis or the development of type 1 diabetes much earlier. And out of this, for those who may have a high genetic risk, they suggest screening for islet autoantibodies at 2 years of age and at 5 to 7 years of age. Again, this is based on primarily European ancestry populations, but it's also recognizing that in type 1 diabetes, it's not clear how long islet autoantibodies will persist. So, we obviously see development of type 1 diabetes in children in their teens, and as I mentioned, also in adults. So, the question then is whether screening for autoantibodies at 2 years and maybe 5 to 7 years of age is really going to capture the bulk of those who are going to progress on to disease. So in terms of precision diagnostics, really the best diagnostic results is basically going to be the integration of all diagnostic modalities. These include the autoantibodies, but also the genetics. And there's been some initial results on genetic risk scores to identify those children or those individuals who have high genetic risk for type 1 diabetes. We basically identified in our populations roughly 80 to 90% of the genetic risk for type 1 diabetes at this stage. Of course, HLA accounts for about half of that. So, we are starting from a higher bar. However, the implementation, because even though it may have high sensitivity and specificity, it doesn't mean that it will have a high predictive value because the prevalence is so low. So research questions are still important in this area of diagnosis. Can islet autoantibodies be used to inform therapeutic approaches? What about prognosis? Are there other immune or non-immune biomarkers that can guide therapeutic optimization and prognosis? And one of the reasons that we want to have good diagnostics here is also that we want to apply these subgroups into precision prevention and precision therapeutics. At this stage, there really is no clear preventive measure for type 1 diabetes. Therapeutics is insulin. However, that can actually be improved. So again, precision therapeutics is tailoring therapies based on a variety of features to prevent or treat disease. Prevention, of course, is how does one intervene? And in type 1 diabetes, because it is an autoimmune disease, we've really been focused on immune interventions. Lifestyle interventions, risk factor avoidance, typically related more type 2 diabetes, monitoring very much so in terms of type 1 and typically continuous glucose monitoring, as well as the classical tracking of hemoglobin A1C, trying to, and importantly, minimizing side effects. And in type 1 diabetes, it can be both hypoglycemia and hyperglycemia. So one of the reasons that we're really focused on this idea of intervention is that the recent teplizumab trial of anti-CD3 has shown that, that's published by TrialNet, and Emily Sims has a nice paper in Science Translational Medicine on this recently, that effectively treatment with teplizumab has markedly slowed the progression to type 1 diabetes. And over a period of 72 months, there were still individuals who had not significantly not gone to development of autoantibodies or development of type 1 diabetes. There are also a series of other compounds that are being studied. Lefacep is actually one. Rituximab had been studied earlier. A series of these that are under investigation currently. There are a whole series of other types of treatments to intervene. However, I think the key thing may be similar to cancer, in that one type of intervention, immune intervention, such as teplizumab, may gain certain amounts of ability to delay progression, but it may be a combination or a cocktail of these different types of compounds or other types of approaches that will really be ultimately important to hopefully prevent the disease from occurring, or at least delay the disease to the extent that perhaps the immune system itself can sort of get itself back together and mount that appropriate immune response or stop the inappropriate immune response. The other part of this is that, are there other types of biomarkers or endotypes that can be used to evaluate and support prevention of trials? Michael Haller provided a nice report of this in the Precision Diabetes Medicine Symposium. Here's the link to that talk. Obviously, in addition to metabolic testing and knowledge of genetic risk scores, and aspects of assaying immune function, can we actually determine who would be best to go on specific trials or specific treatments? Again, combination of sequential therapies, and ultimately, what's the cost effectiveness? If it's extraordinarily expensive to try to delay or stop disease from occurring when there is a therapeutic and insulin, then what is that ratio of cost and benefit? Recognizing that part of the issues with respect to complications is how does one maintain good glucose homeostasis, or at least good physiology, so one doesn't get complications. So again, it's combining person's unique biology and environment to try to prevent or treat the disease. The therapeutic guidelines, again, insulin is the main treatment, the only existing therapy. But the research needs to move beyond this early glycemic response and thinking about how does one understand the pathophysiology of type 1 diabetes to help inform the new therapeutic approaches. And again, most of what we've seen has been in European ancestry populations, and it's important to know, how that translates to other populations, and in whom intensive insulin therapy may not be the best idea. There are studies ongoing now, some of those supported by the Helmsley Charitable Trust, on the impact of exercise, diet, pre-existing conditions, other types of behaviors on therapeutic response to insulin and control of type 1 diabetes. So I think this is a critical area that is growing in importance. Just briefly on precision prognostics, one of the ideas that Leif Group and his team had discussed in terms of how does one think about diabetes as a whole and then cluster into different subgroups is related to outcomes and complications. And so, again, precision prognostics is to improve the accuracy and precision that a person with type 1 diabetes, in our case, will lean and go towards a complication, whether it's cerebral vascular disease, retinopathy, cardiovascular disease, nephropathy, or neuropathy. The most recent genetic information has really been centered more on cardiovascular disease because there's been huge amounts of information related to cardiovascular disease. The importance of nephropathy is clear. About 40% of those with type 1 diabetes will get diabetic kidney disease. However, there's very little known about the genetic basis of this, and in most of the cases, as shown by many of the studies, including DCCT, having good glucose control is the most important aspect of this. So when we think about diabetes data science, this is where we think some of this is going. Obviously translating will need good decision support systems, but we're thinking about, for any individual, you'll need to get DNA and their whole genome sequence, so you'll have everything. They'll go into a database which can be considered to be the virtual image of a patient, which is based on an in silico model of a human metabolic system. These things have been being generated, and so the data include initial genetic profile. You do it once, you have probability distributions, and then what happens is that you continually update and evaluate this ecosystem to really optimize the treatment of those with type 1 diabetes or any diabetes. And so this includes getting information from electronic health records every few months. You can do a Bayesian update. It has to include physician expertise. There's real-time CGMs that can be involved, updating many physiological parameters. And then there's system dynamics and optimal control approaches to maintain the characteristics and the treatment and ultimately diagnoses of things that will happen in the future. And so when we start thinking of all this, going from one point to the next, updating the health records is going to be an incredibly important aspect of this, as well as this monitoring where we go through and really have physiological information at each time point. So in summary, I just want to clarify that as a lot of what we know is from a small part of the world, but we understand that type 1 diabetes is a complex human disease. We understand much of the genetic basis of it, although it may change from population to population. Although much of the genetics is known, the risk scores are based upon really those with type 1 diabetes and those without. And we really haven't applied the genetics well to initiation of disease, development of autoantibodies, or progression to islet autoimmunity. Those things are being attempted, but the numbers are still small. And we need to really develop where genetics fits into all of those. Importantly, we have limited information on these initiation factors in terms of diagnosis. These items, including new biomarkers, new therapeutics, new processes of drugs, and perhaps immune therapy trials, are great for therapeutics and prevention, but they're just a start, and more needs to be done. And finally, of course, prognosis is, although mainly through control of hemoglobin A1Cs, but it's incomplete. We're improving monitoring, but those technologies are still somewhat invasive and not optimally set up. So again, we need to understand more about population-specific prevalence and non-genetic risk factors. And with that, I'd like to, again, thank the hosts for inviting me. And here are some of the people that are involved with our work, and happy to engage with questions and any other discussion in the future. So thanks so much, Dr. Mohan.
Thank you, Dr. Rich. That was a very, very nice overview. I'm sure there must be questions, which we will take after all the three presentations. We'll now move on to the second talk, and may I request my co-chair, Dr. Radha Venkatesan, to introduce Dr. Marie-France Hebert, please, Radha.
Thank you, sir. And it's a privilege for me to co-chair this session with Dr. Mohan on a very important topic on precision diabetes. It's my present privilege and pleasure to introduce Dr. Marie-France Hebert. She's the Associate Professor of Department of Population Medicine, Harvard Medical School, and an endocrinologist, MGH Diabetes Center, Mass General Hospital, Boston, United States of America. Her research interests include etiology and primordial prevention of obesity and related comorbidities, particularly type 2 diabetes and gestational diabetes, fetal metabolic programming mechanisms, and the integration of genetics, epigenetics, and environmental factors contributing to obesity and related disorders. She's also the director of the curriculum team, Nutrition and Lifestyle Medicine, and the co-director of the Advanced Integrated Science course, Metabolism, Nutrition, and Lifestyle Medicine. She's published over 250 articles in peer-reviewed national as well as international journals, and is a recipient of several awards, including Robert H. Ebert Career Development Award by Harvard Medical School and Clinical Scientist Award by Canadian Diabetes Association. It's my privilege to welcome you on to talk on the precision medicine in gestational diabetes mellitus. Over to you, ma'am.
Thank you. Let me share my screen.
Yes.
Can you?
Yes.
Thank you for inviting me to present today. It's a pleasure to be here. In the next few minutes, I will give an overview of gaps and opportunities for precision medicine in the field of gestational diabetes. I firmly believe that precision medicine has many opportunities to improve the care of women affected by gestational diabetes and their offspring. During this presentation, I'll touch on 4 of the pillars of precision medicine, just like Dr. Rich did beautifully for the type 1. I'll try to be as elegant for gestational diabetes precision medicine. So for many years, the classic definition of gestational diabetes, or GDM, has been any degree of glucose intolerance that was first recognized during pregnancy. More recently, the American Diabetes Association proposed the following definition: diabetes diagnosed in the 2nd or 3rd trimester of pregnancy that was not clearly overt diabetes prior to gestation. This updated definition did open a very key question, that is now how to define hyperglycemia detected in the 1st trimester, which I think is one of the major current gaps in an area for future opportunities in the field. In most countries, the current recommendation are to do universal screening between 24 to 28 weeks of gestation using an oral glucose challenge, either using a 1-step or a 2-step approach. There's still a lot of controversies of what is the best approach, but as some of my colleagues suggest, it may be that instead of arguing on the 1-step or 2-step, we should find better diagnostic tools to screen and diagnose GDM. And so you'll recognize this little graph, just as Dr. Rich presented from the consensus report that was published in Diabetes Care and Diabetologia. And so I'm going to first dive into precision diagnostic for gestational diabetes. And one of the key questions for GDM is, can we predict who are the women who will develop GDM in the 2nd or 3rd trimester? Can we identify those at high risk in early pregnancy or even before? accurate GDM prediction could allow us to do more targeted screening, maybe reducing number of women who need to do an OGTT, or target women for earlier detection, or a very high-risk women for preventative intervention to avoid altogether GDM throughout pregnancy. Many algorithms have been proposed with a combination of classic clinical risk factors that are known, or in addition with biomarkers. And many of us are collaborating to help identify genetic markers that are specific to GDM. This is one example of an algorithm that combines clinical factors and biomarkers, most of them being measured in clinical obstetric practices as listed here on the left. And you can see that all the predicting model here offer very good prediction performance as reflected by an area under the curve of 0.88 or 0.98. This is another example of algorithm, this time using data available in electronic health records. In this article that was published in Nature Medicine last year, the baseline model in orange was using a set of classic risk factor as defined by the NIH. And they compare this area under the curve prediction performance to the blue line, which was based on variable that were all present in the electronic health record. And this new algorithm using machine learning technique had an area under the curve of 0.85. Again, very decent. But as we know, all those prediction model and algorithm often perform very well in the source population or very similar population, but not as well once tested in other settings or other countries. So we hope with the current collaboration in the new consensus report that it will open future collaboration between diverse groups that are working on these type of algorithms and lead to future clinical applications. On the genetic side, we can say that the genetics of GDM per se is still in its infancy. Most attempts at genome-wide association studies have been underpowered and reverted to test whether the known loci for type 2 diabetes are also associated with gestational diabetes. This one, GWAS, was published already almost a decade ago, and is still one of the best powered that was published so far. They identified 2 loci that reached genome-wide significance level, both already known for type 2 diabetes, including the melatonin receptor 1B, which interestingly, you can see here that on the graph, its effect size on the risk of GDM per risk allele was much greater than what was measured in a similar population for the effect size on risk of type 2 diabetes. So keep that in mind for the next slide. Given that we are currently trying to assemble as many cohorts and as possible that have information on GDM for the next round of GWAS, and this is preliminary results that is still unpublished from the GenDip consortium. And despite rallying as many cohorts and colleagues that have data, we only have a little over 5,000 GDM cases, which is a very small number compared to most of the type 2 diabetes GWAS. And what we found is, again, the melatonin receptor 1B and a few other well-known type 2 diabetes loci. Can see again this very strong signal from the melatonin receptor, much stronger than TCF7L2, which is our favorite type 2 diabetes loci and the strongest outside of pregnancy. So pointing that there might be a different physiology here in enhancing the signal from melatonin receptor 1B. The other thing I wanted to point out that we found one loci that is only found in pregnancy near a gene called HKDC1, and that we had identified previously to be associated with maternal 2-hour glucose in the HAPO cohort and in the Gen 3G cohort that I'll present in a few slides. So this loci is currently the only one that is very specific to pregnancy. Continuing with our opportunities in precision diagnostic, I would like to share with you a few of the investigation we've done in how to subclassify our GDM cases. And so the next few slides, I will present data and results from analysis conducted in the Gen 3G cohort that I have the chance to co-lead with colleagues from Canada. And so between the years of 2010 to 2013, we recruited over 1,000 women at first trimester, and then follow them up between 24 to 28 weeks of gestation, where they all perform a 75-gram oral glucose tolerance test. And based on that, we assessed that 8.4% of our population had developed GDM, which is expected in this mostly European descent population in Canada. But we also measure insulin and glucose at multiple time points during this OGTT to derive dynamic indices reflecting insulin sensitivity, insulin secretion. And we additionally measure multiple biomarkers, including adipokine, lipids, and inflammatory markers. And then we followed the cohort at delivery, where we collected clinical outcome, baby's anthropometry, cord blood, and placenta samples in over 700 deliveries. So one of our key investigations looking at heterogeneity of GDM was led by Dr. Poe. And so we calculated the insulin sensitivity based on the Matsuda index and the insulin secretion based on the Stumble index, and categorized the woman with GDM as having predominant sensitivity defect if their Matsuda was below the 25th percentile of the normal glycemic distribution. And that represented about half of our GDM women. We categorize GDM as having predominant secretion defect if their Stumble index was below the 25th percentile, and that was about 30% of our women with GDM. And the other almost 20% had a mixed defect where both Matsuda and Stumble were at the lower end of the spectrum. Another way of subclassifying the GDM was to use a soft clustering approach to pregnancy traits using genetic of type 2 diabetes. And this work was led by both Dr. Poe and Dr. Adler. And so using Gen 3G and 222 known type 2 diabetes loci and 35 pregnancy traits, including adiposity, glycemic traits, lipids, adipokine, and inflammatory biomarkers, we were able to derive 5 pregnancy-specific cluster with a combination of genetic and these pregnancy traits. And so building a polygenic risk score based on the loci identified in the first pregnancy cluster, we were able to then go into independent cohorts and test the association on the risk of gestational diabetes incidence. And we saw that this first cluster had a very strong predicting ability here with odds ratio 1.5, and the same combination of known type 2 diabetes loci had a lower ability to predict type 2 diabetes in a similar population. But why would we want to subclassify gestational diabetes? We all know that gestational diabetes is associated with pregnancy complication for both the mother and the baby, such as the one listed here. So with Camille and with Dr. Poe and our phenotyping based on our physiology, we found that it's actually mostly the women with a sensitivity defect that are at higher risk of adverse outcome. And here you can see that the combination of large for gestational age, neonatal hypoglycemia, and C-section as a composite adverse outcome, women with a GDM sensitivity defect had 3 times more likely to experience one of those adverse outcomes. And that was not the case for a woman with GDM who had a secretion defect or a mixed defect. And that's despite all women in our clinical center receiving the same care and the clinician targeting the same glucose target. And this risk was still significant in similar magnitude when we adjusted for BMI. Presence of GDM also been associated with long-term outcome, and women affected by GDM are more likely to develop type 2 diabetes and cardiovascular disease over their lifetime. And offspring that were exposed to maternal hyperglycemia during in utero development are more at risk to develop excess adiposity, impaired glucose tolerance, and even some neurodevelopmental issues. So could we improve our precision prognostic, especially for the risk of future type 2 diabetes in women with prior GDM? First, I think it's important to remember that this risk is not trivial. 50 to 60% of women with prior GDM will develop type 2 diabetes over their lifetime. Recommendation from many organizations is to do screening postpartum 4 to 12 weeks after delivery using an OGTT. And we know that we can prevent type 2 diabetes in women with prior GDM, either using lifestyle or metformin. And this reduction is maintained up to 10 years after introduction of lifestyle or metformin. But wouldn't it be nice to really focus on who we really need to do the postpartum OGTT so we can target and have a better yield, because only less than 50% of women actually come back to do this. So if we could invest our energy in the ones that are at the highest risk, maybe we will have a better return on investment. And for the prevention, if we could target better who is more likely to progress towards type 2 diabetes, or who is more likely to respond to either lifestyle or metformin, we could have also a more focused intervention. This is one recent study using metabolomics to predict which women with prior GDM will go on to develop type 2 diabetes. And you can see here that the area under the curve for predicting type 2 diabetes were around 0.69 to 0.75 using fasting glucose or 2-hour glucose. Since this was a research project, all women came back to do an OGTT postpartum. But the model using metabolomic signature that they derived alone had an area under the curve of 0.88 and slightly higher when adding additional information from the glucose value. So that is highly promising, I think, for predicting who among our women who had gestational diabetes will go on to develop type 2 diabetes. But again, this needs to be replicated in independent and more diverse population. For offspring exposed to gestational diabetes, my research group and many others have been investigating how the epigenome, mainly DNA methylation, also predict long-term programming of obesity and diabetes. And hopefully in the future, we can know which one of those markers can predict who is more likely to develop complications such as obesity and diabetes and may deserve more attention and intervention. Finally, precision therapeutics can also be applied to gestational diabetes. Many lifestyle interventions have attempted to reduce diabetes incidence starting early in pregnancy. Not always with consistent result, but more promising in the recent publication. Yet we are still lacking the tool to select the women who are at the highest risk. And so hopefully, future predicting algorithm will help us to do that. But also we need to figure out what type of intervention works for which women, because not everybody responds the same way. And for precision treatment, we could optimize therapy to reduce complication and maybe limit the burden of the current treatment approach. So just to remind people, many RCTs have demonstrated that GDM treatment can reduce complication. However, treatment is burdensome for many women. The current standards include glucose self-monitoring at least 4 times a day, dietary changes, physical activity, and adding pharmacotherapy when glycemic targets are not achieved with lifestyle. First thing I want to point out is that currently we are aiming for the same glycemic target for all women, no matter what. There are some places that use fetal ultrasound and some measurements, especially the abdominal circumference, to decide on targeting tighter glycemic control. And this is a step towards precision therapeutics, but I think we could still continue to do better. About lifestyle treatment, the current advice are generic, mostly based on trial and error for each woman, opening the door wide to potential precision nutrition. And then for pharmacotherapy, we agree that insulin should be the first line of therapy, but also acknowledge that oral agent can be considered, but we are lacking knowledge of how to consider the true balance of risk benefit for individual women with the classic GDM. So overall, I hope I was able to demonstrate that there are many potential avenues and exciting perspective for precision medicine for GDM. Using precise algorithm to predict GDM itself and the risk of type 2 diabetes on the long term for women with prior GDM. Refining definition for GDM for better diagnostic and prognostics. I also believe that given the current major gap of how to define GDM in the first trimester, we should embrace this opportunity to go beyond just glycemia as a diagnostic tool and really advance the field to identify and target women who would truly benefit to reduce short and long-term complication. The field of precision prevention and treatment is currently wide open, and both clinicians and pregnant women would welcome better targeted approaches. And finally, we are still at the infancy of precision prognostic for long-term outcome of offspring, with the hope to offer preventative intervention in children that would benefit the most and support healthier trajectories for future generation. Just want to acknowledge my research team, collaborators in Sherbrooke who've been instrumental in building and maintaining Gen3G, my colleague at the Choral Division at Harvard, many colleagues inside and outside Boston, and the multiple consortia. And of course, want to acknowledge the ADA for supporting our work in Gen3G.
Thank you, Marie-France. Lots of things you have opened up, and I'm sure there's going to be a lot of questions. We already see questions coming in the chat box, and we'll definitely share some of our own experiences also in GDM during the question session. But now let's go on to the third speaker for today. It's my pleasure and privilege to introduce my good friend, Professor John Nolan, with whom I've been working very closely in the precision diabetes meetings. Professor Nolan is the adjunct professor of endocrinology and metabolism and an honorary fellow at the Trinity College, Dublin. He's an executive member of the American Diabetes Association's Task Force on Precision Medicine. He served as CEO and head of Steno Diabetes Center in Copenhagen. It led to the development of the European Diabetes Forum, a new multi-stakeholder alliance focused on improving diabetes clinical outcomes. He's a member of the Irish Endocrine Society, European Society of Clinical Investigation, Endocrine Society, European Society of Study of Diabetes, and the American Diabetes Association. And of course, he's extensively published and a very popular and powerful speaker. So over to you, Professor Nolan. He's going to talk about precision medicine in diabetes complications.
Great. Thank you very much. Let me just find my slides. Here we go. And okay, so you can see me and hear me? Oh.
Yes, yes, very well.
Perfect. Dr. Mohan, thank you very much for the nice introduction, and it's such an honor and pleasure to be part of this fantastic meeting. I think it's a miracle that this is all over India, and you have the US, Canada, ourselves today. It's a miracle. I think COVID, we can thank COVID for that.
Australia, we had 3 speakers from Australia.
Unbelievable. So thank you very much, and it's a great honor. So I'm going to, let me see, can I see my own slides here? There's a panel at the top. What can I do with that?
For us, it's very clear.
Okay, good.
Yeah.
So the Precision Medicine and Diabetes Initiative that Steve Rich alluded to, that we're both involved in, was started by the ADA and ESD in 2018. So we're in our 4th year of this big international initiative. And I think it's really, it's a new era in diabetes care, and we're at the beginning of it. And it's really a movement to get beyond the one-size-fits-all approach to the clinical care of people with diabetes. And as you've been hearing from the previous 2 speakers and other speakers at this meeting, that is incorporating developments in pathophysiology, genetics, molecular biology, technology, to really change the way we care for patients with diabetes. It's setting the stage for translational medicine, and it's extraordinarily complex, and we're in the early stages. And this diagram from a paper from 3 years ago, shows that it's everything from the underlying biology and biomarkers through computer algorithms, all sorts of complex administrative engagement with regulators, talking to people with diabetes themselves, and then bringing it into the clinic. What I want to do today in this talk is really speak as a clinician, and also to other clinicians out there who want to start in this area. We will be waiting some time, as you have already heard, for many of the new insights from genetics, but it's already changing care. And the guidelines, the international guidelines, an example shown here on this slide, are already reflecting, they're moving in this direction for some years. So the guidelines for the care of people with diabetes are much more focused on narrowing down to the needs, including the physiology and the biology of the patient in front of us. And I like this slide because at the very center, it fits my talk today: prevent complications and optimize quality of life. And I think these guidelines have been showing that instead of one size fits all, we need to consider the patient in front of us within the context of what complications are they at risk for, and can we do more to specifically prevent that? So really, this raises the question, which of course I, and I'm sure many of you have thought of, how do we find success in diabetes care? What is it? And of course, it's very personal. It depends on the person in question, but it is largely quality of life. It's in the short-term prevention of diabetes-related emergencies and admissions to hospital. And in the long term, it's prevention of complications, which I'll speak more about here. It could be many other things, though, and we're learning from people with diabetes that what we call patient-related outcomes are really important. Quality of sleep, time and range, ability to go to work, care for family, do a job, etc. In this slide, I want to emphasize something that really relates, I think, from my own clinical experience, and I think from this field. The first consultation with someone, the first time we as clinicians see someone with diabetes for the first time, is the most important of all. And I want to emphasize here in this nice diagram some key questions that are very important to think about. I ask myself this every time: why has this particular person developed diabetes? Very often we're referred a patient with a diagnosis and a label already. And not uncommonly, that label is wrong. And it's very, very difficult to dislodge from that label once you start. So why has this particular person developed diabetes? What form of diabetes is it? And once we know that, what does that tell us about the risk for this person of developing complications? So right at the first consultation, we can learn a lot. And really the clinical question is, this would help us so much because the volume of diabetes in the clinic is so huge. Who is at higher risk for complications and who is at lower risk? So that's moving away from the one size fits all. This is really important because it allows us to focus clinical time and clinical effort and preventive approaches on those who are much more likely to progress. And equally importantly, we have the chance to reduce anxiety, reduce clinical time and burden, effort and cost in those who are less likely to progress. So that's the beginning of, if you like, precision prognosis, which you've already heard of from both Dr. Rich and Dr. Hebert. So learning how to do this in clinical practice is what I want to talk a little bit about today. And here is a slide that I think at least one of my previous speakers has shown. This is from that same consensus paper that we published last year in Diabetes Care and Diabetes Logia. And it lays out the field for precision prognostics, in other words, precision anticipation of complications, based on the kind of clinical environmental characteristics that we use now in clinical practice, but many of the new biomarkers and genetic markers that are coming on stream, and using algorithms to help us predict as accurately as we can who is at risk for the various complications. And that's really, really important and would transform practice from what we can do currently. So, sorry, let me go back. Apologies for that. What have I done here? Yeah, before we move on, I want to say we have learned so much already from the many clinical trials that have taken place in my career lifetime. I've listed them on the left, all these huge landmark trials that have told us so much that is still so important for 95% of what we do in clinical practice. Glucose control and all the measures for that, blood pressure control and all the measures related to that, control of lipids, monitoring renal function, urinary excretion, smoking cessation and screening. These are really important. And I want to say that at a meeting like this, it's really important to say, if we could only do this, what we already know about these risk factors, if we could do it well in clinical practice with all the challenges that face us, we would have such fantastic results. And I show you an example from the Steiner Diabetes Center, where I was the head of the center for a number of years recently. We published the results on the left of a decade of this approach in Steno, really applying this control, quality control, to all those standard risk factors, glucose, blood pressure, lipids, and so on. We could show in that decade, 2000 to 2011 it was, huge reductions in complications, cardiovascular disease, amputations, and retinopathy. And on the right side of the panel, over a 20-year period, a 90% reduction in blindness. I mean, this is hugely, hugely impressive with the measures we already have. So how would we be able to do better? Well, heterogeneity is the basis for how we could change our clinical practice, so that when we're presented with people with either type 1 or type 2 diabetes, there are many things that we can use. As you've already heard from previous speakers, age, including age of diagnosis, gender, ethnicity, obesity, body composition, nutrition, physical activity, genetics and risk scores, socioeconomic factors, hugely important. But in red, I've emphasized, which I want to say more about, the baseline physiology, the beta cell reserve and insulin resistance, which you heard Dr. Hebert just speak about in the context of pregnancy. I'll show these two slides about the clustering approaches published from Sweden, and thanks to Dr. Miriam Udler in Boston for allowing me to use these slides that she prepared. This was a fantastic landmark paper from Leaf group showing that just using GAD antibodies, age, body mass index, hemoglobin A1C, and measures of insulin secretion and insulin resistance, 5 subtypes of diabetes could be defined. And very importantly, in the context of what I'm saying today, that paper showed that being in one or of the other clusters made a big difference in a number of important progression risks. So the progression to insulin, quite obviously, the severe autoimmune diabetes group are most likely, or the severe insulin deficient group are much more likely to progress to insulin over time. People with severe insulin resistance were at much greater risk in the middle top panel to get chronic renal disease. So this is really important for subclassifying risk. So looking at those groups, the severe autoimmune, they're defined really by physiology. So the severe autoimmune one is very low insulin secretion and poor metabolic control. Severe insulin deficient diabetes, very low insulin secretion and poor metabolic control. Severe insulin resistance diabetes, insulin resistant and obese, and much more likely to get fatty liver, renal failure, and liver fibrosis. And very importantly here for clinical practice, there are 2 moderate groups as well. Imagine if we could know who these people were in our clinic today to reduce the anxiety and the time and burden of follow-up for people who are at lower risk and focus more accurately on those at higher risk. And this slide from Dr. Udler again is showing that in parallel or at the same time as those cluster-based, trait-based clusters, genetic clustering studies have shown similarly that there are subtypes of type 2 diabetes based on the available genetic markers that we have today. And these clusters, very interestingly, also relate to physiology. So 2 of those phenotypes that Dr. Udler published are related to defects in insulin secretion, beta cell and proinsulin. And 3 of the phenotypes are related to different forms of insulin resistance, either related to obesity, lipodystrophy, or the type of insulin resistance that accelerates to fatty liver disease. So this is really important, and the 2 clustering approaches are telling us very much the same type of thing. So as an interim conclusion to what I want to say today, what have these clustering studies taught us about the risk of complications? And what they've taught me is that the physiology, the underlying physiology of diabetes progression is key. And therefore, I think it would really help us in clinical practice, all of us who see diabetes patients, wherever we are, university centers, general hospitals, general practice, rural settings. It would help us now to know in the patient we see before us, what is their beta cell reserve? How much insulin secretion do they have left? And what is the degree of insulin resistance? And this is not something that we currently do. And just to show this, this is a separate study, but there are many examples of this coming up in recent literature. This is one, this ABC study is about predicting who does better among obese subjects, who does better, gets better outcomes from bariatric surgery. It's a little off the point, but nonetheless, look at the criteria. Age, younger subjects do better. BMI, the bigger, the better. C-peptide, really importantly, the higher the C-peptide, the better. And duration of diabetes, shorter is better. And for glycemia, lower A1C is better. It's a little bit like what Dr. Iver presented in the previous, in our previous talk about gestational diabetes. So here it is, those subjects who are in the earlier stages with more insulin secretion in reserve are likely to do better from this very radical therapy for diabetes. So how is this going to work in daily clinical practice? How do we implement this? Well, we're, as I said at the beginning, we're at the very early stages of implementing non-one-size-fits-all, but precision practice. Well, I think it involves a number of things, listening to the concerns of the person in front of us and explaining to that person their individual characteristics and risk. I find that very helpful in diabetes clinical practice, to explain to the person the underlying mechanisms of, say, type 2 diabetes, and doing as much as possible that we can do now to phenotype the individual. So that is, as you've already heard from previous speakers, confirming yes or no to GAD antibody and other antibody status, because that's a really key early one, and measuring insulin secretory reserve and insulin resistance, and using the biomarkers that are coming on stream, many of those you've heard about, and also genetic risk markers when they become available and genetic risk scores. All of these things will be helpful to us in the future. So the tools that we already have and we can use, the antibodies are fairly widely available, but we need to do much, much better about standardizing them and making them available internationally. C-peptide similarly is widely available, and it's useful even in the fasting state, but dynamic tests of C-peptide for insulin secretory reserve are even more helpful, as is measurement of insulin. And there are also online portals for calculating risk, which I'll show you in a second. So these are things that we currently have available, and they allow us to move beyond what we currently had into measuring underlying physiology of insulin secretion and insulin resistance. Here's an example of a risk engine. This one is from the Steno Diabetes Center, and it's for, I think, very, very useful for patients with type 1 diabetes who are in the middle. Say, take the classical patient who's 40 years of age who has diabetes for 15 years. It has been rather difficult clinically to predict risk of complications in such a person. And this type of risk engine is based on data from, here in the case of Steno Diabetes Center, based on data gathered in 5,000 diabetes patients over years and then validated in another database. And here's how it works. You're in the clinic, you can put in you can click in your information about age, diabetes duration, and so on, and you get on the right-hand side an estimation of risk of cardiovascular disease or kidney disease. Very useful in clinical practice. And similarly, you have the UK PDS risk engine for type 2 diabetes. So these are helpful in clinical practice to help more accurately predict risk and have a dialogue with the patient about what you want to do. So an interim conclusion here then is that subphenotyping using physiology is really, really helpful. It helps us to choose which agent we're going to use in treatment. And it's also a more physiological basis for how we advise people on lifestyle. It helps predict risk for complications, as I've shown, and it really helps for explaining all of this to the person in front of us with diabetes. So the future of precision medicine for diabetes complications as it's moving will be a combination of all of these things shown on this slide. And I start first with psychosocial, demographic, and all those social determinants, very important. The ordinary ABC clinical status that I said, if we could do that now widely, we would have huge results anyway. And then measures like proteomics, metabolomics, and genetic risk scores, and then very, very sophisticated computer algorithms to predict risk for this individual patient. So in summary, I think the precision medicine era has arrived for diabetes, and it's wonderful. It's really going to allow us to really move into translational diabetes practice. I want to emphasize that I think environment, social and psychological variants are still huge and very important confounders for all of this, for everything that I said. However, I do think precision prediction and prevention of complications is about much more than just glucose, blood pressure, and the other general risk factors. If we can measure insulin secretion and insulin resistance, they're key to risk progression. That's what the science has shown us. And my final slide, I want to acknowledge the great support of the others on the executive group of the American Diabetes Association Precision Medicine executive, Steve Rich, who you've seen, Paul Franks and Lou Phillips, and others who have joined since for helping to drive this forward. Last but not least, don't forget you can look at our Precision Diabetes 2021 website, where all those talks are freely available from the meeting we held in April this year, where Dr. Mohan was one of the distinguished speakers. So thank you very much for the opportunity to contribute.
Thank you, Dr. Nolan. That was a very, very nice overview, and I'm sure there'll be a lot of questions after we when we take up the questions. Let me now move on to the fourth presentation in this symposium. We'll split this into two parts. So I'll give the first half of my talk, and then my colleague, Dr. Radha Venkateshan, our head of genomics, will give the second part of the talk. Can I have the next slide, please? I have no conflict of interest to declare. These are funded by both the Indian Council of Medical Research as well as the NIHR in the UK. Next slide. So this is the how I'm going to structure this talk. The first part of it, the clustering of diabetes, which is something which I spoke about at the PDMI conference, and therefore I'll shorten it and I'll just talk for 10 minutes about that. And then Dr. Radha will take over and present to you some actually new data that we have on monogenic diabetes, MODY, neonatal diabetes, and congenital hyperinsulinism, because as you may know, we are the National Center for Monogenic Diabetes testing for the country. Next slide, please. So when you talk about type 2 diabetes, this has already been introduced by Professor Nolan, and so I'm not going to spend time on this except to say that this fantastic paper really opened our eyes. We all knew that type 2 diabetes is not one disease, but it was the careful work done by Leaf Group and colleagues from Scandinavia, which was able to bucket type 2 diabetes into different subtypes, the SID and the SAID and the MOD and the MARD, which was presented by, and the SIRD, which was presented by Professor Nolan. So our question was, of course, many populations tried to see whether it is replicable in their own population. And we were particularly interested in trying to replicate this for several reasons, that we believe that South Asians are quite different from the Europeans as far as type 2 diabetes is concerned in many ways. First of all, we get the disease 10 to 20 years earlier than what you see in the white population in Europe. And so when you talk about MARD, for example, mild age-related diabetes, when you're getting the whole disease 20 years younger, we get our MARD also 20 years younger. In fact, we get our MARD at the age when the other groups are present in Europe. So it completely kind of, then our waist circumference, our BMI, we have lean type 2 diabetic patients, we have a lot of normal body weight type 2 diabetic patients. So the whole situation is so different that we thought that we should try to classify this in our own population and see whether it works. Next slide. Next slide. So this is some of the reasons why we wanted to do this is because of all these characteristics of what we call as a South Asian phenotype or the Indian phenotype, the lower age at onset I already mentioned, the lower BMI threshold for type 2 diabetes, increased insulin levels and insulin resistance, which has been described by many, many groups, a rapid decline in beta cell function. This is something which we have been working on for some time, and my colleagues at Emory University with whom we collaborate, Professor Venkat Narayan and colleagues, and Dr. Alka Kanai's group in California, and many other groups we have joined together, and of course the group from the UK have shown that South Asians seem to progress very rapidly from pre-diabetes to diabetes, even from the stage of normal glucose tolerance, pre-diabetes to diabetes. And this seems to be due to a rapid loss of beta cell function. For some reason, we've not quite got a handle on that, but it's definitely a fact. But one of the most characteristic features, when I've sat in a clinic and I've worked at the Hammersmith Hospital for a year, and then coming back to India and looking at the HDL levels in our population, if you actually mixed up all the HDL values of, say, South Asians and white Europeans and didn't give me the name and just gave me the HDL values, I'd be able to pick out with reasonable accuracy, just based on the HDL values, who is an Indian or South Asian and who is a white European, because it's very rare to find a normal HDL in our population. Again, is it genetic? Is it due to the high carbohydrate diet that we take? Is it because of less exercise? Is it the phenotype is like that? We just don't know. We've been doing a lot of genetic studies, but we really haven't hit that. Along with that comes a high triglyceride. There are many others which I won't go into, like low adiponectin levels, a higher HSCRP level, the C-reactive protein, low muscle mass, more abdominal obesity and more visceral fat, and the low birth weight, the thin fat Indian. Even at birth, my colleague Dr. Yajnik from Pune has shown that a newborn baby born in India is very different from a newborn baby whom he collaborated with in the group in Southampton. And he showed that we had much more fat and higher insulin levels even on the day of birth. So there seems to be something, that's why we call it a thin fat Indian. And the gut microbiota, we've recently published our data on gut microbiota comparing the Danish population, Olaf Peterson, Tobin Hansen, and our group, and we have found that the gut microbiota is completely different. Again, just like the HDL, if you gave me the gut microbiome of an Indian and a Danish person just by looking at the gut microbiome. There's not even a point where they overlap. The Indians are there and the Danish are there. So they're completely different. So with all these differences, we thought that we should look at type 2 diabetes clustering and see whether it's the same as what is seen in Europe or not. Next slide. So this is a collaborative study between our center in Chennai and the University of Dundee in Scotland with Ewan Pearson and Colin Palmer and their group. And this is called as the INSPIRED study. INSPIRED stands for India-Scotland Partnership for Precision Medicine in Diabetes and is funded by the NIHR in the UK. Next slide. So that's the paper published in BMJ Open Diabetes. Next slide. So where did we take our population from? You might know that we have centers in most parts of the country now. We have in our electronic records, we have over 500,000 registered patients. That's about 500,000 diabetic patients in our private centers. All these centers are owned by us. They're not franchisees. So we actually have control on all the records. And we are now present in 8 states of India and 32 cities of India. So from this records, electronic record, and from day one, we've had electronic records. So from this database, we selected using very similar inclusion criteria as the Scandinavian population, about 20,000 individuals with type 2 diabetes with less than 5 years duration at the time of the first visit to the clinic, and they were included in the analysis. Next slide. So we use the following criteria. I'm not showing you the whole paper, but because I'm only restricting my talk to 10 minutes, but we initially used the very same variables which Leaf Group and colleagues had used. And we found, as reported in that paper, that we were not able to reproduce that. In fact, out of the 5 subtypes that they had, we had eliminated one straight away because the one with the GAD antibody positive, the SAID group, we thought it's really not a typical type 2 diabetes that we see. It's more aligned with type 1. So we were not interested in that. But looking at the other 4 subtypes, 2 of them we were able to reproduce in our population, the SID and the MOD. But the other 2, the SERD and the MOD variety, the one without insulin resistance, we were not able to replicate in our population. So having done that, we said, okay, probably because we're using the wrong variables. The most striking of them is HDL. So we said, why don't we put in the HDL? So we put in the HDL and triglycerides, and these 4 were the same as what Leaf Group used. I'm very glad that Professor Nolan mentioned the fasting and stimulated C-peptide. I don't know whether you're aware, Professor Nolan, that in virtually every patient who comes to our center, we have data on C-peptide, both fasting and stimulated. The stimulated is after a standard carbohydrate load, which is given for breakfast, and a 90-minute sample. This was kind of standardized 20, 30 years ago, and we've used this in all our publications, a standardized stimulated C-peptide and a fasting. And we have this in something like 150 to 180,000 diabetic patients, and many of them over a period of time. And of course, every young person who comes to us with onset below 30 years of age, we do a C-peptide and the antibody testing compulsorily for every patient who's diagnosed below 30 years of age. Next slide. Excuse me. So to cut a long story short, this is the 4 subtypes that we found. As I said, the SID variety was the same as what Leaf Group and colleagues described. And the MOD variety was also similar, although not identical. As I'll show you, they are much younger, at least 15 to 20 years younger than the Scandinavian group. But then we had 2 new subtypes. One is called as the insulin-resistant obese diabetic, or the IROD. And this is very different from the SIRD, which they had described. And the paper gives all the details. I'm not going to go into it. But what was most interesting, and I was very interested to see the slide by Dr. Hayward showing the combined defect for the GDM. And that's exactly what we found in our type 2 diabetic patient, that a group of our patients had the combined insulin resistant and SID variety. And this has not been described in many other populations. So now 2 of our groups have insulin deficiency, both the SID variety as well as the SERD variety. And that, I think, underscores the point I had made earlier, that insulin deficiency is very common in our thin type 2 diabetic patients. So here we have the combined insulin resistance and the deficient variety. Next slide. Now, if you look at the clinical characteristics of this cluster, I had mentioned the HDL and the triglycerides being very high and the low HDL. Now look at the HDL in all the 4 groups. These are, of course, in milligrams per deciliter, but 40, 38, 36, and 42, you may not even see such HDL concentrations in the white European population, where if you see in milligrams, it usually be 50, 55, 60. We very rarely get 50 or 60 in anyone in our population, unless there is some genetic variation. And then, of course, they can have 80 or 90, but that's like 1 in 1,000 people. The average of the HDL concentration is very, very low. But within this, the third variety, the new variety which we had seen and which we said was not seen in other populations, in fact, had the lowest HDL concentration. And more importantly, if you look at the triglycerides were high in, by relatively speaking, the triglyceride levels were high in all the 3 groups. But look at the triglyceride levels in the third variety. It is 351, almost double that of the other 3 groups. So this unique subtype is not only unique in many ways, we didn't find it in other populations, but also within this group, it seems to have the typical South Asian kind of phenotype with the lowest HDL and the highest triglycerides. Of course, we corroborated by looking at the C-peptide and the HOMA beta and the HOMA IR, and they all fit like a fit to the T, because you can see that the lowest fasting and stimulated C-peptide was in the insulin deficient variety. The highest was in the IROD variety, and of course, the third variety was in between. And similarly, for the HOMA beta and HOMA IR, which we did not use in this particular calculation, but in the first iterations, when we used the Scandinavian model, we used it just for testing to see whether it's true, and it holds true in our population. Next slide. Subsequently, since we had used a clinic-based population, and ours is a private clinic, there could be socioeconomic bias or referral bias in the samples which we had tested at our clinic, and therefore one may argue that this is not representative of India. Luckily for us, we are involved in a very large nationally representative study called as the ICMR India Diabetes Study, and we are just on the threshold of completing the whole study, all the 30 states in India, with a sample size of over 113,000 people. The data collection is over. We published a few papers from that when we were at the halfway stage, but now we have come to the stage where we have a representative sample of the entire country, representative of India's 1.3 billion people. Now, from this, we selected individuals with newly diagnosed diabetes, whom we had detected during the epidemiological study. And then we tried to see whether we can replicate the findings that we had in our clinic population in this nationally representative population. Now, when we did that, of course, we didn't have C-peptide in the entire population. It's too expensive to do that in a large population-based study. So what we did was we said, let's leave out the C-peptide, but we'll use the HDL, triglyceride, and the other factors. So we now have only 6 variables which are used. And we said, let's see whether in this new cohort, we are able to replicate it. Excuse me, next slide. So as you can see, this is the India population now. And you can see that the exact 4 types, the SID, the IROD, the SERD, and the MARD, were seen there. If I can draw your attention to the HDL cholesterol, to which I had alluded earlier, you can see that the HDLs were even lower in the Indian population, because this includes the rural population as well. So very low HDLs. And this is all done in the same lab, by the way. The entire Indian study was done in our lab in Chennai. So it's the same lab. And you can see, again, the SERD had the lowest HDL cholesterol and by far the highest triglycerides, again double of that of the other groups. So this group seems to be somewhat special to our population, and this one as well. Next slide. So now the 2 questions which I think Professor Nolan also alluded to, do these have any reflection on the propensity to develop complications, susceptibility to complications? As you would remember, if you have read the Alquist and the Leaf group paper, what they showed was that if you are insulin deficient, those types are more prone to develop retinopathy and neuropathy, whereas if you have insulin resistance, you're more prone to develop fatty liver, kidney disease, chronic kidney disease, and cardiovascular disease. We did not have data on cardiovascular disease, but we had the data on retinopathy, nephropathy, and CKD. And I'm happy to state that we were able to replicate those findings. If you can give the next Next slide, just press. Okay, so you can see that the SID variety is more prone to retinopathy, whereas the resistant variety was not. But again, we had a surprising finding that the SERD variety, because they had insulin deficiency included in that, they were, next press, they were also prone to retinopathy. So this group is special that it is also prone to retinopathy because they have insulin deficiency. Couple of more presses, please. One more. And if you look at chronic kidney disease, the SID variety is not more prone to kidney disease. However, the insulin resistant variety is more prone. And this is very similar to the Scandinavian data. However, again, we were in for another surprise that the SERD variety, next slide, actually had the highest, go back one slide. The SERD variety had the highest proneness to develop chronic kidney disease, and this therefore is a very special group because they are more prone to develop both retinopathy and nephropathy, and not surprisingly because they have two defects and they seem to be prone to both these complications. And that was a novel finding from our study. Next slide. And finally, we looked at, is there any difference in the achievement of the HbA1c goal of less than 7%. Not surprisingly, the most difficult to control was the SID variety. Because remember, these are patients with type 2 diabetes. And at the time of treatment, we didn't know whether they had SID or SERD. We just treated them in a one-size-fits-all. So there was a question in the box, why are you talking about such sophisticated things when in rural India they don't even have insulin, they don't even have tablets? Why are you talking about genomics? Well, this is not based on genomics, it's based on very simple clinical characteristics. And because we treated in a one-size-fits-all manner, because we had done the clustering retrospectively, we treated all these patients who were insulin deficient with metformin, and they didn't do as well. Whereas the MARD variety, who had the mildest form of diabetes, responded best. And guess who did not respond as well to the metformin? It was the SERD variety, because that was very close to the SID variety, and that's because they had insulin deficiency in addition to insulin resistance. So these two groups would have needed a different form of treatment. Right now, we are doing RC and RCT to see to subclassify them prospectively and to see who responds better to which anti-diabetic drug, whether to a secretagogue or to a sensitizer or to both. Next slide. So I'm going to stop here. So that's about the precision type 2 diabetes and the clustering. And now we have some exciting data to share with you, and over to Dr. Radha to talk about our work on monogenic diabetes and precision diabetes in India. Radha?
Thank you, Dr. Mohan, for this wonderful prelude to the topic of precision diabetes in India, highlighting where we are with respect to type 2 diabetes. And now I'm going to talk about monogenic diabetes and congenital hyperinsulinism, which is also monogenic, although it's exactly opposite. Next. This monogenic diabetes actually is caused by single gene defect that strongly contributes to the disease phenotype, without or not much environmental contribution. And as you may be aware that in each individual DNA, mutation has a high or a complete penetrance. And we have three types. One is the maturity onset diabetes in the young or the MODY, where it's a single gene defect. Again, it's autosomal dominant in inheritance, seen as in a family history of diabetes in multiple generations. And there is an early onset at age less than 35 years and controllable without insulin for 2 years and progressive beta cell dysfunction. The neonatal diabetes mellitus has been defined as an auto-antibody negative insulin-sensitive hyperglycemia that's diagnosed within the first 6 to 9 months of life. Whereas the congenital hyperinsulinism is exactly opposite of neonatal diabetes. It is abnormally high levels of insulin that is there, and that leads to severe hypoglycemia in infants. Next. So we know that the gene mutation causes the defect or disease phenotype in monogenic diabetes. Using genetic information, we can understand the cause of monogenic diabetes as well. But can we tailor treatment to the cause? To that question, the answer is an emphatic yes, we can, with respect to monogenic diabetes. So we have a large number of single gene processes. We know how to detect them. We also know how to interpret them. So that has made us move from lab to the clinic, that is from bench to bedside, and that is really the translational genomics. And at this juncture, it's very important that we ask these questions. Are we diagnosing everyone with monogenic diabetes? Talking about accuracy. Are we diagnosing people at the earliest opportunity? Talking about being timely. Are we reporting the genetic data appropriately? The correct interpretation. Are we applying the findings of genetic data in treating patients? That is translation. And finally, are we following up with the patients to understand the progression of the disease and fine-tuning the treatment course? That talks about the sustainability of the treatment and prognosis, and that is precision medicine. Next. So tailoring treatment to suit gene mutation is precision diabetes. Actually, this is heavily determined not just by the gene, but also by the specific variants in a gene. Not all variants are really pathogenic, and not all variants are clinically actionable. So it's very important to assess which are the ones that are clinically actionable with respect to MODY, NDM, and CHI. So this is being done based on the ACMG and AMP guidelines of C.U. Richards. And now a lot of previously classified variants have been reclassified according to this framework. And according to this framework, there are about 5 types of variants are divided: the pathogenic, likely pathogenic, the variant of unknown significance, that is a gray area which needs to be characterized, and likely benign and benign. Next. So with that, we have moved now from clinical subtypes to genetic subtypes. As can be seen in this slide, in the case of the MODY, we have a number of subtypes, there are about 13, and some of them really do not fit into that classification. But then we have the HNF4 alpha, 1 alpha, HNF1 beta, and GCK. They have very specific clinical features, distinct features, and the treatment also response is also very distinct and different. So both HNF1 alpha and 4 alpha are low dose sulfonylurea sensitive, whereas the GCK just does not require any medication. Diet and exercise is enough. And people harboring mutations in HNF1 beta, they need insulin. But looking at NDM, the KATP channels are the most important ones. Of course, we do have other genes that are also coming up, panels of genes. But then the KATP channel seems to be very important here. And then the clinical features are very severe, and they respond to high dose sulfonylurea only. While the CHI, which is exactly the opposite of NDM, there also the main subtype, the genetic subtype is the KATP channel. And again, the clinical features are very severe, and they either respond to diazoxide or octreotide, or some of them require subtotal pancreatectomy or even near total pancreatectomy. So if you look at it, and each of these genes is etiological. So obviously and automatically, we are defining etiological subgroups here. And this is very well captured by genetic detection or testing. Next. In the case of MODY, we have diagnostics, we have prognostics, we have clinical features, and finally, we also have treatment options. So this is a very clear example of precision medicine. And I'm just going to show you 2 slides. One is where we have all of these are what has been captured in our patients in our laboratory, molecular genetics laboratory in Madras Diabetes Research Foundation. GCK people with patients with GCK mutations, three GCK mutations in 4 patients. You can clearly see that they are just on diet and exercise, and they do not require treatment. And then over a period of year, we have followed up their HbA1c, and we find, you can see the trajectory here. And you can also see that there is a particular mutation, lysine 32 deletion, that deletion, and 2 patients have it, and they have almost the similar kind of a trajectory, whereas the others are a little different, but all of them showing a down curve. Next. While GCK does not have any treatment, does not require any treatment, the KCNJ11 MODY, which is also red, that requires treatment, and that requires a low dose sulfonylurea. So if you look at the graph on the left, We have initially taken initially the patient were on metformin, and then the red dotted line indicates the time at which we detected the genetic detection, and then there is a change in treatment that was given, that is the complete low dose sulfonylurea and stopping metformin. And over a period of 4 years, we followed up and look at the trajectory here. The fasting and the postprandial blood sugars have controlled and show a good glycemic control. And also the HbA1c here is very well controlled, very well within the range, good range. So that is really a good example. Modi is good example of precision diabetes. If we say this is a good example of precision diabetes, the poster child of precision diabetes is neonatal diabetes. Next. Next. So again, these are our patients, that are our NDM patients. I have classified into KCNJ11 mutation and ABCC8 mutation. So I'm just showing the 4-year follow-up. About 5 years we have followed up. The first time is the detection time, and then 4 years of follow-up of their blood glucose level. And all these patients have different mutations, and there are about 3 of them who have an arginine 201 cysteine mutation itself. And you can see that there is a drastic improvement when there is insulin. The treatment was shifted from insulin to high dose sulfonylurea. And then the most beautiful thing is that as we follow, they are able to sustain that level. And that is very important with respect to precision treatment and also in precision medicine. Next. So this is with respect to something similar is also seen with respect to the ABCC8 variant here. Next. So I'm just going to say, show this nucleotide change in the same amino acid, as I said, that the arginine and histidine, arginine 201 histidine and arginine 201 cysteine. So here it shows that the gene mutation drives response to treatment of drugs. And this is actually exemplified here. Next. 5 different NDM patients with KCNJ11 gene variant, the same variant, but then they show similar response to SU therapy. Next. And then 6 different, patients with the same mutation, arginine 201 histidine, that is also the same amino acid, showing similar kind of response to therapy. And this also shows that this particular amino acid residue is a hotspot of mutation. And that we are able to show. And we know very clearly that this really dictates the clinical phenotype. Next. So the precision medicine in CHI is much more complex than NDM because there are levels of classification here that is based on drug response, based on the genetic inheritance, whether paternal or maternal, and also based on the histology, whether it's focal or diffuse. Next. So I'm just showing you the trajectory. This is exactly opposite because initially they were less than 40 or 50 milligram per deciliter of blood glucose and they are hypoglycemic. And then we have currently been following for the past 2 years. And these are all the mutations that we saw in the patient. I'm only, in the interest of time, I'm showing only the mutations who have responded very well to it. And then we are able to clearly see that there is an increase in the blood glucose level and there is a sustaining of that increase. Next. That is next. We also see the same thing with respect to KCNJ11 and also in the case of focal. Next. Next slide. So this is the KATP mutation spectrum that we have seen and the clinical presentation, which correlates very well with the nature of the mutation itself. So as you can see that, in the same 2 genes, that is the KCNJ11 and ABCC8, if you look at it, the same gene, one presents the gain of function mutation leading to NDM, and then the other one is the loss of function mutation leading to congenital hyperinsulinemia. And there is a spectrum of mutation where starting from severity to less severe ones, And accordingly, correspondingly, there is very clearly, you can see the clinical presentation as well. For example, if you look at the DEND, the V64M, that is one of the very severe mutations that we have seen. And I mean, in fact, throughout the world, even Andrew Hattersley, and they have all seen the same thing. So that is clearly a DEND where there is also a seizure seen. But the IDEND, which is where there is no seizure, that's slightly less severe. And then the PNDM and TNDM, Moody. So there are some specific mutations for these specific subtypes of clinical, specific clinical subtypes. With respect to the loss of function, that is the CHI mutations, there is, I've just divided it into diazoxide responsive and unresponsive for simplicity's sake. And certain mutations clearly cause diazoxide responsiveness and certain mutations cause unresponsiveness. We do not know why, and we are all working on it and hope there will be some light maybe in a couple of years from now. Next. So what we do is we use a whole gamut of analysis to deliver on precision medicine. I'm just going to show one example of what we have started doing now. Next, where we have shown the genetics. That is, we have identified a novel mutation in HNF1 alpha mode mutation, that is a R263H mutation. And we have shown co-segregation of this mutation in the family, that's on the maternal side. And next. So this is, we went ahead to evaluate the pathogenicity with the help of structural biology work as well as our functional characterization that clearly showed a reduced expression in the case of this mutation. Next. And then applying the ACMG guidelines, we came up with the fact that this was a pathogenic variant. And finally, next, as an in vivo proof, we followed up the patient and the family, and very clearly, as they were originally on insulin, and then when we shifted them completely to low dose sulfonylurea, you can see the trajectories, and we've been following up this patient for more than 4 years, and you can see the HbA1c lowering as well as the fasting and postprandial glycemia being lowered and coming into a control level. Next. So what does it all do? That clearly tells you that molecular genetics has arrived and it has come to diabetes clinic. So genomics is truly in the driver's seat for precision medicine. Next. So therefore, what I would like to submit is the genetic testing defines rather than just confirms the clinical diagnosis. And the aim of genomic studies to deliver on precision diabetes is a reality today. Next. So I would like to thank ICMR, which has supported me with various projects. And we were able to get samples from pediatricians and neonatologists throughout India. And next. Next. So this is the diabetic monogenic and CHI registry that we have formed. And through this, the patients and the clinicians, they register their patients and then they send the blood samples to us. And we do the genetic workup completely free of cost. And finally, next. This is the wonderful set of colleagues that I'm working with. So we are in the molecular genetics department of Madras Diabetes Research Foundation. Thank you very much for your attention.
Thank you, Radha. Can stop sharing the slides now. So after that, after those 4 presentations, I think we'll now open up the floor for questions and answers. We do have some questions from the floor, and I know that Professor Rich has answered 1 or 2 of them in the chat box, but others may not have seen them. So let me repeat that question, which has been asked to Dr. Rich. Will you give teplizumab to a sibling with type 1 diabetes? And how do you decide, in other words, who to give this to prevent diabetes, type 1 diabetes?
Yes, that's an interesting question, because that's certainly the teplizumab is, actually Kevin Harold has been working on that for the last 25, 30 years, I think, anti-CD3. And TrialNet, in its paper that I mentioned from Emily Sims, it's clearly shown efficacy, but these are individuals in TrialNet that are 2 types, really. One is that they're recent onset type 1s, and trying to see if they can maintain a honeymoon period, but also high risk siblings of individuals with type 1 diabetes where they have 2 or more autoantibodies. At least two of 4 islet autoantibodies. So as I mentioned in the response to chat, if you just take a sibling of someone with type 1 diabetes, the risk of their developing type 1 diabetes is about 8% in European ancestry populations. I'm not certain what it is in all populations. When you start adding additional information, such as the genetic risk of HLA, which again, high genetic risk greatly increases the odds of developing type 1 diabetes, and 2 or more autoantibodies, you're getting essentially 85% chance of that person converting to type 1 diabetes within the next 5 to 8 years. So just being a sibling at 8% to having autoantibodies and a high genetic risk to 85% really weights my decision into more of, if the person has a high genetic risk and autoantibodies, then that's the person you want to put into the tocilizumab trials.
Absolutely, makes absolutely good sense. The other question is about the role of the type 1 genetic risk score. Well, as Radha has presented, I think the screening for monogenic diabetes become pretty routine now. So if you suspect MODY or neonatal diabetes, CHI, the screening for that. But for type 2 diabetes, for type 1 diabetes, we normally do the C-peptide and the antibodies. Beyond that, what is the role of the genetic risk score? Because we're also just setting it up. Andrew Hattersley has been the Exeter group has been pushing us to put that also into our armamentarium so that we complete the genetic testing at our center. So we're just about to set it up. So what is your take on the type 1 genetic risk score in precision medicine?
Well, perhaps I can start with type 1 diabetes and let others comment on maybe a risk score for gestational or for complications or type 2. For me, it's fairly straightforward in that you take a blood sample, you extract DNA, and that's one test, and you have an evaluation of genetic risk score. And if you actually have whole genome sequencing, you don't have to do anything else, which is one of the limitations of designing a genetic risk score test based upon, say, 80 SNPs or 100 SNPs or 150 or 600, whatever number. A whole genome sequence is your genome. So in a sense, you don't have to do anything else. For monogenic diabetes, as was noted in the last talk, these are primarily fully penetrant mutations. And so if they have the mutation and it's basically leading to 100% risk assessment. For type 2 diabetes, even though we may know 90% of the genetic basis, it's 90% of about 50%. So that's about 45% of the overall risk. And so that suggests that it can be used in context with other clinical features such as the autoantibodies or C-peptides or whatever. But I would not say that alone is what will be driving assessment. And I'll stop there.
Thank you. Let me go to Dr. Hebert. So you've very nicely shown the GDM, how that precision diabetes is evolving. So there's a question here that the pregnancy cluster that you showed does not seem to include the HKDC gene, which seems to have evolved. You yourself showed that in one of your earlier slides. And how come that the pregnancy cluster did not pick up that gene? And the second thing is, do you think genetic screening for GDM is worthwhile? And the reason I asked that is, you showed that 8% of the European population is prone to GDM. You might be surprised, or you might know that in our country, if you take my city, of all pregnant women, about 25 to 30% have GDM. So it's like 3 to 4 times higher than yours. So that straight away brings up one aspect of precision medicine. Why is that we are so much more prone to GDM? And that opens up a wonderful collaboration. We'll be very, very happy to collaborate. We have done some genetic study. We also found the HKDC gene, but we're not able to pin down one gene. And for example, TCF7L2, which is strongly, as you said, strongly positive for type 2, did not come as very strongly positive when you look at GDM. So how would you respond to that, to these questions?
Yeah, thank you. I'll start with the first one about HKDC1. So the clustering analysis that we did based on both the genetic loci and the pregnancy trait, we had to go with the majority of those loci are type 2 diabetes known loci, because there's very few that are known pregnancy specific. And HKDC1 is the exception. And because the algorithm is based on clustering, the HKDC1 did not emerge from the top variant driving those cluster, maybe because it's unique and it's not clustering much with the other type 2 diabetes variants. And so that's our hypothesis of why it didn't emerge in one of the main cluster. But it is a self-clustering, and if we would look down, HKDC1 comes in some of those clusters. It's just not one of the major driver.
Okay. There's another question on the, sorry, somebody's asked. There's
on the genetic.
Go ahead, sorry.
On the genetic testing and on the difference in between ethnicity, we know very well that Asian descent are at much higher risk of GDM, and the numbers that you're telling me are not surprising. And we need to do more studies, both to phenotype more refinedly and genotype diverse ancestry to better understand the pathophysiology and the different type of GDM. And it might be that there's different type of GDM in different subgroup in the world. And so I would be very, very interested in pursuing collaborations to know more about that.
Just this afternoon, we had a talk by Professor David Simmons from Australia, and he was talking on the subject of early GDM, which is his Norman Frankel lecture at the ADA also. And he was talking about early GDM. And this is something which we see so commonly here. First trimester, you go and screen, and the A1Cs are normal. So it's not pre-existing diabetes which is coming, but we don't even know what it is. And one of my PhD students is working on that. Hannah is working on that. So hopefully we will get some information on that. But these are all potential areas that I see for collaboration. One more question to you, Dr. Hayward, and then I'll talk to Dr. Nolan. The role of adipose tissue in regulating fetal growth in gestational diabetes. That's come from the audience.
Yeah, so briefly, I'm not sure if it's about the adipose tissue from the mother, that the question, but we've done some investigation in looking at adipokines and how adipokines may predict GDM, and our group and other groups have shown, let's say, that low adiponectin in the first trimester already is an independent predictor of who will develop GDM, and adiponectin is a kind of a marker of how healthy your adipocytes are. And so people who have high insulin resistance and adipocytes that are unable to deal with the higher lipids circulating usually show lower adiponectin. So there's some investigation in that framework, but it's still, again, an area of future research.
Thank you. Radha, you have comment.
I have one question to ask you. So when you're talking about HK deficit, that is that hexokinase. So what about glucokinase gene? Have you seen any association of glucokinase with gestational diabetes mellitus?
We saw with glucokinase receptor with higher glucose in pregnancy. And the candidate, when they looked at candidate gene, I think some groups have seen it, but have to double check on that. This is not emerging in our GWAS currently, and it might be, again, because we're underpowered compared to other sample size.
Yeah, because this is also a kinase, isn't it? Like the HKDC. So I was just wondering whether there is any role.
Thank you. Now let me go to Dr. Nolan. Dr. Nolan, the question I want to ask you is, with respect to complications, we have so far been talking about the classification and the subtypes of diabetes. Now, if you take any complication, take type 1 diabetes, take type 2 diabetes, there are people who simply don't develop complications. And we have got a large series of such people. In fact, we just honored our longest surviving type 1 patient because of the centenary of insulin, and the people have lived for 74 years with type 1 and close. They're now 88 years old and they have no complications. And similarly for type 2, there are people who have got diabetes when they're 40 and they have crossed 100 years of age and they're doing fine. I mean, 60 years and no complications. Same time, we have people who less than 5-10 years, and I mean, one may argue and say, no, maybe they had it for 30 years, but they're only 25 years old or 30 years old. So they could not have had it for longer than that. So, I mean, how can you explain this? It's not just A1C. I mean, their A1Cs are very similar. If you take both, there's no difference at all. And obviously duration is not giving the answer. So what do you think could be the reason why some people don't seem to get complications and others get? And is there any way to forecast that in the future?
The short answer is no. I mean, this is a thing that all clinicians, I know you're speaking from the heart there, and I know it very well too. And it's a miracle that some people seem to escape. And my feeling has always been, and I don't think there's been good proof yet, that some people are genetically protected in some way. This is the most likely thing, you know, because you've already said the standard things. Some of the people who escape complications are very poorly behaved.
Very, very poorly behaved.
They're traveling with poorly controlled glucose and other risk factors as well. So, I mean, I know there are several groups looking at that kind of thing. One person in my time in Steno, Valery Lesenko, who came from Life Group's group and who's now in Norway, I think, has a fairly large study. One of the sources is from Ukraine, where they have two matched sets of duration, and yes, complications are no. So there are people looking at that. I think the search is for genetic protection, but I honestly can't comment further. And my whole thing about physiology and insulin secretion, insulin resistance, I don't think is a player here either, as far as I know.
We had this paper in Diabetologia recently where they looked at the Jocelyn medalist cohort and the golden cohort, and they were talking of some unique biochemical features related to pyruvate kinase, M2, and all kinds of biochemical thing, age, and some of those they're suggesting they could have some peculiarities in that biochemistry which is protecting them. As you rightly said, and Dr. Rich would be interested in this, out of the 8 people who had crossed 60 years type 1 diabetes, whom we gave a medal, in fact, there's a medal in my name, which we have instituted like the Jocelyn medal, which just 10 days ago, we gave it to these people. All the 8, I spoke to them in detail. And for the first 10 years, they were taking 1 insulin a day. And we talk about the legacy effect and the first 10 years being important. One of them was taking 1 short-acting insulin per day. I don't even know how they survived with that. And then, of course, after 10, 20 years, they went to 2 injections a day. And now they are on like 3 injections a day after 40, 50 years. So where is the legacy effect here? Where is the DCCT and where is UKPDS and everything thrown out of gear by these people? These are people who have survived. Whereas many others who have tried so hard have fallen along the way. So, I mean, as a clinician, what can I do to help these guys? You know, so this is something which Dr. Rich, would you like to respond to that?
Yeah, just very quickly, you know, and the Jocelyn medalists, I remember George King sharing data with me at different points, and remarkably, they had extraordinarily high HDLs, and it really looked like these were healthy people, and so you know, the recent there's a recent study coming out, maybe in Jason. Based upon the JDRF Diabetic Nephropathy Collaborative Research Initiative that member of the Jocelyn, Andrei Korleski, and a member of our group, Joe Mikuleski, have published, where they've identified from the Jocelyn, of course, other sites, that about 40% of people with type 1 diabetes will just have eGFRs just flat. You know, they'll never get kidney disease. Then there's about another 40% that have a very slow decline. So if they live to be 125 years, they'll get kidney disease. And then there's about 10% that just drop off a cliff, like within a year. And they've identified a couple of genes that seem to distinguish those that drop off cliffs from those that have slow decline or no decline. So this may be part of the reason, but it's very complicated. And I think a lot of times it's what the physiology is that doesn't really allow, you know, maintaining appropriate control.
There's a question for you, Dr. Ebert, about the cardiovascular consequences of GDM. Do you subscribe to that? They not only get diabetes, but also get cardiovascular disease? And is there a subtype within that who don't? I'm sure there must be.
Yeah, I think so. The first part of the question is, we know that women with GDM are at higher risk for cardiovascular disease over their life course. It is probably mostly from the increased risk of type 2 diabetes, but there's also some data showing that even independent of type 2 diabetes, there is some women who will have higher risk of CVD. And I think the data on the offspring is still to be seen, because we don't have follow-up on the offspring of most recent cohort of GDM that is well phenotype. I think our strongest, most robust data comes from the HAPO study, and they followed up their offspring between like 11 to 14 years of age, and already see impaired glucose tolerance, but it's a little early for other markers of diabetes and cardiovascular disease. And then for the subtypes, I think because we're just starting to subphenotype or use different categories of this heterogeneous condition, it remains to be seen and tested, but we are very interested in that as well. And we did our follow-up at 5 years in the Gen 3G cohort. Our numbers are a little small to really see long-term complications, but we'll look into it.
Thank you. I think we are a little behind time now, so probably wind up by thanking all the speakers, Dr. Rich, Dr. Nolan, Dr. Hewart, Dr. Radha, for excellent presentations. We hope that sometime in the future we can have a bigger meeting on precision diabetes. There's so much to discuss that if you are all willing for that, we'll probably have some time in the future, a larger meeting with the more time allotted, where many more of these questions. But one thing we'd like to offer is that not just because Me Too research and we also have to do it, but because we truly believe that there are huge differences. I mean, 8% GDM there and 25% GDM. Not that we're all obese, and we're not that at all. It's still, we don't explain why we are so much prone to type 2 diabetes at younger age and GDM and so on. So I think there is a fertile field for research, and in precision medicine, if there is something that we can collaborate on, type 1, type 2, GDM, complications, you name it, we have this large database, 500,000 patients. So we would be very, very happy, but I'll take that offline with all of you all. So on that note, I'd like to once again thank all of you for brilliant presentations. I think the first time in India that we've had a real symposium on precision diabetes, and I'm sure you've whetted the appetite of many of the delegates, and you will be invited more often. Thank you very much.
Thank you.
Thank you.
Thank you. Thanks to all of you. We now move on to the next plenary lecture. We welcome Dr. Harish Kumar to share the talk on expanding armamentarium beyond metformin, quest to put peptide in a pill, the journey of oral semaglutide. I will first introduce the chairperson, Dr. Harish Kumar.
Dr. Harish Kumar is clinical professor and head at the Department of Endocrinology, Amrita Institute of Medical Sciences, Cochin. He has been instrumental in setting up the Department of Endocrinology, Diabetes and Podiatric Surgery at the Amrita Institute of Medical Sciences, Cochin. His areas of research are diabetic foot, thyroid disease, and patient education. He is the president of Professional Association of Clinical Endocrinologists of Kerala, PACE, and he is the chief editor of Amrita Journal of Medicine, and he serves as a reviewer and member of editorial board of many national and international journals. He has published more than 250 articles in national and international journals. Our speaker for this session is Dr. Denise Franco. We welcome you, Dr. Franco. I now request the chairperson to introduce the speaker and conduct the session.
Thank you.
So is the screen visible?
Is the screen visible, Harish?
Yeah, can you hear me?
Yeah, we can. We can hear you and see you also.
Okay, yeah. I think I'd just like to introduce Dr. Denise Franco. She's an endocrinologist working at Sao Paulo in Brazil. She's the coordinator of Adult Type 1 Diabetes Department of the Brazilian Diabetes Society. And she has also been a member and a principal investigator of many clinical trials in the area of diabetes. She's now going to give us a lecture on the subject of semaglutide, which is a very exciting and new molecule which is on the horizon. Her talk is titled Expanding Armamentarium Beyond Metformin, the quest to put peptide in a pill and the journey of oral semaglutide. So after she's finished her plenary lecture, we will have a discussion. So I'd request you all to put your questions so that we can have an interactive session at the end of the talk. Otherwise, it will be up to me to ask her all the questions. Please do help.
Thank you so much. It's a pleasure to be here. I would like to be really in a presential way, not in a virtual, but as we are now in this new world, it's really a really pleasure to take part of this amazing program. I love it. I was listened to and I was very impressed and I like it so much. And I love India. It's a pity that I'm not able to be with you. I'm sharing my slides now with you. See, and for us to start that.
Yes, you can make full screen. Yeah.
Yes, I'll get it.
Perfect.
There we are.
Perfect.
Okay. So I would like to start thinking about our patients and the journey that they have to relate to diabetes and how they face the treatments and the daily lives. And if you are having a patient in front of you and you have to decide with him which would be the ideal anti-diabetic drug for the treatment, for sure, we would like to have an arm or a treatment that could be able to get the target and also to decrease the risk of hypoglycemia without hypoglycemia if we can, and also not weight gain. And nowadays, if I can say more than that, I would like to have a drug that also had minimal risk of hypoglycemia and could achieve the good control, but could be safe. So cardiovascular safety, that's something that we are looking for. And when we think about what you have in the real world, the clinical outcomes that have shown us the results that the real world, if you have a patient that is more than two oral anti-diabetic drugs, and if I have the opportunity to give to my patient GLP-1 or add GLP-1, what we see in the real world, what is present for us is that there is a significant more patients reaching HbA1c target that we are looking when we introduce GLP-1 receptor agonist for this patient. And also, if I'm thinking about the weight reduction, if I introduce GLP-1 for my patient, I can also have a less weight gain. And also in some patients, I can lose more than 30% of the weight. And if they are with two or anti-diabetics oral and I introduce the GLP-1, I also can discontinue in some patients the drug, the oral drug, at least one oral drug. So it's a good opportunity for my patients or for your patients to go to GLP-1 receptor agonist. But let's see what we have with our patients. What's that? But the barriers that we have to face when we have an injectable medication to give to my patient. If I have this opportunity and I ask him to go for injectable medication, what you are facing is there is a concern about the injectable one. There are some patients, they don't like the idea because they have the idea they are in a bad situation, they are in the end of the disease and they don't like it. And even for physicians, there are some concerns also to propose to my patient, to his patient, to them patients, injectable medication. So there is a reason for us to go for a different kind of delivery of peptides. And oral delivery, it's a good option because maybe if I can give to my patient an oral peptide, I can improve the compliance, I can expand the treatment options, maybe I can take better for my colleagues, they can accept more and try to address the barrier associated with subcutaneous administration. But there are some questions that we have, not questions, but problems that we have to face to go on our GLP-1 receptor agonists. If I gave them a pill, I have to face the problem with degradation to the stomach because we have a low pH, there are proteolytic enzymes, and also a problem limit to the permeability across the gastrointestinal epithelium, and also the bioavailability, because giving an oral GLP-1, we know that the bioavailability is less than 0.01%. So how can we overcome these problems? That's what we have. It's a new drug. That is a new way how to have the deliver the semaglutide GLP-1 in a co-formulation with a snack. But what's a snack? A snack is sodium and hydroxybenzoyaminocaprylate. That exactly is a fatty acid derivative that can enhance the absorption of the semaglutide. And so when we have this co-formulation, what we can have when it can change the pH of the stomach. So you take the pill, and as soon as the pill achieves the stomach, there is a change in the variable environment, and this change is reversible, total reversible. So there's a time, there is change the pH, there is better environment for the GLP-1 and can enhance this absorption. And so we can face it, transport this barrier, and the GLP-1 can be absorbed. So in one, that was the first class of oral GLP-1 receptor analog. And I can tell you that making it possible, the absorption of this GLP-1, because you can have increase in bioavailability. We can have different kinds of dose of the several treatment dose, and a better patient compliance with a dosing condition. This oral semaglutide was studied in a huge program that is called Pioneer. And the Pioneer trial, we have more than 9,000 patients included. And also more than 5,000 patients was exposed to the oral semaglutide. This program, I can tell you that is on Pioneer 1, it was a comparison between oral semaglutide versus placebo. On Pioneer 2, we had the oral semaglutide versus SGLT2 inhibitors. On Pioneer 3, the comparator was DPP-4 inhibitor. Pioneer 4, it was a comparison between another GLP-1, that was liraglutide versus placebo. And Pioneer 7, it was tested the flexible dose of oral semaglutide. We also have in this program the insulin users that was tested on Pioneer 8, and I can tell you that Indian subjects that were included in the Pioneer 8, and also special populations was studied in the Pioneers 5, the patients that are on real impairment, and also we have the Pioneer 6, that's CVUT trial, that also in Indian was more than 200 patients that were included. So you can see that it's from the beginning, of diabetes, as I can say, in the monotherapy, to the end, all the stages of diabetes, it was including this program. So let's see the results of glycemic efficacy. As you can see now, that's that change from the beginning, the baseline to the end of the trial. You can see in all these trials, there is a consistent better result of oral semaglutide compared to all the comparators. If you see this in the dark blue, it's the higher dose of 14 milligrams. In light blue, as you can see, is the 3 milligrams. And in the medium blue is the 7 milligrams results of oral semaglutide. So there is a consistent reduction of HbA1c whenever you have the different comparators that we have. And across the Pioneer trial, oral semaglutide provides a reduction of HbA1c up to 1%. Let's see some new data that was presented now at the ADA. That was Pioneer 1 postdoc analysis. That is very interesting. That gave us another idea that it was, I really liked this. It's a poster, but if you can introduce, remember the Pioneer 1 was the one that was compared to patients that were only on diet and exercise. And if you introduce earlier in the early days of the disease, we can have a very good results and get the target less than 7, less than 6.5%, and also less than 6%. So introducing the early introduction of oral semaglutide leads us to a higher proportion of patients achieving the glycemic targets that we are looking for our patients. And in this another exploratory analysis, that's the new data also from ATA. If you compare on Pioneer 2, that it was oral semaglutide versus empagliflozin, we had 14% more time spent in glycemia control with oral semaglutide than with empagliflozin. There's some good data to present. But let's go on to see the results of weight reduction, because you know that this is a class that we have this, the reduction, the weight is something that we like to see the results, mainly for this class. So let's go for that. Looking at the Pioneer program, so I have again all the Pioneer program. We have also look at the focus the man on the dark blue, that is the 14 milligrams of oral semaglutide. As we can see, we have during the whole program also a very good result of body weight, and it was a better performance on oral semaglutide again. So across the Pioneer trial, oral semaglutide provides weight reduction up to 5 kilos. Let's move now to the cardiovascular outcomes. The Pioneer 6 was a no inferiority study to show the cardiovascular security. So I have to say that it was a trial, CV outcome trial, focused on the first MACE. So the time to the first occurrence of cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke. And it was a trial. It's a small trial. It was about 1 year and a half. And there's no show, as you can see, there is a 21% risk reduction, and it was no significant statistical difference between placebo. If we think about that and then look at the results of HbA1c and body weight, we can see here comparing to placebo. We have it's okay? Okay.
We lost your voice. I mean, we're not able to hear you. Are you muted, or is it only me?
Are you here?
We can hear her clearly.
Okay. Sorry. So as we can see here, we have 0.7 difference comparing to placebo related to HbA1c, and also a change in body weight performed better for oral semaglutide. And as we know, the Pioneer 6 was a small study to prove the cardiovascular security. And that is the reason now that there is a need for a superiority study. So that's the sole trial that is ongoing trial that is being doing, that will be for at least 5 years, and now driven to 1,000 cases, more than 1,200 events. And it will be including more than 10,000 patients. And that will be to establish the superiority, so be studied the superiority study. And that's the reason for that. But there is, even if you pull the cardiovascular outcomes data from oral and injectable semaglutide that we have on the studies Sustain 6 and Pioneer 6, if you pull them together, semaglutide showed a consistent effect on MACE with 24% risk reduction comparing to the others comparators. So that's the result that we will see now after that, looking at the results of the SOUL trial. There is a good effect on leptin profile and also on blood pressure during the pioneer program. So we have a decrease on lipid metabolism and also reduction of systolic blood pressure. In summary, if we see all this huge program, and I'm very exciting to present the data because I was taking part of that. My site was involved that in many pioneers, many trials. So I'm very happy to be here to talk about that. And if I can summarize the data from related to HbA1c, when we gave to our patient that I was telling you about, including oral semaglutide versus empagliflozin and sitagliptin, they were superior and no inferior to liraglutide. Related to body weight, comparing oral semaglutide, it was superior to sitagliptin and liraglutide, and no difference on empagliflozin. And also, we have the cardiovascular safe, so it's a drug that it's safe to be used in our patients that are on cardiovascular risk, and also on established cardiovascular disease. And the efficacy was established when given early in the therapy, late, or regarding the renal or hepatic impairment. But let's see how I use this. It's important to, in this situation, to teach our patients because it's oral drug that can be, that has to be taken in fasting, and the patient has to wait at least 30 minutes before eating, drinking, or taking any other medication, and with a half glass of water. And also, there are some tips that I can share with you is about how to mitigate the problem that we have with all the GLP-1 class. We know how to manage nausea. So it's important to teach our patients to have some strategies when you are taking GLP-1. Is like to be aware of not eating too many fat food because it can increase the nausea. Stimulate our patients to eat small portion, and whenever they have they face nausea, it's important to teach them that we can de-escalate the drug, wait, have a pause, and then introduce again, and titration slowly. And with oral semaglutide, we have 3 different presentations, so we can do that easily and teach our patient how to deal with that. But who will be my patient that I can give this new drug? As we see from the Pioneer program, we can use for all the stages of the disease. So if you have a patient that's on a diet, I can go for that. Patients that I know that it will be benefit for them to lose weight. Patients where hypoglycemia is a concern. Patients that have established cardiovascular risk. And also, I can tell you that there are patients that are old, and there is no problem with these older patients because it was available in this study, and I can say that it's some drug that is safe even for the aged one. And in the end, in summary, I can tell you that GLP-1 is one of the most effective medications to type 2 diabetes, which has been shown reduce HbA1c, body weight, composite, and outcomes, even in pill burden. Oral semaglutide is really an innovation because it's the first class of GLP-1 in an oral formulation. And across the PIONEER trial, it was safety, efficacy, and we also had a body weight reduction. So for all the patients, we have a PIONEER program to present and say that it's efficacy and was established giving early in the therapy, late in the therapy, regardless the renal or hepatic impairment. Thank you.
Thank you, Dr. Denise Franco, for that wonderful lecture. And I must say, it's a very exciting new molecule which is on the horizon. We must congratulate the scientists at Novo Nordisk for actually making this discovery and bringing it out into the market, which adds a lot to our possibilities as far as treatment of type 2 diabetes is concerned. We have a number of queries from the audience. The first lot of questions which we'll take is directly related to oral semaglutide. So you had mentioned that oral semaglutide is to be taken on an empty stomach first thing in the morning with about half a glass of water. And the concern which people have generally is that a lot of our patients with diabetes are on thyroxine therapy as well. So how do you actually manage that in practical terms?
Well, there are some tips that I can tell you because I have on the trial. I don't have really in Brazil, it's not launched, not yet, but we are involved in the clinical trial, and I have many patients that are on thyroxine. So what I don't know for you, because here in Brazil, there are some patients that they don't want to eat in the morning too many. So for them, it was not so difficult for that. But there are some patients that I introduced I asked them to take the pill at night, and it works very well. It was not difficult to that.
Okay, I think that's a very practical solution to what could otherwise have become a very sticky problem, since thyroxine is a commonly used therapy.
Harish,
I think,
can I comment? Harish, can I make a comment?
Sure.
So a wonderful talk, Dr. Denise Franco, and convey my regards to Professor Fadlow. He visited your city and he has hosted me. Wonderful city and wonderful country. So welcome to India, at least virtually. This molecule seems to be, really creating waves, especially the oral form. The injectable form is fine. We have other alternatives, but the oral form, if all the data that you showed, we are so excited about the SGLT2s, but here is a molecule which is matching the SGLT2s and everything, and probably even exceeding in some ways, especially the weight reduction and so on. So do you think this can be will be a competition to the SGLT2, or why not, actually use both and probably get even better results? I know you don't have the evidence for that, but what do you think? They're taking two different molecules that is both having very good effects. Obviously, studies have to be done, but do you think that even using them synergistically could have some additional benefits?
For sure, it's depends on our patients. I think it's a good opportunity for them, mainly because we are focused on two drugs that had been proved to be safety for our patients, and also we have some data also for related to GLP-1 that we have better results also on the cardiovascular, for all the cardiovascular. So I can certainly use with our patient, but on oral semaglutide, we have all the data from the comparator was with that, but I think that in the real world, we'll have evidence for that and the more patients will be using that. But it's a very exciting molecular, even to be starting early for our patients and overcome the barrier of injectable ones.
Thank you. Thank you.
Okay. I think there's another question from the audience. I think there are some concerns about the safety since it's a new molecule. There were some concerns about retinopathy worsening with the injectable semaglutide. Do we have similar concerns with the oral semaglutide?
Actually, on the Pioneer program, the patients that were on retinopathy, proliferative retinopathy, they were not included in the trial. So what we know that it was not increasing on the problem, the patients that were taking oral semaglutide, but it is a special population was not included. And there is another trial that is focus trial that the main point was to study the GLP-1 and also the results on retinopathy, because it was something that was a concern in sustained trial. And I think that we have the better results after that. We know that all the medications that even then decrease the glycemia very fast, as well as we had on DCCT. We had some concerns about the retinopathy. So it will be a good opportunity to have the results of the focus trial, and then you can really understand what's the relationship to GLP-1 and also retinopathy.
Sure. We are also one of the many centers in India who are doing the focus trial. So in the meantime, till the focus results are out and we know for sure, would you actually recommend that somebody should undergo a retinal check before they have oral semaglutide, or is it not to be worried to that extent?
What I would advise is to go slowly with the glycemia decrease, as well as I have the same advice for people who introduce insulin, for instance, for a patient that has proliferative retinopathy. So the main issue is how fast you decrease your glycemia. So we have to have these concerns when you talk a patient with retinopathy, that we have to be more close to them to follow.
So you had recommended that you start with 3 milligrams and then go to 7 and then 14.
And it's slowly.
Yeah, that's is that based on tolerance, whether the patient is having GI problems? And if so, can you go back to the earlier dose and then stay stable on the dose that's tolerated? Is that the way to use it?
Yes, during the trial, we had some patients, a lot of patients that was whenever you have to increase the dose, they may face some GI effects. And I gave them to try to understand how was the food, the way they were eating. I gave them medications to mitigate the gastrointestinal effects. And then if they were not working, I de-escalate the dose. So I gave back the other dose, the small dose, and then we wait more than 1 month, and then we go back and we could use that. Just the way we do with the injectable ones.
While we are on the topic of GI side effects, there's one more question in that regard, and that is, how does it compare with other GLP-1 receptor agonists, the GI side effects? Is it more, less, the same?
Comparing to the other class, it was quite in all the trial, the partner program, the GI was quite similar to the one that we have on GLP-1 class analogs.
Thank you for clarifying that. There's another question on safety. The question is, in patients with polylithiasis and history of pancreatitis, generally GLP-1 receptor agonists are avoided. Should we do the same for oral semaglutide as well?
I think that we have this more and more being clarified about the pancreatitis, and maybe we know that it's more safe to use that, and we have the same issues that we have to the other GLP-1, so it's the same comparing to the others.
I think, Dr. Denise, you've shown clearly that there's very good HbA1c reduction, weight reduction, cardiovascular safety with the oral semaglutide. I think in India, the main concern would be the cost of therapy.
Yeah,
so,
just like in Brazil.
So my question to you is this idea of saving a penny today or spending £1 tomorrow, can GLP-1 receptor agonists actually be a cost-effective option in the long run?
We have to test that like in the pharma economy, but I think that the more we use, the more easier for us to have to decrease the cost. And thinking about the perspective of our culture, just like yours and mine, we have to have this study on pharmacoeconomy, but I think that the main problem with our patients, is the cardiovascular risk and the cost of having a patient with a cardiovascular event and how to deal with that. So think about our patients and the risk that they have, the high risk, and having a possibility to have this new drug that can act on atherosclerosis from the beginning, and maybe we can avoid these patients to go on these events. We can spend less money on taking care of our patients. So I think that's a good opportunity for us to go for drugs that can decrease the glycemia, decrease the body weight risk of to put some weight, and giving to our patients better quality of life.
I think certainly you've explained how it is cost effective in the long run. There's another question about GLP-1 receptor agonists and weight loss. GLP-1 receptor agonists in general, not specifically oral semaglutide. What is your experience in your clinical practice about weight loss? What sort of weight loss do you expect normally? What do you see in your practice?
It was amazing when I see the results of the body weight. There are some patients that lose many kilos. It's amazing. So individual, I can tell on the trial, we say less than 5 kilos. That was the main results. But when we see in a my clinical practice, I have patients that were able to lose more than 15, 20 kilos. And as far as they go for their losing weight, they can be, they are more, they driven more to lose more and to start exercise and to have a change on the habits, on new habits. So I think that for some patients, this decrease of body weight is also related to the self-esteem and feeling better, the glycemia is better. And so when you put them together, there are some patients that can change their lives.
I think one last question. With the new data that's available from the cardiovascular outcome trials, that is LEADER and SUSTAIN 6, don't you think it is actually sensible to start GLP-1 receptor agonists very early on in therapy? Because generally what we find in India is that most people tend to add it on to 2 or 3 other agents when the glycemic control is not adequate or they want to target some weight loss. Whereas this long-term benefit, I think maybe it should be started very much earlier and continued over a long period of time in order to get the cardiovascular benefit. What are your comments on that?
Yeah, I do believe that. And we have some data that I presented that it was very interesting that when you introduce earlier, that's something that it was done in Pioneer 1. We can have a very good decrease of HbA1c, mainly for the patients that were less than 1 year or 2 years of the disease. So think about that this perspective that the patient are losing weight and having the good glycemia control. I think that we can interfere in the metabolic memory, for instance, and then we can change the history of the journey of this patient to be a better journey.
Thank you, Dr. Denise. I think with that, we'll close the session. I'd like to thank you for and this would like to thank for CME program. I hand over back to Dr. Mohan.
Thank you,
I would
Dr.
like to
Kumar, and
thank,
thank you, Dr. Dennis Franco. Next time we should have you in person to visit India. The SOUL results we are all waiting for. I am the national PI for the SOUL study, and we're very excited by this molecule. And we do hope that we'll meet at the investigators meeting or get you over to China, to India. Thank you very much.
Thank you all.
Thank you.
Our next plenary section is on closer to closing loop with AHCL technology. We welcome Dr. Sundaramurthy Chandru to chair this session. I have great pleasure in introducing Dr. Chandru. He is the consultant diabetologist at Dr. Mohan's Diabetes Specialty Center and Research Medical Officer, Madras Diabetes Research Foundation, Chennai. He has completed the fellowship in diabetology from Dr. Mohan's Diabetes Education Academy and the fellowship in clinical diabetology from the University of Ljubljana, Slovenia. His area of interest includes metabolic changes associated with obesity and diabetes. He is a co-investigator for more than 30 national and international clinical trials and has published several articles in peer-reviewed journals, including Clinical Journal of American Society of Nephrology, Indian Journal of Clinical Medicine, and written chapters in several textbooks.
Dr. Chandru also completed his PhD last week, so congratulations to that too.
Congratulations.
Very important.
Our speaker for this session is Professor Ohad Cohen. We welcome you, Professor Cohen. I now request the chairperson, Dr. Chandru, to introduce the speaker and conduct the session.
Before Dr. Chandru, introduces him, Dr. Cohen just informed me that he is coming back virtually to India, to Chennai after 18 years. So welcome back. It's a big welcome back to you. And we really wish we had you in Chennai in person. And I'm sure with the launch of the new version that you're going to talk about today of the pump, we will be able to get you back to Chennai face to face. Thank you.
Thank you.
Thank you, Dr. Guha Pratibha, for your kind introduction. Thank you, sir, for your kind words. I would like to welcome our next speaker, Professor Ohad Cohen, who is going to talk on closed-loop technology with advanced hybrid closed-loop technology. So he is Associated Professor of Medicine at Institute of Endocrinology, CH Sheba Medical Center and the Sackler School of Medicine, Tel Aviv University, Israel. So he's also Medical Affairs Director of Medtronics for Europe, Middle East, and Africa, active in promoting better care of diabetes with the use of technology through research and education of healthcare professions and patients. He also reviews he is also a reviewer for several journals. He has published over 160 articles in peer-reviewed national and international journals. So over on to Dr. Ohad Cohen.
Thank you, Dr. Chandru, and congratulations on your PhD. I'm sure it was not easy.
Thank you.
And I will start right away. First of all, also thanking Dr. Mohan for inviting me. And as he mentioned, this is closing the loop also for me because I met Dr. Mohan 18 years ago, just moving to the new center in Chennai, even before you joined, I guess, Dr. Chandru. And I introduced to him the pump, a new pump, it's called the MiniMed 508. And sensors were only in the beginning of their life, in the clinical life. And I remember, I don't know even if Dr. Mohan remembers, but I remember that he said, so why don't you guys close the loop? You have a sensor, you have a pump, close it. Well, 18 years later, I can come and say quite nicely that I'm not going to talk about the future. I'm already going to discuss the experience, how these closed loop systems have changed the therapy in a dramatic way in the places that it has been used already, and I'll also hint on the future. So it's a great place to close the loop and discuss how we get closer to closing the loop with the new advanced hybrid closed loop technology. And let's start with the need. Well, if you look globally, and this has just been published in the ATTD, it was a poster in the ATTD, published also in the ADA. When you look at the situation globally on the A1C of people with type 1 diabetes, you can see that the results all over the world is not really different than the results that has been just discussed this morning by Dr. Sabu, with an A1C of 8.5, 8.38, more or less the same. Even Europe, which is much more reimbursed, much more money invested in the treatment of technology in type 1 diabetes, the A1C is 7.7. So there is a global failure in achieving glycemic control in type 1 diabetes. And when discussed in affluent countries like in Western Europe, you can still see that the majority of patients are failing to reach glycemic control. Only between 15% in the UK to 30% in Italy reach an A1C which is lower than 7. And the question is why? Why are we failing to reach this glycemic control that we want in our patients to prevent the future complications? And the answer is we had maybe the approach we made. So the approach today is providing more monitoring, more SMBGs, more real-time, more scanning. And we know that more scanning and more information can provide better outcomes, better A1C. But at the end of the day, it's very difficult, and most of the patients cannot do 22, 30 scans a day. And as we can see that in the whole, just giving more monitoring does not make a big change in the A1C. This is from the Swedish cohort. You know, they have a very strong registry in Sweden, like all patients with type 1 and type 2 are on the national registry. And you can see that adding more technology on the monitoring side prevents some hypoglycemia, very, very comfortable for the patients, but on the A1C level, not my change, not a significant change. And we know because if you just monitor, it doesn't, if you don't do an action, if the glucose you're measuring, you'll not get better control. And what is the action that usually patients have to do with this new information is to inject more. And we know that the more injections, the better A1C. And this is from the DCCT classically doing, if you compare multiple daily injection to 2 mixes a day, you know, you could get better results of MDI, and it has been proved. But what are we doing? We are putting a lot of load on the patients, a lot of monitoring, a lot of injections, and we want them to inject according to what they're going to eat in the future. And we want them to correct the blood glucose when the blood glucose is high without knowing about the future. So the whole concept is that we are treating our patients now to something that will happen in the future according to their glycemia in the past. Now, we've been doing it for many years. And maybe this paradigm of therapy, that means treating the future by the information on the past, should change, and we should start looking at a different way to treat people with type 1 diabetes, because the whole scheme of having them measure a lot and inject a lot cause them to have a huge burden in order to be well controlled. And I like this cartoon because it tells us how much actions a individual with type 1 diabetes has to do to go through a single day to be well controlled. And this is only diabetes related. He has a life, he has family, he has work, he has fun, he wants to enjoy. All this is on top of what he has to do for treating his glycemia. And we know with all this burden comes a burnout. And this is a nice picture of burnout. So this is because it shows what happens after the DCCT ended. For those who were well controlled had eventually lost the control when the intensity of the study went away. So how about changing the whole paradigm? Instead of treating the future according to the past, why not individualizing the therapy? And we had a wonderful discussion just a couple of minutes ago on the precision medicine. instead of giving a general program for the patients with type 1 diabetes and treating them in the future, how about providing what the patient needs now at that moment? And the way to do this is combining, and that's what, that was the idea that we discussed with Dr. Mohan many years ago. Combine sensing with an insulin pump, and find an algorithm, find artificial intelligence that can combine combine these two in a safe way. Now, I don't have a lot of time to discuss why it was so difficult. And just to mention the important difficulty is that there's a lot of lag times because we inject in the subcutaneous tissue, and until it gets to the end target, it takes time. It doesn't go straight like physiology to the liver. And we don't measure in the blood. We measure in the subcutaneous tissue. So all those are huge, I would say, technological barriers that needed to overcome by the mathematicians and the scientists in order to provide the right algorithm. So the first step was, how about taking away the basal rate? Now, it's very hard to assess for physicians to give away something that we were so proud of us to calculate how much insulin is needed in the basal. And the answer is, how do we know what is the perfect basal rate when every day looks different? So the first step in automation was to take away the basal rate from the physician and give every 5 minutes exactly the basal rate that the patient needs at that moment, using a specific algorithm that, unfortunately, I wouldn't have not much time to go into this, but this is how it looks. You can see the blood glucose when the glucose is high, the basal rate is high, and even before it goes slow, just changing a bit the rate and changing a bit the amount of glucose that is under the curve, you can see that the rate very quickly reduces to very low. So it predicts what's going on and acts accordingly like a physiological beta cell. So having just automating the basal rate, let's see how it changed therapy in the world. Let's skip this for the time. I like to show this figure that I've shown in the last ATD last year, and this is what happened after 1 year of use of the hybrid closed loop, the previous version. It's called the 670G, which only automated the basal rate. Already just automating the basal rate, look what happened in Europe. 14,000, almost 15,000 patients, all of them, or most of them, had a time in range of more than 70%, and a GMI, which is equivalent to A1C, which is 7 or below. Now, this is incredible. Now, this is done in many countries that think they're doing the best, some countries that have more issues with finance. All the countries had the same. And you know why they had the same? Because it was not the individual physician or site that did the control. It was actually the algorithm. So what we see is, regardless of where you are or what country, what is the indication, many people now reach a good time in range, good A1C, but very safe. Look how little hypoglycemia there is. And this, I like this slide because it shows us that that's only just automating the basal rate took us from a failure rate, that means only 35% before or 30% on time in range reached the goals. After just automating the basal rate, we already have more than 50% success. Not enough, but already we went from mostly failing to more than 50% succeeding. So we can see the gradual improvement in patients reaching the time in range of more than 70% when you add more and more and more and more technology. So we reached better control. How about the patient's load? Did we increase patient load or did we decrease patient load? Well, look about this. Look what happens when patients just automate the basal rate. This is how their daily load. Okay, one step, very clear, getting better. But we still see that we did not reach the goals in all our patients. So I did a very interesting analysis and looked at the different populations according to their pre-auto mode A1C or GMI. And I saw that those who were very well controlled, turning on automation actually even added to their improvement by decreasing their hypoglycemia. So the good got better. But those who did not do well because they had a high A1C, very low time in range, improved dramatically, but not enough. The A1C reduced the same, but they did not, most of them still did not reach the goal. So we need to automate something else. The next step, and this is what now is currently approved in Europe and being used, and I'll show you in a minute the results, is now a second level of automation. We call it advanced hybrid closed loop, and that is looking very, actually, you know this pump because it's very familiar from the hardware to the 640 that you're using in India. But actually, it's the same. It has a different kind of connectivity with the transmitter, with the glucometers, and now it also connects to the mobile phone by Bluetooth. That makes the patients very happy because they can see all the trends on their phone. It's more easier for them, but it also can interact with the home device or a care partner device, and also can be downloaded at the site. I won't go into much details, but I want to go to what actually is how smart the algorithm is. So on top, as we discussed before, on automating the basal rate, the next level is automating the correction bolus. Now, we did a mistake, right? The way we always taught our patients, our students, our fellow physicians was when your blood glucose is high, calculate and give a correction bolus when it's high. But the pancreas does not work this way. The pancreas does not, the beta cells do not wait until the blood glucose is high and then give a big bolus and see what's happening. Actually, the moment that the blood glucose is above a certain threshold, then they start to get small amounts of insulin secreted into the portal vein. And this is what the algorithm does. The moment that the blood glucose is more than 120 and the basal rate is at its maximum, and if it's not enough, it starts to provide small, early on correction boluses. Okay? And this is how it looks in a patient. When the patient is eating, like here, and he gives a bolus, and he estimated correctly the small meal he had. You can see that everything is fine. The blood glucose is good. There's not a big excursion. But what happened if the patient made a mistake? He underestimated the amount of carbs that he ate. So he injected insulin. He gave a bolus by providing the amount of carbs, but it was insufficient. The blood glucose went high. The basal rate came to the maximum. You can see this shelf over here. But it was not enough. The blood glucose was more than 120, and then small correction boluses kicked in. At the end of the day, the patient was well controlled, and the pump corrected the patient's mistake. But the correction is smart. It's not just a calculation. Every 5 minutes, when there is a reason to give a correction bolus according to the rules I just said, every small correction bolus goes through a simulation of what's going to happen in the future according to the amount of glucose they had, amount of the insulin they have. It's a small simulator that goes every 5 minutes. There is a small correction bolus. For me, it's very difficult. It takes me a lot of time. But for the algorithm on the chip, it takes nanoseconds. And then it can provide the corrections in small doses that are also safe for the future. So again, don't have time to go into much more details, but to provide you the smart of the algorithm that even all those small correction boluses are done in a way that is very, very safe and very calculated to be the right dose. And this is looking at a window of future of 2 hours. So if in the next 2 hours it is predicted to be too much, automatically the correction dose is reduced. But not only that, but also the meal boluses. When the patient says, he wants to eat 80 and he puts 80, and according to the carb ratio, I don't want to go again to details, the major calculation, the basic calculation was supposed to give him 7 units. Then the algorithm takes this 7 units and simulates what's going to happen now in 4 hours. And if in the 4 hours, there is a prediction that this correction, this meal bolus is too high, it will automatically start cutting it until it gets to the dose that the algorithm figures out it will be safe. So many changes, so many artificial, let's call it, so much intelligence in an algorithm, we cannot follow our patients hand in hand and provide this kind of guidance to them, or they cannot even do themselves, even if they are very savvy and very knowledgeable in their diabetes control. Also, exercise now starts to be very simple because you don't have to overeat, undereat, you just put a temporary target 1 or 2 hours before the exercise until you end the exercise, and the rest is taken care by the algorithm. Again, if there be questions on exercise, I can go back into more details because I want to show two things. What happens to the patient? The patient gets another reduction in the load, but what happens to his glycemic control? Now, this is very brand new information, just shown a couple of weeks ago in the ATTD, an analysis we did on the first 1,400 of patients, 1,400 patients that started the 780 in Europe. But before we go to the real world evidence, we start with the pivotal trial, which showed that by switching on the automation, you see something that we never had with insulin. Now, this is on the 100th year of insulin. It's the first time that a device is providing insulin, which increases time in range, but at the same time decreases the time in hyper and decreases the time in hypo. What do I mean by that? It's usually when we have somebody with a high A1C, we give him more insulin, we always predicted, and you remember the DCCT trial, we predicted we're going to increase his hypos. On the opposite, if somebody has a lot of hypos, we decrease the amount of insulin, and we expect that the time above range will go. When you give insulin by a smart algorithm, you give an insulin in the right dose at the right time, so you get more time in range, but less time in the extremes. So this is how insulin gets to be a very effective medicine, but also safe for people with type 1 diabetes, so they can achieve better control. And it's correct in adults. It is the same in adolescents. Remember that usually adolescents had failed previous studies, had not failed, but had less good results when you compare them to adults. Here, when the automation kicks in, actually, it provides the same level or similar level of achievement in both adults and adolescents. But I really like this. This is from the pivotal study showing not that only that the achievement is done by the majority, more than 50%. In the pivotal study, 84% of those who were using the pump in the settings that are intended to be done, 84% which achieved the GMI of less than 7, 79% achieved time in range more than 70%, figures that have never been seen before. But this was the pivotal. People say pivotal, small studies, only the best centers, the best patients. What's going to happen when you go to the real world? So this is what I alluded before, presented first time in the ATTD, 4,120 patients. Look at the results of putting a higher level, next generation of hybrid closed loop in the market. This is already in the hands of you, of us, the physicians. Time in range on the overall European countries that we had the data from that we could analyze. Time in range now is in the 70s. It's the higher 70s, 76.2% reach time in range of less than 76.2% reach time in range between 70 and 180. Very low hypoglycemia and a GMI of 6.8 average. When you see again this fantastic story that the same achievement is done everywhere. Once you put it on somebody, you can be smart, young, old, whatever, you can expect good results. How good results? Let's look back here. So you remember this side? We discussed this, 76.2% time in range of between 70 and 180 with a GMI of 6.8. But look at the achievement. GMI of less than 7 in 79%. Time in range more than 70 in 77%. Both of them in 74%. Those kind of achievement has never been seen in large population of people with type 1 diabetes. That's why I call the whole idea of letting go, letting the devices do the job that we used to do, a revolution. Again, the algorithm provides the insulin what it needs. Increasing time in range, here it's before and after automation, increasing from 63 to 75, but decreases both the hypo and the hyper. Really I would say extraordinary feature. We were not used to have insulin. We always thought it was like a double-sorted therapy because too much is dangerous, too little is not effective. Here we can see we can provide it in the correct dose that can decrease both the highs and the lows. This is also something new. You know, the pivotal study was only 157 patients, and people said, you know, how come you bring a device after just trying it on 157 patients? So the truth is, it has not only been studied in 157, because we have a very powerful in silico model, which has over 7,000 virtual patients that are built on Carolyn informatics that represent different people. And remember, as we said, even type 1, it's not one patient. Every patient is different. So we have 7,600 virtual patients, and we try on them the algorithm before it's even tested in on the first human being. And what's interesting is that the in silico model predicted the results of the real world evidence, of the real world data, better than the pivotal study. So a lot of discussion is, what's more important, a good model, a good in silico model, or a clinical trial which is not very applicable to the real world? Actually, we can see that the in silico model was very, very similar to the real world evidence. Again, things that we can discuss later on. And when you look at the patient's burden, it's very important for success is to see that the patient sees in his eyes that using technology is beneficial to him. How do we measure in real world the effect of? We cannot ask them, right? Because it's anonymized data, it's large data, so we can deduce. How do we deduce that patients are having better experience? By looking at how many times they need to interact, how many times they have to give a bolus to see what's going on, to do a correction. We can see that before initiating the new algorithm, the average boluses per day was 6. It was reduced to 4.8. And we can see that the better control was done always by improved amount of insulin. But the insulin was given mostly by automated basal and automated autocorrection. So I don't know if you remember, if all of you were in this morning session with Dr. Sabu. He described this patient who was sitting, already has insulin. You know, you have an issue of access of insulin. So somebody's ready, a mother with a child with diabetes, having insulin, having better control, giving insulin, but on the other hand, she needs to eat and to prevent the hypoglycemia as a protective measure. So at the end of the day, you have more insulin, better control, more obesity, more PCO. So again, the double-sorted situation. Here, by giving, by the algorithm, the insulin in the right time and the right quantity, you prevent the cycle of increasing insulin, increasing obesity, increasing resistance, and going back to increasing insulin, so on and so forth. Let's getting close to the end. Let's discuss the future. So are we there yet? Now, we're not there yet because of 2 reasons. First of all, patients still need to define and say that he's going to eat. Why? Because of the physiology. Because again, we're not injecting into the portal vein. The pump injects in the subcutaneous tissue. So we need to announce meals. Again, that's a burden. Number two, even the algorithm cannot go to euglycemia yet. We're getting better results, but we are not in euglycemia. And I love this from our R&D department who gave me this and showed the distribution of normal glucose. This is normal glucose. Look, there's even some below 70 in normal, and we know that. So this is the distribution of glucose in normal. The red one is the distribution with the previous 670G algorithm, which only automated the basal rate. We can see the improvement in the profile with the new 780G algorithm. Now we have to wait and see, can we get better? And now let's talk about the future. We are now interested in closing the loop. That was the question. That was the request from Dr. Mohan. Let's talk about how can actually we can put a device and tell the patient, forget about your diabetes. Let the device just no. Don't forget, put the device on. Don't forget to put the insulin. But forget about worrying about your diabetes. So there's a lot of smart things going on. I will just give you some things to make your for your interest. One is GPS. Maybe let's find where you are in the specific weekday. Let's say Thursday. Your blood glucose is also always high. We don't know. I'm not going to ask you why if you're going to a McDonald's or you're going to eat something bad or I don't know what you do. You have a party. But let's say if we find that you have a pattern, how about giving the algorithm some tweaks and say, you know, on Thursday night, be a bit more aggressive. That's one way. Another way is very cool, and it's actually being studied right now. Can we translate hand movement to meals? And when the algorithm detects some hand movement, how about giving some more, giving some less, changing a bit the algorithm? This is always how to think more about our patients to be more controlled by having less burden and ask them less to do, because we think this is really the key for success for all of us. Less work on us physicians, less burden on the patients, more sophisticated algorithm. And I think that what we hope to see, that this is where we are today with all these new sophistications. Maybe we'll go here, and maybe we'll go even without any request from the people with diabetes in the future. And I hope it won't take 18 years like we did this time, and maybe it'll be in the near future when I come back to Chennai, maybe in person. So with this, I want to thank you all, and I hope you enjoyed. Thank you so much.
Wonderful.
Thank you, Doctor.
Sorry. Go ahead.
Yeah, thank you, Dr. Cohen, for the wonderful presentation. This is the moment which we were waiting eagerly for our patients, because we have more than 2,000 type 1 patients at our center. And we have around 400 to 500 patients on insulin pump. Even with insulin pump, it's very difficult to control because we have to do multiple times. And these are most of the patients are not well educated. And we have even small, lesser age group patients. So I think this particular advanced hybrid loop technology is going to be a very good help for all our patients. I thank Medtronics for creating wonderful technology. And we have some questions. Sir, would you like to ask some questions?
You go. I'll just be listening.
Okay. So there is a question, can it be used in mentally ill child with type 1 diabetes with the proper caretaker?
So there are some specifications for the use, and that is you need to have some technology savvy to use it. Now, it's not supposed to be only the one who uses it, it's the level of the care, the caretaker. So if the caretaker is qualified, then it's easier than doing injection, right? Type 1 does not take care of itself. There's always what is the alternative. The alternative is not simpler. Injecting? No, he's going to come and inject. So actually, if there is a caretaker who is able to do this, why not? Why not? Just it needs to be put on the patient, not be taken off, because it's always short-term insulin. And if you disconnect, there's going to be shortage of insulin and might cause a decay. So from this point of view, if the caretaker is qualified, they can make it. And also elderly. The elderly you are, it's better you get. It's not that the opposite we say, because elderly people are considered to be less technological savvy. So I would say it depends on the caretaker, like in children, like young children.
So what is the minimal age where you can stop this technology?
So this is a regulatory question. Right now, it is limited by the age of 7 and up to 8 units of total daily dose a day. So those are 2 limits today. We are ongoing trials on the 2 to 6, trying to expand this to the 2 to 6 years old, but it's not yet. It's not liable. You're not allowed to use it on younger than 7 and less than 8 units per day.
So what is the maximum age where you can use in older patients?
Everybody is older than me. No, but actually there's no limit. There's no upper age.
No upper limit. Okay. There is one more question from the participants. It's during COVID-19 infection, can it be disconnected or to be continued or to be changed?
Great question, because we didn't know, right? Who knew? And we got more and more. So this is great. It's the opposite that everybody thought. Everybody thought, COVID will come and patients who are very dependent on us they're going to change their lifestyle. They need a lot of interaction. They won't be able to go to the sites and they will lose their control. The more technology, it was also true with sensors on pumps and sensors. And we had people on 780 during COVID, they did the best. It's the opposite of the opposite. They actually did the best because they didn't have to go. It adapts to the situation itself. And don't take it, Dr. Chandra, don't take it personally. They do it without us physicians. So the automation can take care of these changing situation in the patient's life cycle. So actually they did very well during the COVID. And we have papers that are going to come and show specifically how the more technology, the better they were controlled. And even I'll tell you a secret, there's many papers, at least 3, and our data showing that during COVID, patients on technology did better than pre-COVID time. And we know that because they actually stayed at home and they had less fluctuation, right, Dr. Mohan?
Better control, obviously. So obviously the results will be better because if the diabetes is well controlled, you have less morbidity due to COVID. In fact, if I can even add to that, in some of the ATTD meetings that we've had, even pumps have been started during COVID because patients have using video technology. Educators have been able to start pumps, but they could not go in person. They couldn't come to the clinic, but the patient wanted to go on the pump. So video demonstrations given pumps are actually started with that and quite successful.
So we actually had to prepare. So it's not. So many people just turned into virtual by changing the face-to-face to a phone call or video. That's not enough. We actually wanted to make specifically education material that can be done virtually, and we can use, and it's ready even for the 640, that you can onboard somebody from MDI to 640 without seeing him once, and we can show that the results are as the same as face-to-face, and the patients were happy. They didn't have to travel. Yeah. This is COVID taught us so much. It's incredible.
May I ask a question?
I'm not the chair, but I hope you can.
With the permission of the chair, please.
Yes. Go ahead, please.
Yes. So, I think this is revolutionary technology, and it's amazing what you've been able to do. So congrats to you and to Medtronic. In a country like India, I think there are 2 limiting factors. Considering the socioeconomic strata of our patients, a lot of our type 1s who go on to pumps, I think there are 2 things. The first being the cost, being a huge limiting factor, not just for our less privileged people, but even I think the normal populace are going to have a problem with costs here. That's the first thing. And the second is literacy. in the lower strata and the usage of the pump for wide acceptance? What can we do for these?
So I think it's a fair question, and I think it needs to be asked. Now, first of all, I brought you data because even if you don't have reimbursement, you need to know everything. No, so you need to go, and that's what Dr. Mohan asked. Tell us what there is, what's the latest, and that's first of all knowledge and for you to know. Number two, this is a problem of both priorities. So you have to choose priorities in this case, and start doing case by case. And this is also on the national level. But you know, it's the same thing also in more affluent country, and I'll tell you, the NHS is rethinking. Even UK is rethinking. Maybe spending more money now on these devices will save us in the future. So it's really different economies. There's a lot of economic questions here. Of course, it is expensive in the short term. This is a very important question for India, and this needs to be discussed internally to see how you prioritize, how you work with the industry to find this. This is really a topic by itself, but it's important to understand. So for me, bringing knowledge is number one. Finding a way to start doing to change the reimbursement situation in India has to go hand in hand with the industry, but also as physicians to be promoting this or talking about this, and the patients also to understand that they deserve it. They deserve it. And for the literacy, now I've been in India many times, and one of my best places that I've been is in Mumbai, because we did some there. There was a group that gave pumps to the poorest of the poor, just to see would they sell it, would they throw it away, will it won't work, because they're, you know, the families are not, they had issue of literacy and so on. That was fantastic results. They kept the pump as it was holy. So the opposite of the opposite, it came out as a paper saying it can actually change the barriers between the rich and the poor and the literate and the illiterate. So I believe a lot in technology, and you know that by the passion that I discuss, and I think most of you share with this, and I'm sure Dr. Chandra, that we all share the passion that technology can actually bridge these inequalities. But it's not simple. It needs a lot of advocacy by all, industry part of it, and we are waiting. But it's a grave situation, and it needs to be starting small, maybe in specific priorities, children, pre-pregnancy and things like that, but it's up to you. And I'm always happy to start the discussion and talk with you about this.
We have also, Anjana and I have donated pumps to very, very poor children. And the ethical question that we had, can we use that money to give 10 children or 20 children insulin rather than give one child a pump? But then it always comes back to that particular child who is not able to manage with multiple doses of insulin, getting extreme variability of sugar. And after giving the pump, that life of that child completely changed. So you really cannot equate what we learned from that. We've done that now for 3-4 such children. And we know that, you know, you cannot really equate that and say, okay, one pump is equal to so much of insulin. Because for that child, it makes a lot of difference. And there are many such children. And I know that there's somebody in Coimbatore, a friend of mine, Dr. Krishnan Swaminathan, he may be
exactly,
and he has been giving hundreds of pumps to really
incredible
poor children, and so it's been done earlier. And I think one of the ways when a more expensive kind of model comes is that we must have some kind of a EMI kind of payment, because people may not be able to pay cash upfront, and so they might have to pay it over a couple of years or something. So loans to be arranged, and if they feel that it's going to change their life and completely automate, the people will invest in that.
So the industry is open for this changes in pay model. People understand this, and since now we know what to expect, it's something that we cannot stand back and say, okay, this is for the rich or this is for that.
Yeah.
Because at the end of the day, that's the right way to treat type 1 diabetes. What can we say? You know, this, if you have that's the present solution. And the point is, if you treat them with some insulin, you increase their life. You might increase so having a intermittent solution can even make things worse. So the dilemma that you have now in India, we are looking for how you're going to solve this. This is, I think, a major ethical, and really we applaud that you're thinking about this and trying to solve this out. And the industry will listen.
Thank you.
Yeah. Thank you, sir. Thank you for your wonderful presentation. I think it's time and we'll wind up. I thank all the speakers and giving me this opportunity to talk on.
We're all waiting for the lunch.
Thank you, sir.
Thank you so much. Bye-bye.
Thank you. Will it be in September, or is that you expecting September?
Listen, I've I don't know yet. I don't say that. All right. Bye-bye. Thank you so much.
Bye-bye.
Thank you.
Purohit to chair the session on monoclonal antibodies, perspectives in managing a high-risk patient of COVID-19. I request Dr. R.M. Anjana to introduce Dr. Lotika Purohit.
Welcome, Dr. Lotika. Your video is not on, so if you could kindly switch it on, we will be happy to introduce you. So it's my pleasant privilege to introduce a very, very good friend and colleague, Dr. Lotika Purohit. Could I have her CV on, please? So Dr. Lotika is the Director and Consulting Diabetologist at Diabetes Care Center, Mumbai. She's the founder of the Sugar Doctor Medicare LLP, Mumbai. She completed her MBBS from the Grant Medical College and Sir J.J. Hospital, and her postgraduate diploma in diabetology from Topiwala National Medical College and BYL Nair Charitable Hospital. With over 24 years of experience in practice medicine in various hospitals and clinics, she is a very highly acclaimed and practicing diabetologist. She's accredited by the RSSDI. She specializes in diabetes management in children, especially type 1, and with insulin treatment. Welcome, ma'am. We're very, very happy to have you.
Thank you very much, Anjana, for the kind words. And I would like to thank Dr. V. Mohan, Dr. Anjana, Dr. Ranjit, and Dr. Guha for this invitation and for including me in this program. And also congratulate you on this hugely successful program that we've been hearing for the last 2 days. It's really been very interesting and a lot of unique sessions and things like that. So, thank you very much. So I will be now chairing the session on the plenary lecture on monoclonal antibodies, the perspectives in managing a high-risk patient of COVID-19. The speaker will be Dr. Owen R. Albin from Michigan, USA. Can I have his CV? Yeah, Dr. Owen R. Albin is an MD and an assistant professor, Division of Infectious Diseases from the Department of Internal Medicine, University of Michigan. He also has research interests which include gram-negative resistance, pneumonia, and antibiotic stewardship in the intensive care. He is a member of the Infectious Diseases Society of America, also a reviewer for several journals. He has published over 25 articles in national and international journals and chapters in several books. He's a recipient of several awards, including the William Dodd Robinson Award for Excellence in Internal Medicine. With this, I would request you to start your presentation, Dr.
Excuse me, there's somebody who's got their mic on. Can you mute, please, everybody, except the speaker?
All are muted, sir.
Some crosstalk is coming. Yeah, that's okay. Now it's fine. Somebody's muted. Thank you so much.
Well, thank you so much to everyone for having me today. I'm going to go ahead and share my screen. And I'll just assume that everyone can see this now. Is that fair? Okay, wonderful. I'm getting a thumbs up. Well, again, thank you so much for having me. As the esteemed chairperson said, my name is Dr. Owen Albin. I'm an assistant professor of infectious diseases in the United States. And what I'm talking to you today about is monoclonal antibody therapy. And I think this is a very, very important topic, obviously, in the setting of a global pandemic, but particularly for a conference on diabetes. And that's because the interplay between COVID-19 and diabetes is an incredibly strong one. We know that diabetes, certainly type 2 and likely type 1, is associated with an increased risk of complications from COVID, notably hospitalization, intensive care unit admission, and is an independent risk factor for mortality when infected with COVID-19. And we also know that COVID-19 may unmask diabetes or exacerbate existing features of diabetes and presents with HHS, diabetic ketoacidosis, and incident insulin resistance, even in patients, again, without a history of diabetes. We know that the COVID-19 virus binds in large part to ACE2 receptors, which are present on the pancreas. And the role of glycemic control in particular for patients hospitalized with COVID is really an evolving topic. We know that higher blood glucose levels tend to be associated with a worse prognosis in COVID, but as severe COVID is really a phenomenon of immunodysregulation, it's really unclear which is the chicken and which is the egg in that relationship right now. So monoclonal antibodies, what are they? We know that if you are infected with COVID, and survive, you'll often generate what's called active immunity, which is you seroconvert about 1 to 3 weeks after the incident infection with COVID-19. And monoclonal antibodies, to a certain extent, are a way to provide passive immunity to patients. So instead of allowing their immune system to generate its own spontaneous response to COVID, we can actually give the markers of the immune system back to patients in either monoclonal antibody form or with convalescent plasma. The benefit of monoclonal antibody therapy in particular relative to convalescent plasma is that monoclonal antibodies can target specific viral epitopes to produce a maximal antiviral effect. They're mass producible to scale. They're administered in a known quantity, which unlike convalescent plasma, if you think about convalescent plasma, it's one of the only medicines we currently utilize where we don't actually know how much we're really giving to people. We quantify it as kind of high titer or low titer, but the exact kind of amount of what we're giving is really unclear. And then with monoclonal antibodies, because they're mass producible, we don't rely on donors for the supply chain. A very brief bit about COVID here. COVID, we think one of the primary virulence factors of COVID, which is required for its activity, is the spike protein. That's noted as the S protein here on this diagram. And this facilitates the host viral attachment and fusion. Monoclonal antibodies, in particular, the ones I'm going to be talking about today, generally bind to what's called the receptor binding domain of COVID-19, which are kind of an extension of the spike protein themselves. And the two monoclonal antibodies that I'm going to be talking to you today about are packaged together, and that is casirivimab and imdevimab. The real benefit of these two antibiotics, they were essentially identified after screening over 200 antibody candidates from mouse models and then B cells isolated from seropositive patients who survived COVID. And they have impressive antiviral activity on their own, but the real benefit of the two of them together is they bind at distinct and non-overlapping sites of this receptor binding domain that I mentioned. And we think that this is largely responsible for what has been observed as a fairly high barrier to resistance to these things. Because they don't actually target the exact same spot, it's harder for the virus to evolve actually resistance to these antibody products. So I'm going to go through just a couple of cases to highlight the role of monoclonal antibody therapy for COVID-19 in patients with diabetes or other high-risk features that often accompany diabetes in patients. So this is case one. It's a 65-year-old man with type 2 diabetes, coronary artery disease, who underwent a 2-vessel CABG sometime in the remote past, and obesity with a BMI of 33. This patient developed 4 days of fever, fatigue, headaches, followed by a dry cough. Not an uncommon story at all. The vitals are listed here below. You can see that the patient is febrile, but otherwise relatively appropriate for outpatient care. And they have a positive nasopharyngeal polymerase chain reaction test for SARS-CoV-2. Chest X-ray is shown down here and shows very mild patchy airspace disease. And the question here is, what benefit might a patient like this derive from monoclonal antibody therapy? I have a limited amount of time to talk here, so what I'm going to try and do is just show you kind of what I think are the top line take-home points here from some of the existing trials. A caveat that I have to supply, though, is that a lot of these trials are either shared as press releases or preprints, right? And so while some of this is still relatively tentative and hasn't undergone full peer review, I think the data are very encouraging. We do have a very, very large study of these 2 monoclonal antibody products done in over 4,500 high-risk ambulatory patients. High risk here means any comorbid features that heighten the risk for severe disease in COVID. And in this study, 58% of patients had obesity, and more than half of them were over the age of 50 with comorbid coronary artery disease or hypertension. The primary outcome of this study was 28-day hospitalization or mortality after randomization. And patients in this study were randomized in 3 arms. They could receive placebo, they could receive the 1,200 milligram dose of CAS-MD, and they could receive double that dose. And this is what was observed. Again, this probably looks a little fuzzy here, but again, it's because it's from a preprint. But what we can see here is that with both the 1,200 milligram dose of casirivimab and imdevimab and the 2,400 milligram dose relative to placebo, that patients with COVID-19 in the ambulatory setting with high-risk features had a risk reduction of around 70% for hospitalization or death after about a month after randomization. These patients also had a median reduction in their symptoms of about 4 days. We've seen similar results in a trial of patients who were asymptomatic but tested positive for COVID. Markedly fewer patients went on to develop symptoms, and those who did develop symptoms had symptoms for a markedly shorter course than those who did not. This is a summary in the United States of the criteria that we've utilized under the Federal Drug Administration's emergency use authorization or approval for this medication. These criteria have laxed, and I understand that the regulatory apparatus in India is quite different, but this is really kind of a guiding principle of what we use to think about who is going to have the lowest number needed to treat, who's going to benefit the most from a product like this. And as you can see, it's really folks with anything kind of in this metabolic syndrome pathway, comorbid obesity, particularly those with a BMI of greater than 35, chronic kidney disease, diabetes, and then really anyone who's immunocompromised, we think, for any reason. For us at our specific center, this is a lot of transplant patients. We also have a high burden of rheumatologic patients who are receiving immunocompromised therapy. And then, of course, anyone over the age of 65. This is case number 2. This is a 35-year-old man with obesity, hypertension, and asthma who was hospitalized with COVID-19. The patient's febrile and has a new oxygen requirement, but does not require escalation to the intensive care unit as of yet. The patient's febrile, and you can see he's requiring 4 liters of oxygen delivered via nasal cannula. He tests positive for COVID-19 and similarly has a chest X-ray with bilateral patchy airspace disease. And the question here is, in a hospitalized patient, what benefit might a patient like this derive from monoclonal antibody therapy? Again, we thankfully have data to guide us here, and this comes in large part from the recovery trial, which has generated some of the highest quality data that we've utilized to guide our therapeutic approach to COVID. The recovery trial took this product, casirivimab and imdevimab, and essentially randomized hospitalized patients to receive the medicine or usual care. And what you can see here is there was a significant reduction in the primary outcome of mortality after 24 days. 24% of patients who received this medication died versus 30%. And then there were also fairly impressive reductions in hospital discharge expediently, a requirement for invasive mechanical ventilation, as well as other surrogate outcomes that are clinically meaningful. And the really interesting thing about this study is, unlike a lot of other monoclonal antibody studies, it stratified patients into those who were seropositive at the time of randomization, seropositive to COVID, versus those who were seronegative. And what you can see here, this is something kind of resembling a Kaplan-Meier curve, but for those who were seropositive, there's really not any meaningful difference between those who did and did not receive monoclonal antibody therapy with CAS-MD. The real difference here was driven by those who were seronegative. In the United States, we have not operationalized this yet. This is not standard of care for hospitalized patients with COVID-19, particularly those with risk factors for progression to even more severe disease. But I think this is likely where we're headed, where we serotype patients admitted with COVID, and particularly those who are seronegative and who have not had a duration of symptoms for a terribly long period of time. I suspect this is where we're moving for the standard of care for hospitalized patients with COVID-19. And then the last, one of the last cases I want to run by you is the concept of the role of monoclonal antibody therapy for post-exposure prophylaxis. So this is a 33-year-old female who contracts COVID-19. She cares for and lives with her mother, who's 56 years old and has comorbid diabetes. And again, what is the role of monoclonal antibody therapy here for post-exposure prophylaxis? And again, we have some good quality data to guide us here. This is a study that was done of about 1,500 uninfected patients who had a household contact with someone who was positive for COVID-19, and themselves, meaning the patients in the study at the time of randomization who tested negative for COVID-19. About a third of these patients had the same high-risk features as we've talked about before: obesity, concurrent cardiovascular disease, age, or diabetes. And these patients were randomized to placebo or to receive CAS-MD as post-exposure prophylaxis, with the primary outcome looking at downstream secondary symptomatic infections from COVID-19. And what you can see here is after a month, there was a significant reduction in those who became infected. Those who received monoclonal antibody therapy had a 1.5% rate of symptomatic infection versus almost 8% in those who received placebo. This was noted within 1 week and after 1 week of receipt of monoclonal antibody therapy. And I think importantly, in those who received monoclonal antibody therapy for post-exposure prophylaxis, the average weeks of symptoms in those who actually developed infection was about a third of what was seen in the placebo group. And that was associated with a reduction in duration of viral load positivity. And then, as I know, India was very much ahead of us in the United States in experiencing the Delta wave. But a lot of what has come up as a central concern in COVID for everything, but particularly for monoclonal antibody therapies, what the role of many of the variants of concern, notably the Delta variant, and how that affects monoclonal antibody therapy. And what we know, this is just a brief chart summarizing, the WHO names: alpha, beta, gamma, epsilon, iota, and delta, and what we know about transmissibility, immune evasiveness, and the relative efficacy of vaccines. I'm showing you here some baseline data, which essentially is a busy slide, but if you look at things essentially in vitro, casirivimab and imdevimab retain excellent neutralizing potential and inhibitory potential against wild-type strains of the COVID-19 virus that have a variety of different mutations plugged in. We call this the DUG mutation. Very, very common, was seen in the alpha variant, and we think accounts for increased transmissibility. The N501Y and the E484K mutations are features of variants like the beta and gamma variants. They're not seen in Delta, but you can see across the board, CAS-MD performs much better than comparator products here. And that's why we've actually shifted to using exclusively CAS-MD here, where we practice in the University of Michigan. And then regarding the Delta variant, to be quite honest with you, we have very little clinical data, but we do have some in vitro data. And again, slide is a little messy here, but these are kind of neutralizing antibody titer experiments. And I want to call your attention to the red lines. The red lines that are higher indicate that the product works quite well at neutralizing the virus. Lower down means it does not work as well. And what you can see is CAS and MD perform quite well against almost all variants of concern, notably the Delta variant, whereas banvolibimab and etesivimab, which are separate products, the banvolibimab or BMAB as we call it, performs quite poorly against the Delta variant. And again, that's one of the reasons that we have shifted from using BMAB and etesivimab to CAS and MD ourselves at the University of Michigan here. So in summary, at a very brief period of time to talk, so I hope I was able to condense everything I think is relevant here, but we have existing data that support the use of this monoclonal antibody product in the following patients: ambulatory patients who test positive for COVID, particularly those who are at high risk for subsequent clinical decline. And I think patients with diabetes are the principal group here. Post-exposure prophylaxis, particularly for household contacts, and then seronegative patients hospitalized for COVID-19. We are currently not using the product in the United States for these indications. They haven't been approved yet, but I believe we will be moving there. And then though data is still early, it does appear that CAS-MD retains efficacy against the Delta variant, which has rapidly become the dominant variant globally and certainly in India. We're still awaiting clinical data on this, however. And I think with that, I will stop sharing right now and end my plenary talk right there.
Thank you very much, Dr. Owen Albin, for an excellent presentation. It was very nice to hear about the antibiotic cocktail, which is colloquially called the antibiotic cocktail, but the monoclonal antibodies. It has been used extensively, I believe, but still, though it's under research. I would like to ask a few questions. In the second,
Dr. Subramaniam also to the.
Yes, Dr. Subramaniam.
Subramaniam, can you switch on your? Oh, there he is. Okay. Yeah. Hi.
Yes,
you
welcome, Dr. Subramaniam.
To some kind of a panel discussion, you can start with the two panelists here.
Yeah.
Dr. Subramaniam has a lot of experience with using this in Chennai. He has earlier shared this in one of the earlier meetings, but I'm sure he has much larger series. Now, if I remember correctly, at that time we had 35 patients or something. So you can ask a question, then probably Dr. Subramaniam can give his experience from.
Yes. So I would like to ask a question. So in the second surge of the disease, we are seeing much more younger patients who are.
Just a couple of minutes to introduce.
Yes. Can I should I introduce?
Yeah, you can.
You can go ahead.
Okay. So I'd like to introduce on the panel, Dr. Subramanian Swaminathan. He is a director of infectious diseases and infectious control from the at the Glen Eagle Global Hospital City, Chennai, as well as in Bangalore. He has completed his DNB and MD from Christian Medical College, Vellore, and ABIM from St. Peter's Drexel University, and AB Infectious Diseases from Wayne State University. He has been involved in the academic training at Christian Medical College in Vellore, and has a number of recipients of several scientific antibodies and several scientific bodies and medical associations. He is the recipient of the Sam GP Moses Gold Medal in Medicine. He has several publications and has delivered several talks at national and international conferences. With this, I welcome Dr. Subramanian Swaminathan.
Ma'am, you can go ahead.
You can go ahead now and ask some questions. There are some
Okay.
questions there, and we can ask additional ones as well.
That's right. So in the second surge, we are seeing a lot more younger people developing a severe disease, although they do not have any risk factors. Do you think this monoclonal antibodies has a role in that as well? Sir, you're muted.
Sorry. If the government of India data is to be taken at face value, they have said that the demographics of the second wave is actually not at all different from what happened in the first wave. All of us feel slightly different from that. We do believe that we had a significant burden of younger people developing severe disease and probably higher mortality as well. But again, I can only say that the government has given data which is slightly to the contrary. But having said that, it still doesn't take away from the fact that comorbidities do play a major role. And even in the young people, we saw mostly problems happening in those with chronic kidney disease, cancer, those with rheumatological conditions, those on immunosuppressive therapy, things like that. So for a young, healthy person, the probability of severe disease was fairly low. The mortality was slightly low. The real concern that we have is there is no single marker to be absolutely certain about who's going to develop severe disease. And again, the other criticism that comes across is that the case definitions are a little too wide over here. In that, you have a huge group of people who become eligible for the therapy. And when you do that, the number needed to treat is going to be quite high. But having said that, the study as such seems to show a significant benefit, whether it's for the preemptive therapy, which is the patients who have infection now and you're preventing disease, or for therapeutic intent, which is based on the recovery trial, the number needed to treat to prevent a meaningful endpoint is fairly low. So it does make sense in investing in that as a treatment option.
Okay, thank you. Dr. Owen, would you like to comment?
No, I would agree with that. I think I think part of the major challenge with COVID still is that we don't have great ways of predicting who will progress to severe disease, and therefore who will most benefit from a therapy that's efficacious at preventing that. We use these kind of surrogate markers, which are comorbidities, but we know that plenty of young people tend to get quite ill, and it can be a major challenge. Our experience here has been that the quote unquote younger patients who run into trouble are those with some form of reactive airway disease and obesity. That has been our experience, or early onset hypertension. And in general, what we have tried to take the approach of is that if a physician has a significant clinical concern about a patient, even if they don't fit into a neat box that we've kind of pre-specified here, we're fairly liberal in giving this medication. Because again, the downside is that if you misphenotype a patient, you're going to end up having to give them medicine to a lot more folks to derive a benefit from it. But the downside is actually fairly low, independent of cost, of course. These are fairly safe medications. They're generally very well tolerated. And in all of the studies to date, we really haven't seen any concerning safety signals whatsoever. So we have a low threshold to give to patients, even if they're young, if they kind of look like the kind of person, for lack of a better word, that clinical judgment would lead you to suspect that they're at higher risk for severe disease down the road.
If I can ask both the panelists, in the list that you said, Dr. Albin, and also in the list of people whom you mentioned in the young, you didn't mention diabetes at all. I was wondering, obesity was mentioned, immunosuppression, cancer, everything else except diabetes was mentioned. Is it that you don't see young people with diabetes who become bad, or is just that you?
Oh, I would say the majority of patients that we have been giving this to do have diabetes.
Okay.
Our diabetes type 1 or type 2 for us is a major criteria for administering this medication here in the United States, certainly.
And your experience, Subramanian?
Yeah. So we've given it about 87, we've given 87 doses as of today. So, I mean, we have one of the largest cohorts in the country as of this point. See, I think the problem is like we are buttonholing a little too tightly. See, pregnant women are also a risk factor. But then again, in the initial, literature, pregnant women was not included in the study. But later on, we know a lot of pregnant women have got it. Another area which I think is concerning is those who have a bad family history tend to have bad outcomes. We've seen crops of families having deaths due to COVID. So that is a kind of situation where I would not worry about risk factors. So if they've lost a family member with COVID, oh, God bless me, I'm going to give them the monoclonal antibody come what may. So I think, a little bit of judgment is to be extended in this decision making. And I think, anybody who we think is at risk should be given the option of taking the drug.
I'd add one more thing there too, which is it's likely that the timing of this is a central determinant of how effective the therapies are. We give these to patients who have been symptomatic for up to 10 days. But I'll tell you, if you have someone who receives the product, and I'm sure that my co-panelists would agree with this, who's getting it at the tail end of that, it's likely that the benefit of that is going to be diminished. And I think one of the challenges we have with the medication currently, at least for us, sir, is that it's very hard to deliver this at the point of care. I think what you'd like to be able to do is diagnose someone with a rapid test and then give them the medication right away. I understand in India, the subcutaneous form of this has been approved for use. We're only using this as an infusion here currently. So we have to identify patients who test positive, coordinate getting them into an infusion center that is like infection control approved for COVID, and then get them the therapy that way. And that takes a lot of time as well.
Although it's approved for subcutaneous use in India, it's not being widely used simply because of reimbursement issues. So what we have done is we have protected as a package, just like oncology gives daycare infusion and things like that. So we do a short admit for about 1 to 1.5 hours. That's all it takes to get all of it done, the monitoring done, and the paperwork to be done out, and the counseling to be done. And we are able to generate a discharge summary so that the reimbursement issue is taken care of. And because cost is an issue, I think this is the only way to do it. If I do it as a subcutaneous injection, then I cannot justify an admission. And so for the most part, 95 to 99% of the use in India currently is intravenous. So much so that most centers are actually doing a single day admission to justify this. I'm one of the few institutions which are doing short admits, so like 1 hour, 1.5 hours kind of admit. We show it as a daycare procedural admit, and that way we are able to justify it. But since this is a new molecule and insurance is still on the fence on this, it's going to take a little bit of time. So subcut is going to take time to take off.
Okay, Alvin, one of the things that you mentioned in one of your slides, you showed the placebo group and the antibody group, and you showed recovery 1.3 weeks and 3-point-something weeks. Can you explain how this weeks concept came when you're giving this? Why would it take 3 weeks to recover from COVID? Yeah, that's the one. Can you unmute?
Sorry about that. I was muted.
Yeah.
So this was in the post-exposure prophylaxis study, and patients who received monoclonal antibody therapy who did progress to develop symptomatic disease had about a week's worth of symptoms versus those with placebo. And again, we think this is just because for those who break through the protection that monoclonal antibody therapy affords, that the illness is markedly milder. And when you have a markedly milder illness, it tends to correlate with viral load, and then it tends to also correlate with persistence of symptoms. I think one thing that's very interesting about this that to my knowledge hasn't been looked at with any monoclonal antibody therapy product is whether these are efficacious at preventing long COVID symptoms in particular. And then in rare patients, but certainly ones that we've seen, some of the downstream complications from COVID, such as incident insulin resistance and a number of other kind of metabolic factors that we know in certain high-risk patients follow COVID. But one could imagine, if you blunt the severity of the index infection, that long COVID sequelae might be reduced as well.
May I ask another question? Yeah. So should there be any biomarkers or any radiological parameters to be considered while defining the people in this high-risk group?
I'm sorry, sir. I don't know if you want to jump in. Okay. Yeah. We are not, I mean, we obviously require test positivity. And as I said before, I think the duration of symptoms is a key determinant of outcome. The median duration of symptoms in some of these major studies was about 4 days worth of symptoms, if it gives you any kind of window into that. But as of right now, no, we are not using any biomarkers to risk stratify patients. I mean, clearly, I think what the data suggests for products like this, and again, this has not been operationalized to a meaningful degree at all here in the United States or to my knowledge elsewhere, but I think serotyping patients likely in the future, particularly in hospitalized patients, is likely going to be a factor in the kind of diagnostic testing pathway or the therapeutic management pathway, because it does appear that seronegative patients are the ones that clearly derive the most benefit from a therapy like this.
I can add 2 points to that. Number one, when we do a test, we need to ask ourselves, is it going to change my risk or is it going to change my benefit? And to my mind, it doesn't change either, because the concept here is that it's not going to increase your harm irrespective of what your baseline is. And 2, in terms of the magnitude of the benefit, the problem is tests done very early in the 3rd day and the 5th day is not very predictive of what's going to happen in the 2nd week. And therefore, you really do not know if you are going to change your target based on that. And lastly, please understand that any roadblock causes a delay in getting to the therapy. And like he pointed out, you want the therapy in as fast as possible. So the less, just PCR and move. And if you can give it as a point of care dosing, that's what he was talking about, which I think is very elegant. Unfortunately, any test that we add on to that is going to make a roadblock and it's going to be unnecessary. As far as the antibody testing is concerned, I would advise a word of caution. Please understand that the antibody test which was done in the recovery trial is a nucleocapsid antibody, and therefore it cannot be any antibody that you do. You'll have to be careful about what antibody you order. It should be consistent with what has been studied in the trials. Currently, there are so many different antibody tests which are available, all forms, shapes, colors, you name it. Therefore, whether that will correlate with these things, we do not know. So please be careful about that and try and make sure that you follow it as far as the guidelines are concerned, if you're looking at it from the therapeutic point, which is the recovery trial data.
Okay. There's one question in the chat box which says that patients receiving monoclonal antibodies, is it compulsory to receive pneumococcal and influenza vaccine later?
Well, if they are candidates for the monoclonal antibody, they may or may not be candidates for the flu and the pneumococcal vaccine. See, the good news is the monoclonal antibody is not an immunomodulator. It's not like steroids, which changes your immune system. Generally speaking, we avoid giving vaccines to people who are already sick. If you're having a fever, your response to a vaccine may not be as robust as it is usually. But to me, I do not want to miss any opportunity to vaccinate. And one of the major drivers is missed opportunities, which to me is concerning. So if you're sure you'll be able to get back to them on follow-up, and if they are candidates for the pneumococcal or the flu vaccine, go ahead and do so when you do so. The caveat is for the COVID vaccination. The problem is if you use the monoclonal antibody, they are automatically excluded from vaccination for COVID for the next 3 months. That is important. So even if you recover from COVID without the monoclonal antibody, you can get the vaccination even a month later. The government says 3 months, but even a month later is no problem. But if you've got the monoclonal antibody, you're out of COVID vaccination for the next 3 months because it kind of hangs around in your system with a very long half-life.
But then you're giving it to only people who have already had the infection, no? So
true, but the monoclonal antibody's half-life is so high that it may inactivate the vaccine. and therefore you may not mount the immunological
delay in the vaccine, your fear is that they'll develop COVID again a second time. They already got it once. So
true. Yeah, absolutely true.
It's
a catch-22 situation. There's no clear good answer here, but take it as you may.
Okay, I think there are no further questions, so we can conclude this session here.
Thank you to Dr. Alvin for joining all the way from US, and to Subramaniam. Nice to meet you again. Oh, by the way, convey my regards to your father.
Certainly will.
He taught me medicine when I was in third year. So that day when you mentioned, you made a casual remark, it suddenly all came back to me. So
yeah, I can imagine. I can imagine. I certainly will. All right.
Thank you, speakers. Thank you, Dr.
Thank you so much for having me. Really appreciate the opportunity.
Thank you very much.
Take care. Thank you, Dr.
Thank you.
So with this, we conclude the scientific session of day 2. We will connect back tomorrow at sharp 9 a.m. for more interesting sessions across both halls, in both the Professor M. Vishwanathan Hall as well as the O.P. Gupta Hall. See you tomorrow at 9 a.m. Thank you. Good night.